Good morning, Mr. Misra. Mr. Misra, good morning.
Good morning. Good morning.
We are ready. Can we start?
Dr. Ashok Kapi sir has not joined yet.
Okay, no problem. Let's wait for him.
Hello, tech team.
Yes, please tell me.
Can we proceed now? I think sir is having any trouble in logging in now.
No problem. We can start.
Okay. Very good morning to everyone. Myself, Dr. Asit Kumar Mishra, on the behalf of Scientific Committee of 19th ISP PG Convention 2021, welcome you to this platform for the second day of the scientific paper presentation. Hope you are all doing well in this COVID era. So, we should begin with our first session of today. First, may I introduce to our chairperson for the session one. Chairperson is Dr. Ashok KP sir. He is professor and head GSL Dental College and Hospital, Rajamundry, Andhra Pradesh. With him is Dr. Manvi Chandra Agarwal, ma'am. She is professor of Institute of Dental Science, Bareilly, Uttar Pradesh. Now, we can begin with the first paper presentation of the day. The presenter is Dr. D. Durga Bhavani.
A warm welcome to everyone. Today I am D. Durga Bhavani and I would like to present a case report regarding the management of ridge defect via GBR with simultaneous implants placement. It's a case report. Coming to the introduction, the successful rehabilitation of the maxillary and anterior segment to the patient's exacting aesthetic demands still remains as a daunting challenge to many dentists. It is due to the pre-existing anatomical defect or due to insufficient bone volume at the site of implant placement. The implant should always be placed according to the prosthetic design and needs, which will in turn increase the aesthetic and functional results. Bone resorption following extraction is one of the major challenges in the implant dentistry, and it makes it difficult for the ideal implant placement. So, prior to the implant placement, in certain cases, both soft and hard tissue augmentation is done before the placement of implants. After extraction of a tooth, the bone will start to heal after 1 week, and the socket gets filled with new bone after 40 days. Unfortunately, this is usually not the case in every situation. In fact, without further treatment, there will be crestal bone resorption. It is common and unavoidable, and it leads to significant ridge dimensional changes. There will be about 1.5 to 2 mm of bone loss in the vertical direction, and there will be a horizontal bone loss of about 40 to 50%. This is a classification of residual ridge defects given by Cyber. This classification includes 3 types of class defects. The class 1 defects include the facial lingual loss of tissue width with normal ridge height. Class 2 defects includes the loss of ridge height with normal ridge width. The class 3 defects involves the combination of loss in both the dimensions. Coming to guided bone regeneration, it is one of the ridge augmentation technique. It is a surgical procedure that uses barrier membrane with or without particulate bone grafts or any other bony substitutes. Osseous regeneration by the guided bone regeneration depends upon the migration of pluripotents or osteogenic cells to the defect area, and also includes the exclusion of the cells that impedes with the bone formation. To ensure the successful guided bone regeneration procedure, there are 4 principles that are need to be met. The first one is the exclusion of the epithelium and connective tissue. Second one is the space maintenance. The third one is the stability of the fibrin clot. And the third one is the wound closure. After the guided bone regeneration procedure, the bone regeneration follows a specific sequence of events. After 24 hours of the graft placement, the graft material or barrier created space is filled with the blood clot, which releases the growth factors and cytokines. These growth factors and cytokines will attract the neutrophils and macrophages. And then the clot is absorbed and it is replaced with the granulation tissue. This granulation tissue is rich in the newly formed blood vessels. Through these blood vessels, the nutrients and mesenchymal stem cells that are capable of osteogenic differentiations are transported and they contribute to the osteoid formation. Once the mineralization of the osteoid takes place, the woven bone is formed and it later serves as a template for the apposition of the lamellar bone. Thus, this transformation of the primary sponge work would eventually constitute both compact and reticular bone with mature bone marrow. When there is an insufficient height or width in the jawbone for the implant placement, the bone graft is placed with the help of guided bone regeneration technique, and the bone graft is replaced by the natural bone. And after the replacement of bone graft with the natural bone, the dental implants are placed, and it results in the successful implant placement. As a part of guided bone regeneration, decortication is done. It is done prior to the bone graft placement. The decortication is the intentional drilling of holes to the cortical bone into the cancellous bone or the removal of cortical bone to expose the cancellous bone. It promotes bleeding, it enhances the healing, it allows the progenitor cells and the blood vessels to reach the bone grafted site more readily. It improves the physical bond between the grafted site bone and the recipient site. Coming to the case report, a 38-year-old female patient has come to our department with the chief complaint of missing teeth in relation to the 1-1 and 1-2 region. After the diagnosis, for this patient, implant placement with guided bone regeneration and usage of the multi-layered platelet-rich fibrin membrane as a barrier membrane was planned, and all these procedures were planned within the single-sitting treatment option. For this patient, upon the elevation of the full-thickness mucoperiosteal flap, a labial plate defect was seen within the 1-1 and 1-2 region. This ridge defect comes under Seibert's class 1 residual ridge defect. After mucoperiosteal flap elevation, thorough debridement is done in relation to the defect area and it is cleaned with saline. Consequently, implants were placed in relation to the 1-1 and 1-2 region. Meanwhile, while the implants are placed, multi-layered platelet-rich fibrin membrane was also prepared. After the implant placement, decortication is done in relation to the 1-1 and 1-2 region and the graft material is placed over the decorticated area. Here, for the graft, osteograft is used as the graft material, and after the graft placement into the defect area, the PRF membrane is placed over the graft material and the wound closure is done with the help of interrupted sutures. After completion of the suture, the patient was given the post-operative instructions, medication were prescribed, and the patient is recalled after 1 week for the suture removal. This is the post-operative radiograph of the patient, which exhibits a good amount of bone volume around the implants. And this is the image showing us the successfully restored implants with the crowns after 6 months. Coming to the conclusion, the clinical examination here revealed an uneventful healing. Radiologically, the osteograft crystals have been completely replaced by the newborn at the end of 6 months. The results of this case study showed that the multi-layered platelet-rich fibrin membranes can be adequately and successfully used over the immediately placed implants and also as a part of the ZBR procedures. Thank you.
Good morning, Ashok sir, and good morning, Manvi ma'am.
Good morning.
Ma'am, you can begin with the question answer session now. Ma'am, a gentle reminder, you have to strictly adhere to the timing of 2 minutes for question answer session, ma'am.
Right. Dr. Durga?
Yes, ma'am. Good morning, ma'am.
Good morning. Just wanted to tell you that always put slide numbers whenever you're giving a presentation.
Okay, ma'am.
Just to point out, right?
Okay,
So,
ma'am.
one question is, what is the fate of clot in this procedure? What happened to the clot?
Here, after completion of the procedure, after placement of suture, the clot gets absorbed, ma'am.
That is what I know. Clot gets resorbed. How actually that happens? What is the mechanism behind it?
After the side, the mediators are released from the graft material and they help in the absorption of the clot, ma'am.
Okay, which bone graft is most suitable one?
Autografts are more suitable, ma'am. And in this case, xenograft is used, ma'am.
Why?
For estimation of
Which
Thank you,
xenograft was used? Which xenograft was used?
osteograft is used here, sir. It is demineralized bone matrix, sir.
Okay. So how much time was given for healing?
After 6 months, restoration is done, sir.
Okay. So how did you check for the bone regeneration?
Using radiographs.
Okay. So how much bone fill was there?
Sir?
How much bone fill was there? No, in the site ridge, in the defect, how much bone fill could you see? Radiographically, you must have measured, right? No, not measured. Can you hear me? Can you hear me? Later. Okay. Okay. You can carry on. We can have the next presenter, please.
Yes, sir. Thank you, Dr. Durga. We can now move on to our next presentation by Dr. Karandip Kaur.
Greetings everyone, I am going to discuss the efficacy of the platelet-rich fibrin membrane in the treatment of the gingival hyperpigmentation. It is basically rejuvenating gingival aesthetic with patient's own blood. Now starting with the introduction, the aesthetic needs of the patients are increasing day by day. Every patient wants a beautiful smile. A beautiful smile indeed enhances the individual self-confidence. Now the harmony of the smile, it is basically determined by the shape, color and position of the teeth along with the gingival tissue. The most frequently pigmented region of the oral cavity is the gingiva. The normal physiological color of gingiva is coral pink or the salmon pink as produced by the tissue vascularity with physiological variation of the melanin pigmentation. Any color variation in the gingiva, it is basically determined by the thickness of the gingival epithelium, blood supply, amount of the keratinization and the number of the pigmented cells present. Gingival pigmentation is presented as a diffuse, deep purplish discoloration or as irregularly shaped brown or light brown or black patches, dry or the strand. This color is basically depend upon the depth of the melanin pigmentation. The distribution of the pigmentation is variable with different ethnic groups worldwide and it's prevalent in all races. It results from melanin granules which are produced by melanoblast. Melanin, which is a non-hemoglobin derived brown pigment, is the most common of the endogenous pigment and is produced by the melanocytes present in the epithelials, basal and suprabasal cell layer. The process of the pigmentation usually consists of the three phases. First is the activation of the melanocyte. This activation is basically by the various factors such as the hormones or the sunlight, which leads to the production of the chemical mediators such as the melanocyte stimulating hormone. Followed by the next phase where the synthesis of the melanin take place in the organelles known as melanosomes. In this, the tyrosinase enzyme, it basically act on amino acid tyrosine, which get further converted into the dopa, which get further converted by the action of the tyrosinase into the dopaquinine, and then they're followed by the expression of the melanin. This expression of the melanin take place when the melanosome, they migrate from the melanocytes to the keratinocytes, so there will be expression of the pigmentation on the skin. Gingival pigmentation can be physiological or pathological. Physiological is also known as ethnic or the racial pigmentation. Pathological due to variety of the reasons. It can be due to any endocrine disease such as Addison disease, due to medication such as the zidovudine or etc. Clinical melanin pigmentation is benign and is not a medical problem, but pigmented gingiva may cause an aesthetic concern, particularly during speech and smile, so patient seeks for treatment. Now, the gingival depigmentation is a periodontal plastic procedure whereby surgical hyperpigmentation is removed or reduced by various techniques. The various gingival depigmentation techniques are the scalpel surgical technique, burr abrasion method, electrosurgery, cryosurgery, lasers, radiosurgery, chemical method, free gingival graft, acellular dermal matrix allograft. One of the first and still popular technique to be employed is the surgical removal of the unwanted pigmentation using the scalpel. The procedure basically involves the surgical removal of the gingival epithelium along with the layer of underlying connective tissue, thereby allowing the denuded connective tissue to heal by secondary intention. The new epithelium that forms is devoid of melanin pigmentation, thereby providing the patient desirable result. Next, the coverage of the exposed connective tissue during the initial post-surgical phase minimizes the likelihood of the post-operative bleeding and facilitates unperturbed healing by preventing the surface trauma. Conventionally, the non-usual dressing have been used. However, they have certain disadvantages. For example, the retention of the plaque or the feeling of the foreignness in the mouth. So, the clinician have tended for the more valuable things such as the PRF. PRF is a second generation platelet concentrate and it was developed in France by Chokran et al. In 2001. It accelerates wound healing by effective neovascularization and promote fast cicatrical tissue remodeling and can be used to shield open wound. Now, the use of platelet concentrate known for its immense therapeutic potential could be a boon for rapid epithelialization on the pigmented gingiva. So, this case report describes the efficacy of the platelet-rich fibrin membrane in the treatment of the gingival deep hyperpigmentation. Case report. A 24-year-old male patient visited the Department of the Periodontics SGRD Amritsar with a chief complaint of dark-colored gums. The history revealed that dark-colored gums were present since birth. No relevant past dental history was reported. Medical history was also non-contributory. Oral examination revealed pigmented gingiva having a DOPI score of 3 from right first premolar to the left second premolar. Dermat-Gupta oral pigmentation index was used to assess the depigmentation. This is a pre-operative picture of the patient. Then the patient was sent for hematological investigation, which include the HB, BT, CT, TLC, DLC, HBV, HCV, HIV, RBS. All the tests were within normal limits. Before the treatment, all the vitals, blood pressure, respiratory pulse state were recorded. All the vitals were also within the normal limits. Then the treatment plan was formulated. Treatment included a scalpel surgery with PRF membrane to perform the depigmentation. The entire procedure was explained to the patient and the written consent was obtained. Now the procedure. Oral prophylaxis was done before the surgery. Local anesthesia was infiltrated in the maxillary anterior region from premolar to premolar. A Ward Parker handle number 15 blade was used to remove the pigmented layer. Hemorrhage during the surgical procedure was controlled by direct pressure applied with the sterile saline soaked gauze. After removing the entire pigmented epithelium, a thinner layer of the connective tissue with the scalpel, the exposed surface was irrigated with saline. This is a picture showing this is the picture immediately after the depigmentation procedure has been performed with the scalpel. Next, the PRF was prepared according to the protocol given by the Chokran, and this PRF was placed over the depigmented epithelium, as shown in this picture. Next, the membrane was stabilized with a 3-knot absorbable surgical suture followed by the placement of the periodontal dressing. The patient was prescribed analgesic and was refrained from brushing for 3 days following the procedure and was instructed to rinse mouth with 0.12% chlorhexidine digluconate mouthwash. Patient was reviewed at the end of the 1 week. This is a clinical picture after the 1 week. The visual analog scale and healing index was assessed and the patient reported no pain. HI was also evaluated according to the Landry et al. And the patient showed good healing. This is the picture after the 1 month. This shows the reepithelialization was complete and healing was found to be satisfactory. This is the pre-post-operative view by the end of the 6th month. Gingiva appears healthy and no further repigmentation was observed. Now, when gingival hyperpigmentation becomes an aesthetic concern, it compels the patient to undergo depigmentation surgery, although it is not a medical condition. The scalpel surgery may cause unpleasant bleeding during and after the procedure and leaves behind an open connective tissue wound to heal by secondary intention. However, the vested advantage of cost-benefit ratio with scalpel use and faster post-operative healing make it a treatment of choice among others. Now, the PRF, which is an activated fibrinogen, a second-generation platelet concentrator, has properties superior to the first-generation platelet concentrator, that is the PRP. PRF has been found to deliver growth factors in high concentration to the surgical site and promote wound healing, maturation, wound sealing, and hemostasis. Platelet concentrates are necessary to cover the exposed lamina propria as healing occurs with secondary intention, which is delayed if the surgical site is left exposed. According to Corso MD et al. 2010, he reported in his study that fibrin network allows for cellular migration, particularly for endothelial cells, necessary for the angiogenesis and vascularization. Now, the advantages which PRF offer here are that it is a simplified and effective technique. It is available through autologous blood sample, minimal blood manipulation. The most important, it circumvents the addition of the external thrombin as polymerization is a completely natural process, thus refraining from any risk of immunological reaction. Now, concluding, scalpel surgical technique with PRF membrane yielded aesthetically acceptable results with minimal discomfort to the patient. Healing was uneventful. The depigmentation procedure thus was successful and the patient was comfortable with the aesthetics achieved. PRF can be considered as a natural fibrin material, favorable to develop a microvascularization and guiding epithelial cells migration to its surface. Thus, its utilization seemed to be of high interest in dermatological and plastic surgical procedure. Thank you.
Okay, Manvi ma'am and Ashok sir, you can start the question and answer session now.
Dr. Karandeep,
Morning, ma'am.
what are pre-melanoma?
Ma'am, these are the organelles which are found in the basal and the suprabasal layer of the epithelium, which are basically responsible for the formation of the melanocyte cells.
Positional?
Melanocytes.
What are melanophores? Melanophores. One more question. Enumerate various methods to assess gingival aesthetics. Just tell me tell me the names of methods by which you can assess gingival aesthetics.
Basically, there are various indices for the pigmentation measurement, such as the melanin index, oral depigmentation index, pigmentation index. These are the non-indexes which are used to measure the pigmentation. Also, we can, for like gingival display, we can have the classification of the smile line. Sorry, ma'am.
Do you have any aesthetics?
I do not recall any.
Ashok, sure. You can ask.
Yeah, yeah. Hello.
Good morning, sir.
Hello.
Good morning, sir.
Yeah. What about repigmentation? Was there any repigmentation after the
Sir,
procedure?
in this particular case, when I recalled the patient after 6 months, there was no sign of repigmentation. However, various studies have said that with the scalper, the rate of pigmentation, the rate of repigmentation is like after 6 months to 1 year, and with laser, it is basically like 1 year to 2 years. But in this particular case, the follow-up was of 6 months, so there was no sign of repigmentation.
Okay. What is the difference between scalpel and laser depigmentation?
Sir, in
In terms
scalpel,
of healing. In terms of healing.
sir, healing is faster with the scalpel as compared to the laser.
Why is it so?
Uh,
Okay. Thank you. So we can have the next presentation. So thank you, Karandeep.
Thank you, Karandeep. We can move on to our next presentation by Dr. Yugandhar Ramesh.
Good morning, everyone. Myself, Dr. Yugandhara Desurkar, will be presenting a paper on NIPSA, Preservation of Papillary Aesthetics PPE, a case series. Periodontal regenerative therapy aims at the recovery of the lost periodontal tissues due to disease. With the introduction of new biomaterials, minimally invasive surgical techniques have been proposed for the reconstructive treatment of deep intrabony defects, and their effectiveness have increased over time with the use of papilla preservation approaches. But the main unwanted outcome of regenerative treatment is gingival margin and papilla recessions. Risk factors associated with soft tissue collapse are reduced keratinized tissue, thin gingival biotype, thin papilla. To minimize these complications, various flap designs have been innovated from time to time. Rodriguez et al. In 2018 innovated a novel approach for the surgical treatment of intrabony defects NIPSA, that is non-incised papilla surgical approach, which is PPE for interdental papilla, causing preservation of papillary aesthetics. NIPSA technique involves a horizontal incision at the base of the defect, followed by coronal reflection of mucoperiostral flap, then debridement using curettes, grafting and barrier membrane placement, and at last suturing. To assess the papillary levels, Cardoropoli et al. In 2004 gave an index called Papilla Presence Index with the scores ranging from 1 to 4. Score 1, when papilla completely present, filling entire interdental embrasure. Score 2, when papilla no longer completely present and lies apical to contact point. In score 3, papilla present more apically and interdental CEJ is visible. In score 4, both interdental and buccal CEJs are visible and patient's aesthetic is dramatically compromised. When there is a buccal recession present, in cases with score 1 and score 2, it can be classified as papilla presence 1 with buccal recession and papilla presence 2 with buccal recession. In this case series, I'll be discussing 3 cases of intrabony defects treated using NIPSA approach. Here is the first case. A 29 years old male reported to the Department of Periodontics with a chief complaint of loosening of tooth in upper front region of jaw since last 6 months. Patient was taken medication for schizophrenia since last 13 years. On examination, there was grade 2 mobile 1-3 and radiographically intrabony defect was present with 1-3. Taking consent from patient's guardian and patient's physician, treatment plan was established as phase 1 therapy, RCT with 1-3, splinting with 1-3, and reconstructive periodontal therapy with 1-3 using NIPSA approach. These are the preoperative images. Under all aseptic conditions, local anesthesia was administered and horizontal incision given on buccal aspect with 1-3 at the base of the defect. Then mucoperiostral flap reflected coronally and the defect debrided using curettes. Then debrided defect was filled with DFDP graft materials and chorion barrier membrane was placed. Due to thickness of tissue, double layer suturing was done. To suture subcutaneous tissue, 6O chromic gut resorbable reverse cutting suture material was used and horizontal mattress suturing was done. And to suture incision line, 5O reverse cutting silk suture material was used and interrupted suturing was done. Periodontal dressing was given. And these are the pre-operative and post-operative 3 months images. Appreciating these images, it can be say that there was no increase in gingival and papillary recession at 3 months follow-up and soft tissue healing was achieved. In second case, a 42 years old female reported to the Department of Periodontics with a pain and gum swelling in overall mouth since 1 month. There was no past medical history associated. On examination, generalized gingival inflammation and multiple periodontal pockets was seen. Grade 2 mobile 4-4 was present. Radiographically, intrabone defect was present with 4-4. And treatment plan was established as phase 1 therapy, splinting with 4-4 and reconstructive periodontal surgery with 4-4 using NIPSA approach. These are preoperative images. Under all aseptic conditions, local anesthesia was administered and horizontal incision was given on buccal aspect with 4-4 at the base of the defect. Then mucoperiosteal flap reflected coronally and defect was debrided using curettes. And then debrided defect was filled with DFDP graft material and chorion barrier membrane was placed. Then incision line was sutured using 6O chromic gut resorbable reverse cutting suture material by horizontal mattress suturing and periodontal dressing was given. This is the photograph at 3 months follow. Comparing pre-operative and post-operative 3-month photograph, it can be appreciated that there was no increase in gingival as well as papillary recession and soft tissue healing was achieved. Then third case, a 36-year-old female reported to the Department of Periodontics with a chief complaint of pain and gum swelling in lower front region of jaw. And there was no past medical history associated. On examination, periodontal pocket was present on distal aspect of 3-2. Radiographically, bone loss was present with 3-2. And treatment plan was established as phase 1 therapy, RCT with 3-2 and reconstructive periodontal surgery with 3-2 using NIPSA approach. These are preoperative images. And under all aseptic conditions, local anesthesia was administered and horizontal incision was given at the base of defect on buccal aspect of 3-2. Mucoperiosteal flap reflected coronally and defect was debrided using curettes. In the debrided defect, DFDP graft material along with the chorion barrier membrane was placed. Then incision line was sutured using 6O chromic gut resorbable reverse cutting suture material by horizontal mattress suturing and periodontal dressing was given. This photograph is at 3 months follow. Comparing pre-operative and post-operative 3 months photograph, it can be appreciated that there was no increase in gingival recession but minimal increase in papillary recession. As a discussion, in present case series, 3 cases of intrabony defects were treated by NIPSA surgical approach. NIPSA is a new surgical approach for the management of soft tissues in periodontal surgery, maintaining papilla and marginal tissues intact. Main advantages of the technique are preserving pre-operative gingival architecture and preserving suprabony soft tissues in lingual aspect and adjacent teeth. The technique provides a dome to protect the periodontal defect with better blood supply to marginal tissue. Suturing is facilitated, optimizing primary intention closure of the wound and avoiding papillary contraction. The dome helps to preserve stability of blood clot. In this case series, all the 3 cases shows optimal soft tissue healing at 3 months follow-up. In all 3 cases, pre-operatively, papilla presence index 2 with recession was present and post-operatively also papilla presence 2 with recession was present. So it can be said that soft tissue preservation was definitely done. But in case 3, there was slight increase in papillary recession. It could be because of reduced keratinized tissue and thin gingival biotype. According to Devans' golden statement, perpetual preservation of what remains is more important than meticulous replacement of what is missing. NIPSA is a promising technique for the treatment of intrabony periodontal defects for the optimal soft tissue preservation can be concluded. Thank you.
So, Akshar and Manvi ma'am, we can start with the question answer session now.
Dr. Yugandhara.
Yes, ma'am. Good morning, ma'am.
Who proposed minimally invasive technique and
Yes, ma'am.
who proposed minimally invasive surgical technique and when? You mentioned in your introduction slide that this
Yes, ma'am.
NIPSA is a part of.
Ma'am, NIPSA technique is proposed by Roderick et al. And it is one modification of papilla preservation technique, and also can be called as a minimally invasive surgical technique.
I'm asking who proposed minimally invasive surgical technique? MIST. Who proposed MIST?
Ma'am, Cortellini et al. Cortellini et al, ma'am.
How to solve the case you have treated? Don't you find it unethical that you did surgery on a session intrabony defects and leaving that as such?
Sorry, ma'am. I'm not able to.
I guess it's not audible.
Yes, ma'am.
Okay, thank you.
Okay, ma'am. Thank you, ma'am.
Dr. Yugandhara,
Yes, sir.
so how was the case after 6 months? So was the
Sir, actually 6-month follow-up is not there. Only 3 months follow-up I have got. Because I have done cases before 3 months only.
okay? Is this your
That's
thesis?
why I haven't. Yes, sir. Actually, it is my thesis cases. These are my thesis cases.
Okay.
So that's why I haven't shown any radiographic changes pre-op and post-op, because of I don't have a follow-up of 6 months. I have
So
only
at least
follow-up of 3 months.
No, at least 3 months radiograph should have been there, right? Because this is basically heart tissue regeneration, right?
Yes, sir. Sir, I have taken a radiograph for one patient, but there was no any heart tissue changes. So I haven't included those radiographs.
So only you have checked only for what do you call it?
Soft tissue preservation.
Soft tissue preservation. That's it.
Yes, sir. Soft
what are
tissue
the other
preservation
parameters?
pre-op.
That's what. What are the other parameters to be looked into?
For regenerative treatment, sir, clinical attachment level gain, pocket probing depth reduction, bone fill, percentage of bone fill pre-operatively and post-operatively.
Okay. So are you using
And
PVCT for bone fill?
no, sir, no CBCT. I'm not using CBCT.
Oh, okay. Thank you.
Thank you, sir. Thank you, ma'am.
Okay.
Dr. Yugandhara, am I audible?
Yes, ma'am. You're audible.
Yeah, I just wanted to ask that you are treating, according to your study, you're treating for the papillary aesthetics, right? You're consulting the
Yes,
papilla.
ma'am. Yes, ma'am. For papillary aesthetics.
So once you're treating, that tooth as a surgical, how can you leave the recession untreated?
Yes, ma'am. Once I get bone fill, after that, we can try for root coverage procedure, because there was bony dehiscence on buccal aspect of the tooth. So after bone fill, we can go for root coverage procedures, ma'am. Simultaneously, we cannot do the root coverage procedure. Yes, ma'am. All the teeth had. Yes, ma'am. All the teeth has some amount of recession. All the 3 teeth. All the 3. In all 3 cases, there was some amount of recession. In first case, there was 5 mm recession. In second case, 3 mm. And in last case, 2 mm of recession. Thank you, ma'am. Thank you so much.
Okay. Thank you, Dr. Yugandhara. Now, before moving on to the next presentation, I may request all the presenters to mute their audio and off their video during the video presentation mode. They can only start their video at the time of question answer session. We can now begin with the next presentation by Dr. Faisal Sultan.
Good morning, respected judges. This is my paper presentation on topic comparative split path evaluation of non-surgical periodontal therapy using active oxygen oral gel and conventional ultrasonic scale, a case report. When we come to the introduction, there are many products that are used for treatment of periodontitis and periimplantitis which are active only for a very short period of time. Both antibiotics and fluoxetine have difficult to penetrate the biofilm due to the molecular size. Oxygen molecules can penetrate deep into the biofilm and kill the anaerobic bacteria. Topical oxygen therapy, which is potentially less toxic for topical oxygen, is also more convenient in that way that it can be done at home. It's less expensive and has fewer complications. So oxygen plays an important role in the process of wound healing. So with all this advanced scientific knowledge, Dr. Peter Wildock and his team has developed a unique formula which contains oxygen, that is the Blue M gel. So Blue M oral gel increases the oxygen saturation in the mouth and speeds up the recovery from the bleeding gums and reduces the pocket around the teeth and implants. It speeds up the wound healing after extraction of teeth, implantation, and chemotherapy with pore-fitting dentures. So when you come to the mechanism action of this oral gel, so Blue M gel mainly contains sodium borate, which is converted into sodium borate and hydrogen peroxide. So in low concentration, hydrogen peroxide has a disinfectant action that occurs with the antibacterial reactive oxygen species during the respiratory burst of neutrophils in normal oral fluids and has a chemotactic effect on the leukocytes. So the concentration of hydrogen peroxide in the Blue M gel is in a range of 1.5 to 3%. So research has shown that the continuous low concentration of hydrogen peroxide will kill the pathogenic bacteria more effectively than one high off concentration. So the active ingredients in the Blue M gel are mainly sodium perborate, which produces oxygen molecule which can penetrate deep into the biofilm and kill the anaerobic bacteria that protects the methyl salicylate, which is an antiseptic, lactoferrin, which is a bone growth accelerator, and there is honey and xylitol, which help in plaque control. So the case report, a 22-year-old male patient had reported to the department with chronic generalized peritonitis. A split mouth non-surgical technique was performed using Blue M gel on one side and conventional ultrasonic scaling on the other side. Clinical parameters like pocket probing depth were recorded at baseline and 1 month. So the objective was to compare and evaluate the pocket probing depth before and after application of Blue M gel as an adjunct to conventional ultrasonic scaling. So this is the preoperative probing depths before the phase 1 was done. So in relation to 1.4, there was a probing depth of 4 millimeters. In 1.6 was 6 millimeters and 4.2 was 6 millimeters. So after the probing depths were taken, phase 1 therapy was done. And after the phase 1 therapy was done, the patient was asked to rinse the mouth properly so that to remove food debris. At the test site, cotton rolls were used to isolate the area, and using a 2 ml syringe, the Blue M gel was applied into the gingival pockets. The patient was asked to sit idle for 5 minutes and then the gel was washed off using saline. Once the gel was washed off, the cotton rolls were replaced again. The Blue M gel was reapplied and the gel was left in its place. The patient was asked not to rinse his mouth, nor eat or drink for the next half an hour. Also, the patient was recalled every week for a month for the application of the gel. So this is a slide which shows the preoperative probing depths and the postoperative probing depths after 1 month. So you can see the preoperative probing depths was which has from 4 millimeters has reduced to 3 millimeters, and in relation to 1.6 it has reduced from 6 to 4 millimeters, and in relation to 4.2 it has reduced from 6 to 4 millimeters. So the results and discussion are there was a significant reduction in the pocket probing depth and gingival inflammation was seen on the test side as compared to the control side, and also there was slight reduction of probing depth seen on the control side. So it has been suggested that oxygen delivering gel commercially available as Blue M gel is used in various fields of dentistry like implantology, periodontology, etc. But there are few clinical trials comparing the efficacy of topical oxygen therapy and conventional topical drug therapy. Most of the studies are mainly done on animals, and very limited studies have been done on human beings. It has been consistently implied that sufficient oxygen supply to tissues is critical in the process of healing and the avoidance of wound infection. Also, in previous studies, where the patients with acute necrotizing ulcerative peritonitis were treated with antibiotic therapy alone, and also antibiotic therapy with adjunct oxygen therapy, it was found out that in groups with adjunct oxygen therapy, all the patients showed reduction in microorganisms, resulting in a more rapid improvement in the clinical parameters with less periodontal destruction. So I can conclude my presentation by saying that the use of active oxygen therapy containing agents help in reducing the pocket microbial count and also reduce the pocket probing depths. Emphasis is on the fact that with thorough scaling and root planing, along with an adjuvant and topical oxygen therapy, aids in reducing the periodontal pockets, but further research has to be done to assess the effect of oxygen delivering agents in the future. These are my references. Thank you.
Ashok sir and Manvi ma'am, you can start.
This is just one case, right? Dr. Faisal?
Yes, sir. Yes, sir. Good morning, sir.
Good morning. So this is like just a single case
Single
that you have
case.
done.
Yes, sir.
Then just based on that, how can you say that this is a good material or good technique?
So because there are research, like multiple research has been done in which they have tried multiple.
No, in your study, how much was the reduction? You've not mentioned anything about that.
Sir, it has reduced from there. So there was a pocket reduction from 6 millimeters.
How much?
From 6 to 4.
Okay. What about the contralateral side?
So in the ultrasonic scaling side, there was only minimal reduction.
How much? How much?
It was only 1 millimeter. From 6 to it has reduced to 5.
See, that is just saying 1 millimeter reduction. Here it is 4 millimeters. Here it is 5 millimeters. It doesn't make sense.
Yes, sir.
Okay. So unless there is a substantial reduction, and with one case, you cannot conclude that this is a good material or good technique unless you have a good number of cases. Unless around 20-30 cases have been done and you have shown results in all the cases.
Yes,
this
sir.
cannot be a conclusive study.
Yes, sir. Yes.
Okay. Who has proposed this technique?
So this technique was given by, initially it was oxygen therapy was used by Fritz Kramer in 1985 in dentistry. And this gel was introduced by Peter Bilbog, which used this Blue M gel, which contains sodium perborate and hydrogen peroxide.
Okay. When was it used?
Sorry, sir?
When was it used?
So when
Blue gel.
Blue M gel, it was used
first. Who was the pioneer?
So I'm not sure about when it was first used, this Blue M gel.
Is this your thesis topic?
No, sir, it's not my thesis topic.
Okay. Ma'am, you can have your questions.
No, sir, thank you. Same doubt. I agree with you, sir. Only a single case and he's talking about like a study. It's not a complete thing. Dr. Faisal?
Yes, ma'am.
Not a study, just a single case. And that too, you are not emphasizing on the contralateral side and nothing you mentioned talking about intense. No, it's not a study actually, just a single case and you're presenting.
Yes, ma'am.
Okay. Try to do it properly next time. Thank you.
Okay, thank you, Dr. Faisal. And now we can move on to our next presentation by Dr. Niti Deborah.
The topic of presentation is peripheral odontogenic fibromyxoma in relation to the retromolar region in the mandible, a rare case report. Gallen was the first to use the term epulis for gingival tumors to describe any abnormal localized overgrowth in the gingiva. The commonly observed presentations of gingival epulis are pyogenic granulomas, focal fibrous hyperplasias, peripheral ossifying fibromas, peripheral giant cell granulomas, peripheral odontogenic fibromas. Thoma and Goldman in 1947 were the first to describe a certain lesion known as the myxoma of the jaws. Markov et al. Was the first to describe fibromyxoma related to the jaws. Both these lesions fall under the category of gingival epulis. These lesions arise due to the proliferation of primordial mesenchymal cells, resulting in an amorphous mucoid-rich intercellular matrix. The World Health Organization has been using these terms synonymously, both myxoma and fibromyxoma. Yet there are some reports which give the intricate differences between these two lesions, which is the presence of a higher amount of collagen fibers in fibromyxoma observed by histological examination. The lack of a clear distinction between the two has adversely affected the documentation on fibromyxoma lesions. Odontogenic fibromyxoma is a rare, benign, slow-growing neoplastic lesion which accounts for less than 3 to 8% of all odontogenic cysts and tumors. It occurs commonly between the ages of 20 to 30 years. It is rarely seen in children and adults. above the age of 50 years, it has a female predilection. It originates from the dental follicle, dental papilla, and periodontal ligament. It is a painless lesion, but it could be symptomatic sometimes. It may interfere with occlusion and may be associated with mobile or impacted teeth. The current report is a clear case of peripheral odontogenic fibromyxoma, and to our knowledge, only a handful of cases are present in the literature. Therefore, documentation of such a case was deemed necessary to add to the currently available evidence. Coming to the case report, a 53-year-old male patient reported to the department with the chief complaint of growth of gum tissue in the lower right side of the jaw for the past 6 months or so. No history of any associated pain or discomfort was given, except for interference during mastication. The lesion was said to have gradually increased in size. There was no conclusive history of trauma, although he vaguely recollects the possibility of trauma while brushing his teeth with neem stick. The patient was systemically healthy. The lesion on examination was found in the lower right quadrant, distal to 4/8 in the retromolar region. It measured approximately 2.2 centimeters into 2 centimeters. It was sessile, solitary, irregularly shaped with a rough corrugated fibrous surface. There was no associated bleeding or exudation. The other observations were palpable right submandibular lymph node and tenderness on palpation. The clicking sound of temporomandibular joint was noted. The clinical signs of inflammation of the gingiva were positive. The probing pocket depth and attachment level were greater than 5 millimeters in the posterior teeth, and the attrition was generalized. This is the preoperative photograph of the lesion. The patient was advised to avoid using neem stick in the future and to obtain OPG, and was subjected to complete hemogram analysis. The hemogram reports revealed normal values for the parameters assessed, and there was also no bony involvement observed around the lesion in the radiographic analysis. This indicated a soft tissue lesion, which was local and non-metastatic in nature. This is the OPG of the patient. The provisional diagnosis made was chronic generalized periodontitis with gingival epilis in relation to the right retromolar region. The differential diagnoses include peripheral giant cell tumor, peripheral ossifying fibroma, cryogenic granuloma, traumatic or irritational fibroma. A thorough scaling and root planing was done. Following this, the patient was prescribed antibiotics pre-surgically. Following the resolution of soft tissue inflammation, our immediate aim was to surgically excise the lesion. After 1 week, the lesion was excised. The lesion was held taut using a suture material and was surgically excised from the base. The remnants were removed using electrocautery, and bleeding was arrested using the same. The surgical site was also curated. The lesion measured approximately 2.5 centimeters into 2.3 centimeters. The biopsy tissue was sent for histopathological examination. The patient was prescribed analgesics for 3 days. The patient was reviewed after 1 week. Healing was uneventful and satisfactory. Again, he was reviewed after 8 weeks. The healing was good with no complications or recurrences. The patient is still under follow-up, and the subsequent periodontal management is being planned and executed effectively. The histopathological report revealed hyperplastic parakeratinoid stratified squamous epithelium and a highly cellular fibrous connective tissue. The connective tissue had proliferating spindle cells with plump to spindle nuclei and indistinct cytoplasm. Numerous vascular channels and perivascular inflammatory cell infiltration was observed throughout the lesion. In the subepithelial region, the connective tissue was more myxomatous with minimal inflammatory cells. This is the histopathological picture. This is the epithelium and this is the connective tissue. In this picture, we can see the myxoid and the fibrous component in the connective tissue. The patient was initially anxious due to the size of the lesion. The lesion was bigger than the usual hyperplastic gingival growths and could have been triggered by trauma from brushing with a neem stick. The histopathology report revealed a diagnosis of peripheral odontogenic fibromyxoma, a benign neoplastic lesion, and therefore surgical excision was deemed sufficient. The patient was also relieved and satisfied. Odontogenic fibromyxoma commonly affects the mandible more than the maxilla, with a predilection to the posterior region. It is usually painless and locally aggressive in nature and may be associated with swelling. It is usually found in the tooth-bearing regions, particularly premolar and molar areas. Other associated uncommon features are pain, paresthesia, hyperesthesia, anesthesia, root resorption, and displacement of the teeth. A rare occurrence of this lesion may be found in the condyle and the gingiva. The lesion originates from the ectomesenchymal tissue, particularly the cell rests of serae, which are remnants of the dental lamina, which gives rise to dental follicle, dental papilla, and undifferentiated periodontal ligament cells. Al-Azami et al. Reported the commonly stated histopathological features for fibromyxoma, and our lesion also exhibited similar features. The presence of stellate or spindle-shaped cells in a myxoid connective tissue stroma with an abundance of dense collagen fibers and islands of odontogenic epithelium, along with numerous intertwining blood vessels. The presence of dense collagen fibers differentiates odontogenic fibromyxoma from odontogenic myxoma. The lesions are managed conservatively if smaller by surgical excision, curettage, and cauterization. Larger lesions are managed by more extensive resection. The recurrence rate is 25%, which is due to incomplete excision, which occurs within 2 to 3 years, either promptly or delayed. This case was a diagnostic dilemma for us due to its rare occurrence in the non-tooth-bearing region in the mandible. Histopathological examination was instrumental in accurate diagnosis of the condition, which enabled precise management to avoid complications or recurrences. Appropriate management of any long-standing lesion prevents its spread and conversion to malignancy. Thank you.
Dr. Manvi ma'am and Dr. Ashok sir, you can start with the question and answer session.
What is the etiology of this condition?
For fibromyxoma, there's no particular etiology, but generally for these types of lesions, the etiology, the trigger factor could be trauma or some form of irritation, and maybe some viral infection.
Okay, the pathogenesis?
It originates from the cell rest of serae. So when it is triggered, these cells tend to multiply, or there is a hypoplastic reaction. So when that happens, there is a formation of a tumor-like growth.
So was there any specific feature which prompted you to take the histological diagnosis?
Actually, we since it was bigger than a normal hyperplastic reaction, we were a little concerned that it might be some neoplastic lesion. So to rule out neoplasia, we decided to biopsy the tissue and send it for histopathological examination.
What was your differential diagnosis?
Peripheral giant cell granuloma, peripheral ossifying fibroma, pyogenic granuloma, and traumatic fibroma.
So how do you differentiate this from peripheral ossifying fibroma?
In the clinically there won't be much of a difference, but histopathologically there will be bone tissue that is found if it's an ossifying fibroma. In giant cell granuloma, there will be giant cells that are present.
Okay. Okay, thank you. Ma'am, you can have your questions.
Neeti, how do these kinds of lesions start with?
Ma'am?
Am I audible?
Yes, ma'am. This time it cut a little, ma'am.
How do these kind of lesions start with?
How do they start with? Yeah, so there is no particular etiology for this lesion, but there could be trigger factors. So that trigger factor for this patient, we think it is trauma due to brushing with a neem stick, but he only vaguely remembers that. So it's usually irritation or trauma or some viral infection. In this case, we think it's trauma due to neem stick injury.
What viral infections?
HPV, those kind of viral infections. Just generally, it says that certain viral infections give rise to gingival epulis.
Thank
you. Okay. Thank you, Dr. Neeti.
Thank you, sir.
Now we can move on to our last presentation of the session. Presenter is Dr. Sheetal Barkhade.
Hello everyone, I am presenting a case series of use of diode lasers for lingual phenectomy, a novel approach. Moving toward the introduction part, now what is frenum? Frenum is a membranous fold which joins two parts and restricts the individual movement of each. Now, what is partial ankylosing? Partial ankylosing is a congenital shortness of lingual frenum and frenulum. Here are some pictures which shows the short lingual frenulum. Now, how does it diagnose? It is diagnosed on the basis of free tongue. Now, what is free tongue? Free tongue is a length from the insertion of lingual frenulum into the base of the tongue to the tip of the tongue. This is free tongue. Now, classification of ankyloglossia given by Kotlow in 1999, clinically acceptable, which is normal. Class 1, mild ankyloglossia. Class 2, moderate ankyloglossia. Class 3, severe ankyloglossia. Class 4, complete ankyloglossia. Now, clinically acceptable, which is normal, is greater than 16 or 16 millimeter of free tongue. Class 1 mild ankyloglossia, here free tongue is 12 to 16 millimeter. Class 2 is a moderate ankyloglossia, here free tongue is 8 to 11 millimeter. Class 3 severe ankyloglossia, here free tongue is 3 to 7 millimeter. And class 4, which is complete ankyloglossia, here free tongue is less than 3 millimeter, which is measured with the help of periodontal probe. Now there are some problems which are associated with the ankyloglossia. First of all is midline diastema. Second, oral motor dysfunction. Third is the gingival recession. Fourth is anterior open bite. Fifth is speech difficulties. Now there are some techniques for lingual phenectomy. First is surgical blade. Second is bipolar dithermy. Third is laser. Outcome of technique include with surgical blade, there will be suturing, numbness, and weakening effect. With bipolar dithermy, there will be burning flesh smell and taste, low tactile sensitivity, and high heat production. Now, what are the advantages of laser? Better visualization, tissue surface sterilization, decreased swelling, edema, and scarring, decreased pain response, which lead to increased patient acceptance. Now, aims of the case series is the aim of the present case series was to evaluate the effectiveness of diode laser in a treatment of ankyloglossia. Now, materials and methods. The total of 10 patients with mean age of 20.5 years were selected from outpatient department of periodontics. Now the inclusion criteria, 4 patients of class 3 and 6 patients of class 2 were included. Now the exclusion criteria, patient with diabetes, autoimmune disease and smoking were excluded. Periodontal surgery in selected area were excluded. Clinical parameters are clinical measurement recorded at the baseline and 3 months post-operatively where plaque index, papillary bleeding index, and protrusion of tongue. Let's move toward the surgical procedure. Surgical procedure, an initiated tip of 300 micrometer was used at 2.75 watt pulse interval at 1.0 ms. Pulse length was 1.0 ms with an average power of 1.37 watt in pulsated mode were used. This is pre-operative picture. Tip was moved in a brushing stroke motion. The attachment of frenum to alveolar ridge was also excised. Here is intraoperative picture, which shows the detachment of lingual frenum with the alveolar ridge. This is post-operative picture after 3 months. Here is pre-operative photograph and here is post-operative photograph. Post-operative exercise were advised to the patient was stretching tongue toward the nose and then toward the chin. Then making top lip fat without opening the mouth. Then making lump on one side of cheek without opening mouth. Then fourth exercise was poking tongue outside the mouth as far as possible. Now the results were plaque index and papillary bleeding index at the baseline and 3 months were calculated. There was significant difference between the plaque index and papillary bleeding index from the baseline to the post-operatively 3 months. Protrusion of tongue at the baseline and 3 months post-operatively, there is significant protrusion of tongue was calculated. Now moving toward the discussion part, 980 nanometer wavelength for maximum absorption of hemoglobin and oxyhemoglobin were used. TIP was initiated for hot tip effect, focuses large amount of energy. Pulsated mode were used to prevent rapid rise in temperature of target tissue and preventing collateral damage. Absence of post-operative swelling and hemostasis for increased platelet activation by laser and lymphatic sealing. There were no need to suture because of complete hemostasis were obtained. Patients were advised to undergo speech therapy. Now moving towards the conclusion, the case series concluded, diode laser definitely has an advantages over scalpel. Second was, practitioner should consider laser in a soft tissue surgical procedure. Third was, as the end of 3-month follow-up, there was improvement in the tongue movement, swallowing the food and pronouncing words. Thank you very much.
Ashok sir and Manvi ma'am, you can share the paper.
So Dr. Sheetal.
Yes, sir. Good morning.
Good morning. So one thing I wanted to know, in your exclusion criteria, you put autoimmune diseases. Why?
Yes, sir.
Why autoimmune diseases were excluded? Which autoimmune disease are you thinking about? What has it got to do with ankylosing? Okay, one more question is, in your comparison, you used plaque index. So what is the role of plaque index in ankylosing? Plaque index and bleeding index. Why these were taken in a case?
Because of ankylosing.
Yeah.
Because of ankylosing, there is diminished ability to the brushing. So there is accumulation of the plaque, and so we calculated plaque index and papillary bleeding index.
What were the objectives of your study? To measure plaque index?
No.
Then there should have been something else to measure the effectiveness of your surgery. So your criteria, this thing, I did not find it proper. Because obviously, like once the free movement of tongue is there, probably there will be other aspects. Probably the speech would improve, the ability, like patient can feel like probably better comfort, probably verbal index scale or something verbal rating scale would have been better rather than plaque index and bleeding index. And how does, like, tell me about bleeding index, why bleeding index was used? What has it got to do with your study? See, the parameter has to satisfy what you are trying to measure. You just cannot put random stats there or random indices there. The indices are meant to measure particular thing. Okay, finally, what is your conclusion?
Yes, sir.
What is your conclusion? After conducting this study, what is your conclusion?
Diode lasers has better advantages over the scalpel technique.
So, scalpel, have you done scalpel? In this
No, sir.
in this case series, have you compared with Calpul?
No.
Then how can you say it is better than Calpul? Because since you're not compared, and you cannot just randomly quote a statement. Okay. Okay, ma'am, you can have your questions. You can start with your questions.
Dr. Sheetal, what are the common complications that are encountered while treating in gynecolostia?
Yes.
Am I audible?
Yes, ma'am.
Audible?
No, ma'am.
Am I audible now?
Yes, ma'am.
Acha, I was asking what are the commonly encountered complications while treating gynecolostia?
Complications.
Yeah.
Speech. There will be speech problems, difficulty
No,
in
after
feeding.
treatment or in treatment, while treating or after treatment, what can be the complications that might occur? No problems. What is that burn smell, that burn tissue smell while you are doing laser known as? The tissue that burns, no, smells bad. You told in your slide. What is that smell known as?
Fishy smell.
Sorry?
Fleshy smell.
Is there any term for that? Okay, tell me, evidence-based, how much is the incidence for recurrence? Is there any incidence for recurrence of ankyloglossia? If it is there, how much?
10%.
Evidence. Quote the author from where you're talking, giving me this statement. Thank you.
Okay. Thank you, Dr. Sheetal. With this, we end our first session here. I may thank Dr. Ashok KP sir and Dr. Manvi Chandra Agarwal ma'am for taking out their valuable time and being a part of this first ever virtual PG convention 2021. As a gentle reminder to our chairperson to send the evaluation sheet as soon as possible to the mentioned email site and the WhatsApp number also. Thank you, sir, and thank you, ma'am.
Thank you, Dr. Thank you.
Thank you.
Thank you, ma'am. Thank you, sir.
Yeah, I'll do that.
Yes, sir.
Okay, thank you.
Now we move on to our second session. The chairperson may introduce the chairperson of the session 2. Is Dr. Y.V. Shashikant, sir. He is professor and head, Anil Neerakunda Institute of Dental Science, Visakhapatnam. Along with him is Dr. Sachin Sivnaikar. He is professor of Maratha Mandal's NGH Institute of Dental Science, RGHS, Bangalore. Welcome you, sir.
Good afternoon.
Good
morning.
Good morning, sir. Good morning, sir. Sir, a reminder, sir, you have to stick to the you have strictly adhered to the time schedule of 2 minutes of question answer session. The backend team will provide a timer on the screen at the time of question answer session.
Sure.
A request to all the participants to mute their audio and off their video at the time of presentation. Also to the chairperson, sir, also to mute their audio and the video at the time of presentation. Only at the question answer time you can unmute it. Tech team, we can begin with the first presentation. First presenter is Dr. Aditi Agarwal.
Good morning to all. Today's topic for my paper presentation is comparative result of frenectomy by different surgical technique, a case series. Then coming to the introduction, an aesthetic smile is a prime concern of people nowadays. So smile designing get more focused to achieve this. So patient with midline diastema visit dentist to demand its closure to achieve a pleasing smile. Then maxillary labial frenum is capable of creating a diastema and recession which affects the aesthetic. So in addition to that, high frenum also also hinders the oral hygiene maintenance. So abnormal frenal attachment is very common problem in general population. Then coming to the classification of abnormal frenal attachment given by Plasek et al. In 1974. It can be of 4 types: mucosal, gingival, papillary, and papilla penetrating. In mucosal, the frenal fibers are attached up to the mucogingival junction. Then gingival, the fibers are inserted within the attached gingiva. And third, papillary, the fibers extending into the interdental papilla. And fourth, papilla penetrating, the frenal fiber crosses the alveolar processes and extend up to the palatine papilla. Then coming to the problems of the abnormal frenal attachment. A frenum becomes a problem, which is attachment. It is close to the marginal gingiva. A tension on the frenum may pull the gingival margin away from the tooth surface. A condition may be conducive to plaque accumulation and inhibit the proper tooth brushing. Then coming to the abnormal frenum has been found to be associated with the following problems: malalignment of teeth, difficulty in brushing, recession, loss of papilla, persistent of midline diastema, compromised denture fit or retention. Then coming to the diagnosis, there are 2 types of test for frenal attachment: tension test and Blanche test. The tension test is used for identification of high frenal attachment. In upper anterior region, the lip is retracted and the upper lip is pulled outward, forward and upward, and lower lip is pulled outward, forward and downward. And after that, applying a tension over it to see the movement of the papillary tip, and blanching produces due to the ischemia of this region. And in Miller in 1985 stated that the frenum characterized as pathogenic when it is unusually wide or there is no apparent zone of attached gingiva along with the midline or interdental papilla, which shifts when the frenum is extended. Then coming to the treatment, there are the 2 types of treatment for abnormal frenal attachment: frenotomy and frenectomy. Frenotomy means incision of frenum and relocating its attachment apically. Frenectomy means complete removal of frenum, including its attachment to the underlying bone. Then coming to the techniques of frenectomy, I have done with the 5 types of frenectomy techniques: scalpel, electrocautery, soft tissue diet laser, Z-plasty, and paralleling technique. But other techniques are also there: viviplasty and Miller's technique. Then aim of my case presentation is or case series is, the present case series was attempted to evaluate the differences in post-operative pain level with a visual analog scale at 24 hours and 7-day post-frenectomy using a different technique. These are I have done with a 5 case report with as earlier said, the 5 techniques. Then coming to the case report 1, 25-year-old female patient with a chief complaint of spacing between her upper anterior teeth with midline diastema present in upper anterior region and with a papillary penetrating type of frenum, and it was decided to treat this patient with conventional frenectomy technique with a scalpel after taking her consent. This is a surgical procedure of conventional technique done by scalpel. Then coming to the case report, 24-year male patient is the chief complaint of poor aesthetic due to malalignment of teeth and midline diastema present with a procline incisor in upper anterior region and papillary penetrating type of frenum seen, and it was decided to treat this patient with electrocautery surgery technique after taking consent. Then this is a surgical procedure for electrocautery surgical technique. Then coming to the case report 3, 24-year male patient with a chief complaint of spacing between his upper anterior teeth, midline diastema present in upper anterior region with papillary type of frenum, and it was decided to treat this patient with soft tissue diet laser frenectomy. After taking his consent. This is the surgical procedure for soft tissue diet laser. And this is the also the surgical procedure of tongue tie. It was done by this laser, but patient did not come for the follow-up. Then coming to the case report 4, 26-year male patient with the chief complaint of irregular teeth and spacing between his upper anterior teeth with midline diastema present with anterior procline upper anteriors with a papillary penetrating type hypertrophic labial frenum, and it was decided to treat this patient with Z-plasty technique with scalpel. This is the surgical procedure of Z-plasty. Then coming to the case report 5, 24-year female patient spacing between her upper anterior teeth with midline diastema present in upper anterior region with papillary penetrating type and it was decided to treat this patient with frenectomy using a paralleling technique. This is the surgical procedure of paralleling technique. Then coming to the result indicated that the patient treated with the diode laser had relatively less post-operative pain. That is a visual analog scale score at 24 hours and 7-day post-frenectomy as compared to the patient treated with the other frenectomy technique. And the table shows that comparison of VAS score of post-operative pain at 24 hours and 7-day post-frenectomy using a different techniques. In that, the laser surgery had significantly less post-operative pain, followed by the paralleling technique, conventional technique, Z-plasty technique, and electrocautery. And after 7-day post-frenectomy, the patient had experienced no pain in all the surgical procedure. Then coming to the discussion, in the era of periodontal plastic surgery, a more conservative and precise technique being adopted to create a more functional and aesthetic result. So the apparent frenum being a most etiological factor for the persistence of midline diastema, focus on the frenum and has it becomes an essential. So apparent frenum can be treated by two procedures, frenectomy or frenotomy. So the soft tissue diode laser is another viable alternative to the scalpel in the soft tissue surgery. So Desiet et al. In 2009 stated that diode laser is considered as an excellent soft tissue laser and it does not interact with dental hard tissue. So in present case series studied that the subject treated with soft tissue diode laser had significantly less post-operative pain at 24 hours as compared to scalpel surgery, electrocautery, Z-plasty technique, and paralleling technique. So Hightech et al. 2006 and Butucci Babu et al. 2014 stated that soft tissue laser treatment used for frenectomy operation provides better patient perception in terms of post-operative pain and function that was obtained by the scalpel technique. So it was concluded that the soft tissue diode laser frenectomy can be considered as the most comfortable surgical procedure with comparatively less post-operative pain. These are the references. Thank you.
I may invite Dr. Sachikant sir and Dr. Sachin sir to chair the session.
Good morning. Good morning. Aditi, can you hear me? Aditi, can you hear me, please? Hello. Aditi?
Good morning, sir.
Yeah.
Yes, sir. Yes. Good morning, sir.
Yeah.
Yes, sir.
Good morning.
Hello.
Regarding
Hello.
your presentation, you have presented the various techniques which are used for frenectomy, the labial frenectomy as well as the lingual frenectomy. That's what you have done. So,
yes.
Yeah, for a diastema closure, how do you think or when do you do your frenectomy in relation to orthodontic treatment and why?
Yes, sir.
A young patient who has come to you with midline diastema being caused by a high labial frenum, you have planned to do frenectomy. Now, how would you plan your frenectomy in relation to orthodontic treatment? Now, will you do it before your orthodontic treatment or after? And if so, why?
Sir, after orthodontic treatment.
Why?
Because the midline diastema will be closer, and after that we will perform a frenectomy procedure.
No, but if that is the case, then the frenum, if it is extending to the incisor papilla, it will be a hindrance for the diastema closure by the orthodontist, right?
Yes, sir.
Then?
Sir, if frenum is now crosses the interdental papilla, then it can be done before the orthodontic treatment.
Okay, so you are taking both stands.
Yeah.
All right. Okay.
Sir, because in many studies, some author says that it can be done after the orthodontic removal of appliances before 6 weeks, and in some studies stated that it can be done if interdental papilla alveolar crosses this papilla, then it can be done before ortho treatment.
Did you place a pack after doing a labial frenectomy?
Yeah, sir.
Did you place a pack after doing a labial frenectomy?
Yeah, sir.
Where did you place the pack?
In that half of the tooth and half of the gingiva portion.
So it is not extending to the base of the sulcus?
No, sir.
Then what kind of healing do you expect after labial frenectomy? Is it primary intention or secondary intention?
Sir, it takes primary.
No, that only happens on the lip. What about the ridge?
Okay.
Doctor, please go ahead. I think I'm done. Please.
And hello.
Yes.
Hello. Yes.
Regarding the laser technique,
Yes.
okay, in which technique the healing is better? The surgical technique, the electrocautery, or the laser?
Sir, laser.
Why?
Because the patient has have less pain. It is a painless treatment.
How pain is associated with the healing? Healing is better in which technique?
Sir, soft tissue diode laser.
That's what. Why?
Sir, because in others technique, for example, in electrocautery, there is a mild bleeding, and and after that, in a scalpel technique also patient feel bleeding and discomfort.
I think you need to read a bit on healing. Okay, what was the settings used for diode laser in this case?
Sir, in contact mode.
No,
How
sir
many
is
watts?
asking you the settings. Wattage.
Sir, 10 watt.
How much?
Sir, 10.
3. Sorry. No, I didn't
10?
understand.
I didn't get you actually.
Hello.
Yeah, I
Sir,
didn't
at
get you.
918 and hello.
Yeah, go ahead.
Sir, 2 watt.
2 watt. And what was the wavelength?
Sir, 980 nanometer.
Okay.
We already extended the time frame, sir.
Okay. Yeah. Thank you.
Thank you.
Yes, sir. Thank you, Aditi. We can now move on. We can now move on to the next presentation by Dr. Tulika Rani.
Good morning to one and all present here. Hope everyone is safe and fine. Myself, Dr. Tulika, third year postgraduate student from the Department of Periodontology at Career Postgraduate Institute of Dental Sciences and Hospital. Today I am here to present a paper on multidisciplinary approach for the treatment of pregnancy-induced oral pyogenic granuloma. Starting with the introduction, oral pyogenic granuloma is a non-neoplastic mass of excess granulation tissue that occurs in response to stimuli such as hormonal factors, traumatic injury, or the local irritant. It is principally found on the gingiva and arises predominantly in females in the second decade of life. The clinical presentation includes exophytic, lobulated, or the smooth surface lesion with a red to purplish color and a soft, spongy texture. Almost 5% lesion arises during the pregnancy. The pyogenic granuloma that arises during pregnancy are referred as pregnancy tumor. It is most commonly appeared after first trimester, grows rapidly, and typically regresses after delivery. This paper presents 4 cases of pregnancy-induced pyogenic granuloma in which different approaches were used for the excision of lesion. Starting with the case report, in case 1, a 25-year-old female patient reported at the Department of Periodontology with the chief complaint of slowly increasing size of gum since 3rd month of pregnancy, and after delivery it was still present. The medical history was non-contributory, and on intraoral examination, a large gingival mass was present in respective 4-2 and 4-3. The investigations were carried out for all the cases, that is intraoral periapical radiograph and the routine blood examination. The provisional diagnosis on the basis of history and the clinical presentation of patient was made pregnancy-induced gingival overgrowth. The treatment was done. The phase 1 therapy was completed and oral hygiene instructions were given to the patient. The patient was advised to use 0.2% of fluorexidine rinse twice daily for 2 weeks. And excision of growth was done by conventional method, and maintenance phase therapy was continued. The histopathological examination confirms the diagnosis field pyogenic granuloma. This is the clinical presentation of the lesion, the facial view, the right tetra view. The intraoral periapical radiograph shows there is no any kind of bone loss in and around the lesion. The surgical procedure, as shown in the figure, the conservative method was used and the lesion excision was done. The histopathological examination presented non-lobular capillary hemangioma, and 1 month post-operative image shows there is complete healing of the lesion area with no recurrence. Coming to the second case, a 32-year-old female patient in her first trimester reported with the chief complaint of slowly increasing size of gum. On intraoral examination, the localized pedunculated, firm and non-compressible, non-pulsatile growth was present. The histopathological examination was confirmed the presence of pyogenic granuloma. This is the clinical presentation in which we can see the facial view, the buccal view. The IOPR shows the horizontal bone loss in the region of lesion. Then the excision of lesion was done by the reverse bevel incision, and then the area was curated. The histopathological image showed presence of lobular capillary hemangioma, and 1 month post-operative image shows there is complete healing of the lesion site with no recurrence. Coming to the case number 3, it is the case report of 31-year-old female patient. The histopathological examination of the gingival growth suggests presence of pyogenic granuloma. This is the surgical procedure in which we can see in the facial view, the growth was present with respect to 4.6, 4.7 and 4.8. The IOPR suggests there is no any kind of bone loss. The excision of lesion was done by the modified excision technique in which 2 mm of the healthy tissue was also removed surrounding the lesion. The histopathological image presented the presence of lobular capillary hemangioma. Coming to the case number 4, a 24-year-old female patient in her first trimester of pregnancy complains of swelling on the left maxillary front teeth region since 2 to 3 weeks. The histopathological examination of the lesion was confirmed the presence of pyogenic granuloma. This is the clinical presentation of the lesion, the facial view, the palatal view, and the extent of the lesion. The 980 nm of diode laser was used for the excision of lesion at 2 watts. The IOPR shows no bony involvement and the excision of lesion was done. The post-excision figure shows the bloodless field due to use of the diode laser. The histopathological image presented the presence of the lobular capillary hemangioma. The healing after 1 month and 6 months presented the complete healing of the lesion area, and there is no recurrence of the lesion. The post-surgical instructions had given to all the patients, and the antibiotic and analgesics were prescribed, and patient is advised to use 0.12% of chlorhexidine oral rinse, and the patient had instructed to return for the post-operative evaluation. Coming to the discussion, pyogenic granuloma is an inflammatory hyperplastic oral lesion and comprises about the 1.85% of the oral lesion other than caries and gingivitis. The pathogenesis can be explained as during pregnancy, estrogen and progesterone increases expression of angiogenic factors and decrease granuloma cell apoptosis. There are various suggested treatment options such as the curettage, cryotherapy, laser ablation, the sclerotherapy, corticosteroid injection, and the surgical excision. The differential diagnosis includes capillary hemangioma, peripheral giant cell granuloma, peripheral ossifying fibroma, hyperplastic gingival inflammation, suppository sarcoma, metastatic sarcoma, carcinoma, and the angiosarcoma and non-Hodgkin's lymphoma. In first case, conservative surgical excision was used. In second case, the excision was done by the reverse bevel incision. In third case, a modified excision was done with the deep curettage to eradicate the pyogenic granuloma with 2 mm of surrounding healthy tissue, and no recurrence was noted. In the fourth case, use of diode laser was done for the excision of the lesion, and removal of lesion with diode laser is a safer technique. Coming to the conclusion, this paper summarizes that pyogenic granuloma can be nicely treated with the correct diagnosis and the proper treatment planning and guided follow-up of the lesion. In all the 4 cases, different techniques were used, and all the 4 techniques presented had good treatment outcomes, including no recurrence in the 6 months. The use of diode laser is a safer technique with various advantages, including the bloodless field. At last, I would like to thank you all for your presence. Thank you.
Shasikan sir and Sachin
Yes.
sir, you can start the question answer session. For
Dr.
both
Sachin,
the
please go.
chairperson, sir, for both the chairperson, the time is only 2 minutes. You can check the timer on the screen, sir. You can begin now.
Yes, sir. Okay. Doctor sir, please go ahead. Please go ahead.
In Yeah, good morning, doctor. In your first case, there was an pathological migration. Okay. So, so was it because of the enlargement?
Yes, sir, there was pathological migration was present, but it was not due to the enlargement in that area. Because the pyogenic granuloma that I was showing in this case, in first case, was totally healed, and the lesion was present starting from the second trimester and after delivery also, and we had treated the pyogenic granuloma after the delivery of the patient.
So
And
the spacing was present before the enlargement.
Yes, sir.
The spacing was present even before the enlargement occurred.
The migration, sir.
Yeah, the migration was present even before the enlargement was there.
Sir, according to the history of the patient, she was telling that she was having only the enlargement, not about any about the pathological migration. But sir, in case of if there is pathological migration and the bone loss, then there will be some other differential diagnosis that we can make in the cases of such as the peripheral ossifying fibroma cases.
Okay,
but in
you
this
mentioned those differential diagnoses. What is the recurrence rate for pyogenic granuloma?
So, I'm not quoting any studies, but I have studies that 60% cases are having the recurrence rate.
What is the cause of recurrence? What is the cause of recurrence?
So, there may be the many cause of recurrence. There is a persistent local irritational factors, and they may be also associated with the pregnancy or the trauma, and also as I said, the hormonal factors.
See,
And
now
also
all of
the-
these things, other than hormonal factors, the rest is what you have to correct before doing the surgery, right?
Exactly, sir.
The
Yes.
etiological factor has to be removed even prior to doing surgery. But if you're
Yes,
saying
sir.
that they're still persisting, like trauma or inability to effectively clean, other than hormonal factors probably which are not modifiable, the rest of the factors are modifiable, but yet any other reasons for recurrence of pyogenic granuloma?
Yes, sir. If they are doing surgery and it's not properly removed all the infected tissue, then it can also cause the recurrence of pyogenic granuloma.
In your histopathological reports, you were saying it is lobular capillary hemangioma, and you also put the same word in differential diagnosis. Then it is not a pyogenic granuloma. Then you are using the word lobular capillary hemangioma in all your histopathological reports of all the cases. And
Yes,
you
sir.
also
Yes.
use the same word capillary hemangioma again in a differential diagnosis. And hemangiomas are not to be operated directly, right? You know that, right?
Yes, sir. Definitely.
Yeah. Because the problem with bleeding.
Exactly, sir.
But your histopathological reports are all showing us hemangiomas.
Because sir, histologically we can divide the pyogenic granuloma of two types. That is the lobulary capillary hemangioma and
Very
non-lobular
good.
capillary hemangioma.
Okay.
And
Okay.
in
All
my
right. Yes. And
and
what is
sir,
the kind of healing you can expect after doing your surgery?
Yes, sir.
What is the kind of healing we can anticipate? Healing
After
after
doing,
excision.
sorry,
Yes.
sir, there is a glitch in the sound, sir.
All right. Fine. Fine. Thank you. Thank you.
Thank you, sir.
Thank you. Thank you.
Thank you so much, sir.
Thank you, Dr. Tulika. We can now move on to our next presentation by Dr. Pankaj Goyal.
Good morning, respected members. I, Pankaj Goyal, is going to represent a case in front of you, which is phenytoin-induced gingival overgrowth, an aesthetically linked mental trauma or psychological trauma for patients with epilepsy. Now, what is epilepsy? It is one of the most common chronic neurological disorder in humans. It is a disease where a person has recurrent seizures due to the chronic underlying process. It is due to the abnormal or excessive neurological activity in the cortex of the brain. The prevalence of the epilepsy is 3.0 to 11.9 per thousand population, and incidence is 0.2 to 0.6 per thousand population. Currently, more than 20 prescription medications are used for the treatment of the epilepsy, which are associated with the gingival enlargement. Gingival enlargement, and gingival overgrowth are terms used interchangeably with hyperplasia, hypertrophy, and fibrosis. Hyperplasia is an increase in the number of the cells in tissues that result in increased tissue volume. Hypertrophy refers to the increased tissue size and volume resulting from the cell size. Now, drug associated with the gingival overgrowth can be broadly classified as anticonvulsant, immunosuppressant, calcium channel blockers, and among them, phenytoin is the most commonly associated with the gingival enlargement. Gingival enlargement is defined as abnormal overgrowth of the gingival tissues. In terms of prevalence, phenytoin is 50%, cyclosporin 30%, and calcium channel blocker 10 to 20%. DIGO was first reported in 1939 by Kimball with chronic usage of anti-epileptic phenytoin. Phenytoin-induced gingival overgrowth is characterized by the enlargement of the antinatal papilla, increased thickening of the marginal tissue, causing aesthetic, psychological disturbance, may affect mastication, malposition of the teeth, difficulty in speech, and impaired oral hygiene. The color changes from the pink to deep bluish red, depending upon the amount of the inflammatory infiltrate present in the tissues, and secondary inflammation may induce edema, ulceration, and bleeding. Gingival overgrowth normally begins at the intestinal papilla and is more frequent found in the anterior segment of the labial surface. The overgrowth takes 2 to 3 months to become noticeable and can take 12 to 18 months to reach its maximum severity. Gingival enlargement is prominent in plaque accumulated areas around orthodontic appliances and rarely in the edentulous areas. Case report. A 29-year-old female patient visited the Department of Periodontics with the chief complaint of poor aesthetics, swollen and bleeding gums since 8 to 10 years in the mandibular jaw. Her medical history revealed patient is epileptic and on medication and taking phenytoin 500 mg twice daily. The oral hygiene was poor with abundant plaque and subgingival calculus. The gingival overgrowth showed pebble surface with some areas having firm and leathery consistency, while the other areas have soft and edematous consistency as a result of secondary inflammatory changes due to the presence of abundant local factors. Now we are talking about the intraoral examination. There is a bleeding on probing, which we are given score 3 according to the circular bleeding index. Generalized grade 3 gingival enlargement, which involve the interdental papilla, the margin gingiva, and the attached gingiva, which is reddish pink in color, rounded, and bulbous contour. There is a greater mobility of the mandibular central incisors. Deep pockets of 6 to 8 mm, which is measured by the CPITN probe, which is community periodontal index for treatment needs, covering 3/4 of the clinical crown of the teeth. There is no facial asymmetry, and in the OPG, we can see that there is a more moderate horizontal bone loss. With the consent of the patient and a physician, phase 1 therapy was done, in which patient education and motivation, professional toothbrushing, multiple scaling and root planning were undertaken as subgingival irrigation. After 1 month, the gingival condition improved and the case was subjected to routine oral hygiene with a soft, gentle toothbrush and warm saline rinses. What is phenytoin? Phenytoin is a drug of choice for the treatment of grand mal, temporal lobe, psychomotor seizure, and it has been linked to the gingival overgrowth for more than 70 years. Gingival overgrowth, the gingival enlargement of gingival tissue is due to the increase in the extracellular matrix content and increase in the number of cells of the bone. It is due to the impairment in the imbalance between the synthesis and degradation of the extracellular matrix. Phenytoin in the saliva is absorbed or diffused by the circular epithelium, which is mainly from two pathways. One is mainly the systemic circulation, and other from the reabsorption pathway of the saliva. Phenytoin-induced gingival overgrowth frequently occurs on the anterior buccal, maxillary, and mandible. Entire dentition can be covered in severe cases. Treatment option non-surgical. Simple discontinuation of the offending agent is not a practical option, but replacing it with another medication might be. Alternative medication to phenytoin include carbamazepine and valproic acid, which has a lesser effect than the phenytoin on gingival enlargement. Clinicians should also emphasize the plaque control as the first step in the treatment of the drug-induced gingival enlargement. Good oral hygiene and frequent professional removal of the plaque decreases the degree of the gingival enlargement present and improves the overall health. Prevention: avoid local irritants, rigorous plaque control, using mouthwashes, periodontal maintenance therapy at 3 months intervals, topical or oral folic acid supplementation. Treatment: oral hygiene measures, tooth cleaning, scaling and root surface instrumentation, substitution of phenytoin, that is carbamazepine, valproic acid, gabapentin. If possible, oral folic acid supplementation 0.5 mg per day. Surgical: gingival enlargement may persist despite drug substitution attempt and good plaque control. These cases need to be treated by periodontal surgery. Before any surgical procedure, precautions and consultation with the physician regarding underlying systemic disease should be taken into consideration. The surgical management of the drug-induced gingival overgrowth includes the scalpel, gingivectomy, periodontal flap surgery, and electrosurgery, and laser excision. Now, conclusion. Adverse aesthetics and impaired function are associated with the presence of drug-induced gingival enlargement. Comprehensive treatment of these cases is multidisciplinary in nature, and dentists and physicians should first consider the non-surgical approach, including the removal of the local factors and discontinuation of the offending drug. If the non-surgical approach is not effective, periodontal surgery in form of gingivectomy or periodontal flap procedure can effectively reduce the enlarged gingival tissues. Now, gingival enlargement occurs on intake of cyclosporin, phenytoin, and calcium channel blockers. Drug-induced gingival overgrowth also results in the periodontal tissue. It is necessary to advise patients of the possibility of this effect and emphasize the importance of maintaining good oral hygiene as a preventive measure. Hence, it would be good to identify and explore possible risk factors relating to both prevalence and severity of the drug-induced gingival overgrowth. Several new therapeutic modalities are needed to establish the pathogenesis of gingival enlargement and to create awareness for the future. Thank you so much.
Dr. Sachin sir and Dr. Sasikant sir.
Dr.
Good morning,
Pankaj,
sir.
what treatment did you do for the patient finally?
Sir, actually, due to the COVID, we cannot recall the patient, sir. Actually, I'm in first year, sir, so I already done
Okay.
scaling and curettage, sir.
So what was the effect you achieved by doing scaling and curettage?
Sir,
Are you still doing curettage? By the way, are you still doing curettage for the patient?
No, sir.
Then that's what you said just now?
Sir, we had done curettage before 2 months, sir.
No, curettage is still an accepted treatment procedure. Is gingival curettage still an established treatment procedure?
Sorry, sir, I don't know, sir.
Okay, fine. Okay, fine. I understand what you have done. And did you achieve any benefit by doing scaling and root planing? Could you recall
Sir, there is a reduction in the reduction in the inflammation, sir, bleeding on probing, sir, and patient can eat, sir, is able to chewing of.
Okay, how long since you started this phenytoin?
Sir, patient was taking, sir, at the age of 18, sir, and now sir, patient is sir 30 years, sir. Patient taking, sir, from last 12 years, sir.
So, do you believe that the enlargement they developed now is because of phenytoin?
Yes, sir. It might.
But you have clearly mentioned in one of your slides, it is usually starts within 2 to 3 months after starting the drug, and
yes,
maximum it will achieve its maximum size in 12 to 18 months. But
yes,
patient
sir.
is already on medication for more than 12 years. So I
Yes,
doubt
sir.
whether it is because of phenytoin or is it an inflammatory enlargement.
Sir,
you understood my question, right?
Yes, sir. So phenytoin, sir, it is due to the phenytoin, sir.
How are you concluding that it is because of phenytoin? Have you done any histopathological study? No,
No, sir. No, sir. No, sir.
Then how are you concluding it is a drug-induced enlargement? Because, as you said in your slide, if the patient is going to develop the enlargement because of phenytoin, it is going to start within 2 to 3 months of starting the medication, and
Yes,
he's
sir.
surely going to notice it in 6 months, and it will achieve maximum size in 12 to 18 months.
Yes, sir.
But you are saying the patient is on medication for more than 12 years.
Yes, sir. But patient complains, sir, ki the swelling was, sir, from last 10 to 11 years, sir.
And it achieved this size. Okay, fine. You were saying for the drug substitute, the patient can be given gabapentin or carbamazepine, right? Drug
Yes,
substitute
sir.
for phenytoin.
Substitute for phenytoin, sir.
Yeah, carbamazepine. Suppose if you're giving to the patient, what are the what should you be taking care of? Very importantly, if you're giving carbamazepine for the patient.
Sir,
Any idea,
platelet
doctor?
count, sir, it may suppress the, sir, bone marrow, sir.
What can it result in?
Suppression
You're
of
right.
bone.
Very good. You are right. And it will result in what? If there is bone marrow suppression, what can the patient suffer from if
Sir,
he's
there
on
is
long-term
decrease, sir.
carbamazepine?
Sir, decrease in the platelet count, sir. We have
Not
sir,
platelet
BPCT,
count.
sir.
Not platelet count. Not platelet count. It is aplastic anemia. There is a probability of aplastic anemia because of bone marrow suppression. Anyway, Doctor sir, please continue, sir. Doctor, please go ahead.
Yeah. Regarding to your treatment plan, did you only substitute the drug or you sent it back to the physician?
Sir, we have sent it back to the physician, sir. Sir, it put on the patient, sir, tab, sir. I don't know about much, sir, but it put the doctor put on patient, sir, tab, sir.
What is it? Is it valproic acid? What is the generic name of the drug?
Sir, might be, sir, valproic acid, sir. And sir, it reduces the dose of the phenytoin, sir, 100 milligrams, sir.
All right. Please go ahead.
Okay. Okay, I think we are done with the time, I guess, sir.
Yes.
Yeah.
Sure. Thank you, sir.
Okay. Thank you, Dr. Pankaj. Now the next presentation, Dr. Minkim Gao, he is not present in the panel, so we will skip his presentation and go to the next presentation by Dr. Sudipta Ghosh.
Good morning, everybody. Myself, Dr. Sudipta Ghosh. Today, I am going to present a rare case report of grade 3 idiopathic gingival fibromatosis.
Hello.
Idiopathic gingival fibromatosis is an uncommon benign condition characterized by progressive enlargement of the gingiva caused by an increase in the size of submucosal collagenous connective tissue that affects the marginal gingiva, attached gingiva, and interdental papilla. It causes aesthetic, functional, psychological, and masticative disturbance of the oral cavity. Basically, gingival enlargement can be due to plaque accumulation, poor oral hygiene, inadequate nutrition, or systemic hormonal stimulation. Investigations are in evolution to establish the genetic linkage and heterogeneity associated with it. In recent times, a mutation in the son of 7-1 or SOS1 gene has been suggested as a possible cause of isolated or non-syndromic gingival fibromatosis, but no definite linkage has been established yet. The enlarged gingival tissue may partially or totally cover the dental crown, can cause diastemas, pseudopocketing, delay or impaired tooth eruption, and aggressive periodontitis due to poor oral hygiene. In case of severe condition, it may lead to mastication and speech impediments or lip closure difficulties. This condition may be painful when tissue are traumatized during masticatory process. If the inheritance is autosomal dominant, then the phenotypic frequency is 1 in 750,000 people, and the gene frequency is 1 in 350,000 people. Now, this is my case. Patient particulars. A 12-year-old female patient reported to the outpatient department of periodontology with a complaint of swollen gum in both upper and lower front and back teeth region. According to patient, the swelling appeared at the time of eruption of permanent teeth and was not associated with any pain. Swelling caused difficulties in speech, mastication, and complete closure of lips, thereby leading to aesthetic impairment. This picture shows the integral presentation of the case. Patient's medical, dental, personal, and family history were non-contributory. Integral examination revealed enlargement of gingiva on both buccal and palatal side with pinkish red in color, fibrous in consistency. Bleeding or probing was absent. Gingival enlargement enclosed the major surface of the teeth present except the incisal occlusion surface. Occlusal radiographs and panoramic radiograph were advised. Also, a general examination and routine blood investigations were advised to eliminate any medical abnormality. All the reports were within the physiological limit. This is the occlusal radiography view. Alginate impression of upper and lower arch was made and study model were obtained for the record purpose. Based on the available data regarding history and clinical features, a provisional diagnosis of idiopathic gingival fibromatosis was made. Now the surgical procedure. Treatment consisted of sextant by sextant surgical excision of the enlarged gingiva under local anesthesia. The transgingival probing was done on the buccal and palatal aspect of the maxillary anterior and posterior teeth. The marking of depth of gingival surface of maxillary, buccal, and palatal area was done with a French Kaplan pocket marker. First, internal viral gingivectomy was performed on the buccal and palatal aspect of the maxillary arch. Lesion waste procedure was done to remove the gingival overgrowth over the palatal aspect of the maxillary posterior region. On the maxillary posterior region, lesion waste procedure combined with internal viral gingivectomy was done in order to remove the overgrowth. The excised tissue was sent for histopathological examination. This is the perioperative picture of this patient. Below picture, it shows the excised gingival tissue. Suture was placed and patient was asked to maintain good oral hygiene. This picture shows after suturing. Patient was recalled after 14 days for checkup and suture removal. This picture shows after 14 days. And this is the preoperative view and postoperative view of this patient after 6 months. Discussion. Gingival fibromatosis may occur as an inherited condition known as hereditary gingival fibromatosis, or it may be associated with inflammation, leukemic infiltration, and medications. In the present case, family history was negative. The patient exhibit no sign of hypertrichosis, mental retardation, and epilepsy or intake of any medication known to cause enlargement. Hence, the cause was diagnosed as a non-syndromic case of IgF. Among the suggested treatment protocol, lesion-wise technique along with internal gingivectomy was selected as it helps in eliminating the guesswork involved with placement of primary incision as opposed to the conventional internal gingivectomy procedure. This is my conclusion. The patient case report highlights a non-syndromic IgF and its management. Surgery significantly improved the patient's aesthetics and mastocytory function. Recurrence has not been reported. This is my references. Thank you.
Dr. Sudeep Ghosh.
Good morning.
Can you hear me? Can you hear me,
Yes,
Dr. Sudeep? Yeah.
Yes, sir.
You have said it is a case of idiopathic gingival fibromatosis. What about the histopathological report? Did you send it for histopathological examination?
Yeah, yes, sir. So
What
the
was the
report,
report?
so the report shows the some amount of connective tissue that is relatively avascular and consists of densely collagen bundles, numerous fibroblasts present in the slide.
Is it conclusive that it is? Does it conclude that it is a case of idiopathic enlargement?
Yes, sir. The department just concluded it idiopathic because there is no familiar history of any drug history.
So usually if it is a case of idiopathic, we also call it as a familial gingival enlargement. Usually there will be a family history wherein either the siblings.
No, sir. There is no history of any familial history.
What is the synonym for idiopathic gingival enlargements? What is the synonyms other than the word idiopathic gingival? What else it is called as?
Sir, idiopathic fibro may be called as gingivo fibromatosis or elephantiasis, or gingival hyperplasia, or in case of congenital familial fibromatosis.
Now, you have shown the surgery being performed in the first quadrant. Did you perform the surgery in the rest of the quadrants?
No, sir. Due to COVID situation, we are not able to do this.
Okay. You said there was no recurrence, but normally what is the recurrence rate in these kind of cases? If it is indeed a case of idiopathic gingival enlargement, what is the percentage of cases where you get recurrence?
Sir, in my case, there is shows no recurrence still after 6 months.
Well, that is not a satisfactory answer. Anyway, now you have only done gingivectomy. You do internal bevel gingivectomy. Now, what is it to be followed up with? You have to follow up gingivectomy with some other procedure.
Yes, sir. No, sir. After in this case, we have not done any procedure after this surgery. But
normally, after gingivectomy, we have to do a follow-up procedure. What is it? What do you do?
Yes. No,
what
sir. In this case, sir. No, sir.
I'm asking otherwise, what should you be doing? Normally, any gingivectomy procedure should be followed up with some other procedure to get back the arcuate counter of the gingiva.
Yes, sir. Yes.
What is that procedure called as?
Gingivoplasty.
Okay. Doctor, please go ahead, sir.
Why an internal bevel? Why not an external bevel gingivectomy in this case?
Because, sir, in this case, the mass is so heavy. The external bevel gingivectomy is quite difficult. And the lesion-wise procedure is ideally, sir, very easy to case if there is a some mass is excised before.
What is an indication for an internal bevel gingivectomy and an external bevel gingivectomy?
So normally in classical gingivectomy, external bevel gingivectomy is done, sir. But in case of lesion-wise procedure, we are doing the internal bevel gingivectomy.
What should be the width of attached gingiva when you are doing a gingivectomy procedure?
Yes, sir.
What should be the width of attached gingiva remaining when you are planning to do a gingivectomy procedure? You understood my question?
Yes, sir.
When you're doing the decision-making tree, when you're planning to do a gingivectomy, what is the important factor you have to keep in mind when you're planning gingivectomy? About the amount of attached gingiva that should be remaining after you have done your gingivectomy. Without which the sir was asking the same question, I'm asking it to you in a different format. Sir is actually asking the same question. I'm asking it to you in a different format. You're a first year student or a final year student, doctor?
It's a second year student.
Okay.
Second year.
Sir, please go ahead.
Okay, I'm done, sir. We'll go to the next slide.
Okay, thank you, Dr. Sudipta. Tech team, do we have any news of the next presenter, Dr. Minkingao Gao? Is he there, or we can move on to the next session?
She is not here.
Okay. Okay.
So it's better to move on next session.
Okay. Okay. So with this, we now conclude our second session. I may present my thanks to Dr. Y.V. Shashikant sir and Dr. Sachin Sibnaikar sir for their for taking out their time and sharing
Thank you.
this session.
It was a pleasure. It was a pleasure.
Sir,
Thank you. Well organized. It was well organized.
Very well organized. Surely, no doubt about that.
Thank you, sir.
Done a great job.
Sir, a gentle reminder to send
Yes,
the
sure.
evaluations to
I'll
send the
do it.
evaluations. Yes, sir. Yes. Thank you
Sure,
so much.
Yeah, we'll send it. Yeah, thank you. Thank you. Good day, all. Good day, all.
Yes, sir. Thank you so much, sir.
Bye, sir. Bye.
Now we move on to our third session. May I introduce the chairperson of the third session, Dr. Shalu Batla, ma'am. He is a professor at College of Dental Science and Research, Mulana, Ambala, Haryana. Along with her is Dr. Sumit Malhotra, professor and head, ITS Dental College, Moradabad, Ghaziabad. Welcome you, sir, and welcome, ma'am.
Thank you.
Ma'am, and sir, a gentle reminder to stick to the 2-minute time frame for the question answer session. At the time of this message is to all the presenter also. At the time of presentation, kindly mute your audio and keep your video off. At the time of question answer, you can unmute yourself and show your video. We can now go with the first presentation of the third session by Dr. Asa Todi.
Respected judges, I am Dr. Asa Todi, and the topic of my paper presentation is gingival overgrowth, the camouflaged cause and the tactful treatment. Coming to introduction, gingival overgrowth is the increase in the size of gingiva which occurs in response to local inflammatory condition, drug therapy, systemic conditions, or idiopathic causes. It predisposes to further plaque accumulation, difficulty in maintaining oral hygiene, and interferes with mastication. Gingival hypertrophy and hyperplasia are histopathologic terms which cannot be accurately differentiated, hence are avoided. Brief mechanism of action: when local inflammatory conditions, systemic conditions, or there is a genetic susceptibility which acts on the normal tissue, there is cellular adaptive response from the tissue causing hyperplasia, hypertrophy, and fibrosis due to the increased proliferation of fibroblasts due to the increased expression of transforming growth factor beta and connective tissue growth factor, and there is a reduced rate of apoptosis of fibroblasts leading to gingival overgrowth. And the three main causes for it are increased proliferation of epithelial and connective tissue cells, increased secretion of extracellular matrix proteins, and increased collagen production and degradation. According to the distribution, it can be classified as localized and generalized. According to the area of distribution, it may be marginal, papillary, diffuse, or discrete. According to the etiological factors and pathological changes, Carranza classified it as inflammatory gingival enlargement as acute abscess or chronic, non-inflammatory drug-induced gingival enlargement, enlargement associated with systemic diseases or conditions such as pregnancy or leukemia. Neoplastic gingival enlargement may be benign or malignant tumors, and false gingival enlargement due to underlying osseous or dental tissues. The degree of gingival enlargement can be scored by many ways. I have mentioned two such methods as given by Bokenkamp and Bornhorst in the year 1994, where grade 0 had no signs of clinical gingival enlargement, grade 1 where the enlargement was confined to interdental papilla, grade 2 enlargement involves papillary and marginal gingiva, and grade 3 involves most of the gingival tissue covering the crown. In 1985, Seymour gave the horizontal component where the enlargement was measured labiolingually and grade 0 was normal, grade 1 was thickening from the normal up to 2 mm, grade 2 was thickening from normal more than 2 mm. The aim of this case report is to compare and evaluate the camouflage signs and symptoms in patients presenting with gingival overgrowth with the help of proper diagnosis, substantial investigations followed by tactful treatment modalities. The objective was to highlight gingival overgrowth and how it presents differently in different patients, and to plan and adopt a streamlined treatment with proper diagnosis and investigations. The methodology will be as follows. Case report 1, wherein a 66-year-old male patient presented in the department with a chief complaint of overgrowth in mandibular anterior region since 3 months. He gave a history of chronic systemic diseases such as chronic kidney disease, diabetes, hypertension, and was under medication for the same. Blood investigations and CBCT was advised. After the goal of phase 1 was achieved, the blood investigations were reviewed, parameters were normal, and CBCT showed no signs of bony prominences. The patient was given antibiotic prophylaxis and gingivectomy surgery was performed. The tissue was sent for histopathological analysis. These are the various radiographic investigations in the form of a CBCT and OPG which showed no bony prominences. LA was given and external bevel gingivectomy was done using 15-number blade after the pocket was measured through a pocket marker. The excised mass was put in formalin and sent for histopathological examination. Tissue tags were removed to obtain a clean surgical field. The hemostasis was achieved and sutures were placed immediately after the surgery. Post-operative healing was seen as such after 7 days and sutures were removed. These are the 21 days and 45 days post-operative healing. The final report as given by oral pathology department revealed significant rise in plasma cells and a slight rise in inflammatory components suggestive of plasma cell gingivitis as a provisional diagnosis, but due to inconclusive rise in plasma cells, the diagnosis was given as chronic non-specific gingival inflammation. Case report 2 involved a 24-year female patient presented with the chief complaint of bleeding and swollen gums in both maxillary and mandibular labial region and in the lingual mandibular teeth. The patient had a poor oral hygiene with no adverse habits, no drug history or underlying systemic disease. Phase 1 therapy was performed to eliminate the local factors, but the pocket probing depth was 10 mm even after phase 1 was achieved and surgery was planned. Investigations and OPG revealed no underlying pathology. Hence, the patient was put on antibiotic prophylaxis and gingivectomy was performed. This was how the patient presented in the OPD. Scaling and root planing was done. This is the day of the surgery. Pockets were marked with the pocket marker and LA was given. External bevel gingivectomy was performed with using a 15-number blade. Post-operative labial group. The lingual side was excised with the help of electrocautery. Hemostasis was achieved and the periodontal plaque was placed. Excised tissue was sent for histopathological examination. These are the 10 days post-operative picture. The histopathological examination done by oral pathology revealed that the patient had a chronic inflammatory gingival overgrowth due to local factors. Hence, the patient was given post-operative oral hygiene instructions to maintain the surgical site. In my results, I would like to say that my case report 1 of gingival overgrowth was quite challenging as there wasn't a clear-cut margin of the extent of the enlarged tissue and on palpation it was fibrotic. The provisional diagnosis for the case could be a drug-induced gingival overgrowth due to the underlying systemic conditions of the patient or plasma cell gingivitis after seeing the histological section. But due to insignificant plasma cells, the final diagnosis was chronic non-specific gingival inflammation. While the second case of gingival overgrowth presented with a soft and edematous tissue with heavy gingival bleeding, patient had no history of drug or systemic diseases. Hence, after phase 1 therapy and surgery, it was concluded that it was a case of inflammatory gingival overgrowth due to local factors and it was confirmed by histopathology. This paper outlines 2 of the multifaceted causes of gingival overgrowth and throws light on its treatment with proper diagnosis and planning. Proper clinical examination and investigations are primary tools to reach the final diagnosis along with histopathological reports. Most often, the nature of the tissue predicts the underlying causes, which is clinically determined and correlated with further reports. In my conclusion, I would like to say that the first and foremost treatment for a case of gingival overgrowth is to go for a non-surgical therapy where meticulous self-administered oral hygiene, along with all necessary components of phase 1, should be carried out by the clinician to achieve the goal of phase 1 therapy. In most possible cases of gingival overgrowth, there is presence of inflammation. Hence, to reduce the bacterial load, adjunctive antibiotic therapy can be given to the patient. Surgical treatment is advocated when overgrowth is severe by scalpel gingivectomy, flap surgery, electrosurgery, and laser excision. Hence, the payoff of all these surgeries is based on the luminary, that is the maintenance phase, which is the key to all comprehensive dental treatment care. Thank you.
Okay, I may invite Dr. Shalubatla ma'am and Dr. Sumit Malhotra sir to chair the session.
A very good morning to all. Dr. Astam, a very wonderful presentation. I have just one question to ask. Like, yeah, you in the last slide you said that along with the gingivectomy, we can do flap surgery in such cases. So,
Yes,
which all flap surgeries you can perform in such cases?
Ma'am, we can go for an undisplaced flap surgery.
Great. So what will be the indications, peculiar indications for the undisplaced flap surgery?
Ma'am, basically when the pocket depth is more than a certain amount, that is more than 5 to 6 mm, we can go for a pocket, undisplaced flap surgery in the aesthetic area specifically, because we don't want to have a gingival recession as an outcome of our surgery.
Okay, great. And can you just elaborate on the differential diagnosis apart from your drug-induced gingival enlargement and plasma cell gingivitis?
Ma'am, we can also give a differential, since in my case report 1, there was a significant enlargement which was quite hard in nature, fibrotic in nature. If we wouldn't have gone for a CBCT or a OPG, we would have given a differential diagnosis of a fibrous osseous lesion such as fibrous dysplasia. So that was ruled out due to further investigations, ma'am. Or any underlying dental tissues enlargement would also have been a differential diagnosis.
Any other differential diagnosis apart from the falls or the osseous enlargement? Any other?
Ma'am, it could have been a fibroma, a benign malignant tumor, neoplasm,
Okay.
which could have we could have given as a diagnosis.
That's it, or any other thing you can think of?
Considering with clinical correlation, these were the only.
Great, good enough.
Since it was fibrotic in nature, because otherwise we have a lot of hematomas and everything, but it would have been like not fibrotic on palpation, ma'am.
Yeah, great. Sumit sir, please.
I have a question. In the first case report,
Yes,
what technique did you employ?
Sir, we went with a normal external. We had planned a normal external bevel gingivectomy. Since the margins were very erratic and very abrupt, sir, we and the pocket measurement, like the fibrosis of the tissue was so much that once I like measured it with the pockets, I could not see the pocket depth. So we planned for a normal external bevel gingivectomy only, and the amount of tissue that we could remove along with along with the blade, we removed it, and further the tissue tags.
Because of paucity of time, my question was that if you employed external bevel gingivectomy, then why did you give sutures?
Sir, that was to provide hemostasis, sir. So the margins were.
That's very odd. Okay. And why did you in the second case report?
Yes.
Why did you do surgical on the buccal side and electrocautery on the lingual side?
Because we just wanted the comparative evaluation, and also on the lingual side, the gingival enlargement was too minimal. So we did not want to. We did not want to go beyond a certain level and damage the lingual artery, sir. So
Thank you.
conservative.
Very nice presentation.
Thank you, sir.
Thank you.
Thank you, Dr. Asta. We can move on to the next presentation by Dr. Kunal Apurva.
Hi, a good day to all of you here. I'm going to present my case report on Vilcodontics, cutting corners to save time. What the periodontium? It's a dynamic tissue, and the regulation of its remodeling gives an edge in the traditional orthodontic treatment. A multidisciplinary approach, it's often required for the correction of complex dentoalveolar problems in patients, and this can be better explained by an ortho-perio integration. During orthodontic treatment, the tooth socket migrates and the tooth moves through the bone, carrying its attachment apparatus, that is the periodontal ligament, along with it. And therefore, orthodontic tooth movement, it's basically a periodontal ligament phenomenon. Periodontally accelerated osteogenic orthodontics or Vilcodontics, it combines the periodontal therapy with orthodontic therapy, which minimizes the treatment time. It's a clinical procedure that combines selective alveolar corticotomies, particulate bone grafting, and the application of orthodontic forces. This PAO, it results in an increase in the alveolar bone width, a shorter treatment time, increased post-treatment stability, and decreased amount of apical root resorption. What are the indications and contraindications? The indications are dehiscence and fenestrations over prominent root surfaces, anterior open bites and deviated midlines, cross bites and tooth size discrepancies, conservative alternative to orthodontic surgery, moderate to severe malocclusion in both adolescents and adults, accelerate the canine retraction after premolar extractions, enhance the post-orthodontic stability, and to facilitate eruption of the impacted teeth. The contraindications are patients with severe active periodontal disease, patients with inadequately treated endodontic problems, patients on long-term medications which will slow down the bone metabolism such as bisphosphonates and NSAIDs, and patients on long-term steroid therapy. What is the rationale of the use of bone grafts? Particulate bone grafting is done either with an autogenous bone graft, decalcified freeze-dried bone allografts, or xenografts, and the placement of this bone graft is believed to be responsible for the increased post-treatment alveolar bone width, and the tooth can be moved 2 to 3 times more in 1/3 the time required for traditional therapy. Coming to the present case, a 16-year-old male patient had presented with the chief complaint of forwardly placed upper and lower front teeth, and in clinical examination there was crowding and proclination of the mandibular anteriors along with an open bite. There was no significant medical dental history, no history of previous and present medications that the patient was on, and no relevant family history. The oral hygiene methods used were once in a day brushing using a soft bristle brush and toothpaste in a horizontal manner, and the patient was on a mixed diet. And when the oral habits were examined, it was noticed that tongue thrusting was present, which accounted for the anterior open bite. The treatment plan which was given was phase 1 involved scaling and root planing, oral hygiene reinforcement, and recall after 1 week for the evaluation. Phase 2, a corticotomy was planned with bone grafts in relation to the lower anteriors, and there was no phase 3, and under phase 4, a periodic recall and maintenance at 1 month, 3 months, and 6 months. The surgical procedure. The flap design, the procedure was performed under local anesthesia, and like you can see here, a full thickness mucoperiosteal flap was elevated from the canine to the canine region. Care was taken to preserve the interdental papilla, and the labial flap was deflected much beyond the apices of the lower anteriors. Next, we have the corticotomy. Selective decortication was performed using a piezotome at a depth of about 2 millimeters. Vertical grooves were placed extending into the cortical bone, but just before the medullary bone was reached, and these vertical grooves were started 1 to 2 millimeters below the alveolar crest and extended 1 to 2 millimeters beyond the apices of the anteriors. Grafting, a xenograft was placed, and the amount of the volume of the graft material depended on the direction and the movement of the teeth, the pre-treatment alveolar bone thickness, and the need for alveolar support. And finally, the flaps were reapproximated with a non-resorbable black braided silk suture with interrupted sutures in a tension-free manner, and these sutures were left in place for a period of up to 7 days. After a period of 2 to 3 weeks, the retraction of the lower arch was continued using coiled springs like you can see here, and a periodic recall was done every 3 to 6 months to assess the periodontal status of the patient. And the discussion, corticotomy assisted orthodontics has been employed in various forms to accelerate orthodontic treatment. Rapid tooth movement associated with corticotomy was first introduced by Henry Cole in 1959, and the cortical plates of the bone are believed to be the main resistance to orthodontic tooth movement. In corticotomy-assisted orthodontics, rapid tooth movement is achieved by disrupting the continuity of the cortical bone by selective cut and preserving the vitality of the teeth and the marginal periodontium. Periodontally accelerated osteogenic orthodontics, also called as the Wilcodontics, was introduced by the Wilco brothers in 2001. It's a revised corticotomy facilitated technique which involves a full thickness labial and lingual flap elevation accompanied by selective surgical scarring of the cortical bones. That is the corticotomy procedure. And this was followed by placement of the graft material, surgical closure, and orthodontic force application. So this is the biology behind the use of this corticotomy. So regional acceleratory phenomenon. It's a local response of the tissue to the noxious stimuli through which the tissue regenerates at a faster rate than the normal. So what happens is when orthodontic forces are applied in conjunction with these micro-osteoperforations, there is an increased inflammatory mediators. There is an increased level of cytokines and increased osteoclastic activity, which will accelerate the bone turnover and facilitate a rapid orthodontic tooth movement. The rapid tooth movement associated with PAO is different from the periodontal ligament associated tooth movement, and recent evidence suggests that this RAP, it's a localized osteoporosis state which occurs as a part of healing and may be responsible for the rapid tooth movement associated with PAO. The initiation of orthodontic force should not be delayed more than 2 weeks after surgery, and this time period for the RAP usually lasts for about 4 to 6 months. Frost had considered that the greatest resistance to the tooth movement was due to the cortical walls, and consequently, breaking them up would reduce the treatment time. Fisher had also considered that corticotomy encourages faster tooth movement because it reduces the bone mass. What are the advantages and disadvantages of this technique? Lesser time in brackets, accelerated treatment time, less risk of post-orthodontic gingival recession and subsequent cervical abrasions, greater post-orthodontic stability and retention, less risk of root resorption, and less relapse. And disadvantages, it's an expensive procedure, it's a mildly invasive surgical procedure, mild to moderate pain and swelling, and not recommended in class 3 malocclusion. And to conclude, this Wilcodontics, it's an interdisciplinary collaboration that has integrated the use of traditional orthodontic tooth movement in conjunction with the periodontal tissue engineering and regenerative surgery. And the result of this interdisciplinary amalgamation has been a rapid orthodontic tooth movement with drastically shortened treatment times and also an increased scope of treatment with reduced side effects. And these are my references. Thank you.
Yes, Dr. Kunal.
Good morning, ma'am.
Can you just tell about any other contraindication? Whatever you have written is fine, good enough. But any other contraindication you can think about related to Wilcodontics?
Basically, any bone-related disorders, ma'am, like any osteoporosis state, osteopenia, if the patient has been on any medication for any bone metabolic disorders, so that's a contraindication for corticotomy, ma'am.
Any other thing which you have written apart from that? Okay, never mind.
Any long-term steroid therapies, yes.
Good enough. Any particular post-operative instruction you tell to your patient when you perform Wilcodontics?
It is just the orthodontist that we say that the activation of the appliances should be done within 1 to 2 weeks after the procedure is to be performed, ma'am.
Okay.
And
any other you can think of? Okay, never mind. Sumit sir.
Dr. Kunal, it was a nice presentation again. So, what are the other modalities which you can use for Wilcodontics apart from what you have used here?
so here we have used a piezotome, sir, but conventionally we can just use a round carbide burr for the osteotomy cuts, sir, the corticotomy cuts. Or else otherwise using a piezotome, it could be a flapless approach, sir. Just a incision could be given and a tunnel could be created and the bone graft could be placed, sir.
Lasers have an application here? Any role to play?
Basically, we had used piezo in this particular case to achieve precise cuts, sir. That was our only.
Lasers. Do you think they have a role to play here?
I personally have not gone through any studies this corticotomy, sir. I'm not aware of any studies.
You used a xenograph. to
Yes, sir.
augment the buccal size. So how do you think it stabilizes there?
The xenograft, sir.
Yeah. Normally you need a
How do you think
contained defect, no? To put a bone graft in a contained defect. In such a defect, will the graft stay there?
So basically, we think because there are cuts there, it almost becomes like a shallow groove, sir. So that might act as a place for the graft to stay in place, and then we obviously reapproximate the flaps back, sir.
Okay, and did you assess the post-operative increase in thickness in the buccal bone?
Sir, the orthodontics treatment is still going on, and so the post-operative CPCT has not been taken yet, sir. So that is the reason I didn't include it yet, sir.
Right.
The
Thank you.
finishing courses are still being applied, sir.
Thank you, sir.
Thank you, sir. Thank you,
Thank you,
ma'am.
Dr. Apurva. We can move on to our next presentation by Dr. Amrit Kumar, Dr. Sonal Singh, and Dr. Neha Kumari.
First of all, I would like to thank Indian Society of Periodontology for giving me this wonderful opportunity to share my views and my case report on the topic, that is the management and histopathological evaluation of an unusual gingival enlargement. Myself, presenter Amrit Kumar, and the co-authors for this study are Neha Kumari and Sonal Singh. So as the case is all about the gingival enlargement, I would like to say something about gingival enlargement. Gingival enlargement is the proliferation and intensification of the gingiva, which is a prevailing character of a diseased gingival tissues. And as per the literature, gingival enlargement and gingival overgrowth are the ongoing approved clinical nomenclature used to describe the clinical manifestation. So now coming back to the case report, a 35-year-old female reported to the Department of Periodontology at Buddha Institute of Dental Sciences and Hospital, Patna, with a chief complaint of rapid unilateral swelling of gingiva in right maxillary and right mandibular region and extreme mobility of teeth in upper right region since 3 to 4 months. And on taking the medical history, nothing relevant was reported, neither any sort of drugs or medications was noted up, and neither any systemic conditions was reported. And past dental history revealed that the gingivectomy was done for the same twice 2 years ago and 6 months ago, respectively, elsewhere. Coming back to the extraoral examination, the enlarged gingiva could be palpated over right cheek. The overlying skin appeared to be normal, and no abnormality was detected in the right submandibular lymph nodes. In intraoral examination, it was seen that the diffuse nodular enlargement of gingiva extending from lateral incisor to molar region in right maxillary arch and right mandible, including the mandibular anterior region, can be seen. The calculus deposits were present on exposed tooth surfaces, and slight bleeding on provocation was noted. And also grade 3 mobility was present with respect to 1/6. So in the photograph 2 and photograph 3, we can easily see the large amount of gingival tissues, which is covering the more than 2/3 of the crown of the teeth. And this is consisting of the preoperative view of anterior region, and that is the lateral view. And this is the preoperative occlusal view of maxilla and mandible. And it easily shows that the great amount of gingival tissues which is surrounding the tooth here. So coming to the radiographical examination, generalized horizontal bone loss in right upper and lower arch was seen. And hematological examination did not reveal any abnormality, and everything related to this examination was okay. And provisional diagnosis was made as the idiopathic gingival enlargement. So treatment consisted of 3 major parts, that is the phase 1 periodontal therapy, undisplaced flap surgery, and supportive periodontal therapy. For the phase 1 periodontal therapy, the patient was called, and the supra and subgingival scaling was done, and the patient was called after 1 week for the undisplaced flap surgery. The patient was made aware of the surgery, and the written consent was obtained from the patient, and the surgery was carried out. And in the surgical procedure, the area which was taken up for the surgery was anesthetized using 2% of lignocaine and 1:80,000 adrenaline concentration. An undisplaced flap with the excision of gingival overgrowth in lower anterior region was done, and the desired amount of gingival tissue was excised out, followed by the extraction of 1/6 tooth, that was grade 3 mobile. And in the photograph itself, we can see here the undisplaced flap reflection, that is the with excision of gingival overgrowth. Same surgical procedure for right mandibular arch and followed by the debridement and suturing. Same surgical procedure for right maxillary arch followed by suturing and placement of periodontal dressing. So after the placement of periodontal dressing, the patient was advised for the medication that consisted of an antibiotic, that is the amoxicillin 500 milligram thrice daily for 7 days, followed by an analgesic, that is ibuprofen 400 milligram twice daily for 3 days, and followed by a antacid, that is pan 40 milligram, that is 1 and 2 means the once daily empty stomach. So as the excised tissue was sent for the histopathological analysis, following histopathological features were seen. Number 1 is the parakeratinized stratified squamous epithelium supported by connective tissue stroma. Second is the elongated retipex was seen. And third, that is the most important, connective tissue shows chronic inflammatory cells and dilated blood vessels filled with red blood cells were seen. And the histopathological diagnosis was made as the inflammatory gingival enlargement. And the post-operative photographs, these two are the 3 months post-operative occlusal view of maxillary and mandibular arch. We can easily appreciate the loss of the tissues, the loss of the great amount of gingival tissues which were seen in the pre-operative photographs, and now the situation is completely opposite. This is the pre and post evolution photograph after 5 months. We can easily see the large amount of gingival tissues which is in the photograph 1, and now after 5 months the photograph 2 which is itself in the slide bottom part. And this surgery was the patient was benefited with this surgery. Coming to the discussion, idiopathic gingival enlargement is a rare condition of the unknown etiology characterized by slow progressive enlargement of the gingiva. The enlargement may be localized to specific areas of the tooth of the mouth, typically the labial gingiva around the lower molars and the maxillary tuberosity region, or may be generalized. Severity may vary from mild involvement to severe involvement of all the teeth. In present case, we opted for undisplaced flap procedure to treat the patient's periodontal disease as well as to improve her functionality and aesthetics. And after a period of 5 months, evaluation of healing of the gingival tissue as well as any possible recurrence of the gingival enlargement was done. And no recurrence was seen at the end of 5 months follow-up, which could also attribute to a well-planned professional maintenance protocol. The patient was satisfied with aesthetic and functional result of the treatment. And concluding, I like to say that gingival overgrowth is disfiguring and can interfere in mastication and speech. Hence, a thorough understanding of the pathogenesis is essential. Unusual gingival enlargement can be successfully treated following undisplaced flap surgery, but its successful outcome depends on patient education and motivation, periodic recall, and proper oral hygiene maintenance that reduces the chance of recurrence. That's all for this case report. Thank you.
Dr. Amrita?
Yes, ma'am.
Yeah. So what was the age of the patient?
Ma'am, age was 35, ma'am.
Okay. So it was a case, basically a case of idiopathic gingival fibromatosis. Fine.
Yes, ma'am. Yeah.
So what are the various syndromes associated with this fibromatosis?
Ma'am, that is syndromes associated with
usually these kind of syndromes are associated with the idiopathic gingival fibromatosis. Can you name some of it? Okay, no issues. And
ma'am,
so,
Zimmerland syndrome, ma'am. Zimmerland syndrome, Rutherford syndrome.
Okay. Any other? A very
Yeah,
common one.
Hurler syndrome, ma'am. Also.
So can you just differential diagnose with this thing?
This case,
orofacial granulomatous?
ma'am, we can differentially diagnose as like fibroma, pyogenic granuloma.
That is fine. If I have to differentiate between idiopathic this idiopathic gingival fibromatosis and orofacial granulomatosis, can you just just tell the differences between the two? How we can clinically differentiate between the two? Did the patient had lip swelling?
Ma'am, patient did not have any sort of lip swelling.
Okay. That's all from my side, Sumit sir.
Dr. Amrit Kumar, when I saw your histologic report, it was showing inflammatory gingival enlargement.
Yeah. Yes.
And your diagnosis is idiopathic fibromatosis.
Yeah.
So do they go along in your inflammatory?
Sir, actually, inflammatory gingival, I have diagnosed this as an idiopathic because patient had gone previous time surgeries also, and she was maintaining the oral hygiene in a very proper way. And 6 months ago, she has gone a surgery and she was on evaluation also. She was maintaining the oral hygiene, but then also the recurrence was going on.
If that is the case, then why is the presentation so inflammatory? Idiopathic enlargement is known to be very fibrous, very pink colored, leathery. But then your presentation is very different. You should have I think you should again relook at the diagnosis. Apart from this, I have a small suggestion that you should work on the quality of your photographs, especially when you make a presentation. Right?
Yes,
Thank you. Thank you so much.
Okay. Thank you, Dr. Amrit. We can now move on to the next presentation by Dr. P. Sai Chan.
Good morning, everyone. Myself, Dr. Sai Chan. I'll be presenting a case report on ridge augmentation using piezo, whether it is a marketing hype or clinical reality. Before going on to what is ridge augmentation and how ridge augmentation is performed, let us see why ridge augmentation is required. As we are very much aware that alveolar ridge resorption is a common phenomenon of tooth loss, it has been reported that 50% of the bone loss is seen in the first 12 months, among which 2/3 of it has been reported to be occur in the initial 2 to 3 months itself. So these defects of the maxilla and mandible after tooth loss often range from continuity defects to smaller localized losses of alveolar bone proper. These osseous defects after tooth loss often are the result of cancer, pathologic process, trauma, infection, or due to secondary edentulation and aging as a result of poor dental health. So Seibert in 1983 has classified these residual ridge deformities into 3 classes. Class 1 includes buccolingual loss of tissue or faciolingual loss of tissue with normal apicocornal ridge height. Class 2 refers to apicocornal loss of tissue with normal buccolingual ridge width. And class 3 is a combination type of defect where there is a loss of buccocornal tissue as well as loss of apicocornal tissue. So in order to correct these defects or deformities, ridge augmentation is a procedure which is done for replacing the lost bone of residual ridge by grafting either natural or synthetic material. This ridge augmentation has been proven highly effective in the reconstruction of jaw anatomy, restoring aesthetics, as well as providing biomechanical support for the placement of implants. So in order to make it possible to install dental implants, ridge augmentation is a procedure should be accomplished to increase the vertical bony dimension. A wide variety of grafting materials have been applied and clinically effective, including autografts, allografts, xenografts, and alloplasts. Autografts are those materials which are obtained from the same individual. These can be obtained from either extraoral sources or intraoral sources. Allografts include graft material that is obtained from another individual of the same species, such as freeze-dried bone allograft or demineralized freeze-dried bone allograft. Xenografts includes the graft material which is obtained from the another species, such as those derived from the bone mineral of animal origin or calcium phosphates, and alloplasts are those graft materials which are obtained synthetically, and examples include bioactive glass and polymers. A brief elaboration on autogenous bone grafts. Autogenous bone grafts are those which are harvested from the patient's own body. They are considered to be ideal because of its osteoconductive, osteoinductive, and osteogenetic potential. Also, the added benefit of autogenous bone graft is it can be easily procured and the risk of disease transfer is avoided. In the reconstruction of ridges, autogenous bone graft has been considered as the gold standard. This autogenous bone graft can be harvested from extraoral sources such as iliac crust or cranium, etc., and intraoral sources such as mandibular ramus, mandibular symphysis, or maxillary tuberosity. Here is a case report which was done in our department using mandibular symphysis as the source of autogenous block graft. A 25-year-old male patient came to our department with a chief complaint of missing tooth in his upper front region due to trauma from 1 year. On intraoral examination, it was reported that missing tooth was in relation to 2-2 with a buccolingual width at cervical level of 3.1 mm and at incisor level of 2.1 mm. Before explaining treatment procedure was explained to the patient and informed consent was obtained. Preoperative and postoperative photographs were taken for the analysis. In the photograph, it can be seen that the missing tooth was in relation to 2-2. After giving local anesthesia and elevating the full thickness mucoperiosteal flap in the region of 2-2, the bone deficiency can be appreciated. We have chosen mandibular symphysis as the donor site because of its added advantages than that of using ramus of the mandible. Here, after giving local anesthesia, intracircular incision was given and 2 vertical relieving incisions were given and full thickness mucoperiosteal flap is elevated. Using piezoelectric unit, osteotome was used to separate the bone, and the separated bone graft has been kept in hypotonic saline solution for preservation until it is incorporated at the recipient site. The donor site has been closed with a mixture of bone graft and PRF, and then sutures are placed for healing to occur. The recipient site, the obtained graft material is incorporated and the screws are placed for maintaining the stability of the graft material, and then sutures are placed. A period of 6 months has been prescribed for the healing to occur. After 6 months, the postoperative improvement in the buccolingual width of 6 mm at cervical position and width of 3 mm at incisor level was observed. We have used piezosurgical device because of its added advantages than other devices. This piezoelectric unit was developed by Tommaso Versillotti in 1988. It has advantages of selective cutting action, that is precise removal of bone can be obtained with requirement of less hand pressure and maintaining blood-less surgical field with less collateral tissue damage with better healing. Also, although the disadvantage of having residual reduction in the vital bone when compared with that of graft materials obtained through a bone scraper, piezoelectric surgical device has more benefit than that of other devices. Also, why chin or mandibular symphysis is chosen? Because of its ease of access than other areas such as mandibular ramus, and also it has provided good bone quality for localized repair, and also it is a corticocancellous nature of bone. Also, it has reported that post-operatively low morbidity and minimal graft resorption has been seen. Moving on to discussion, bone thickness gained through the use of autogenous block bone graft has been reported to be favorable in many studies. In a study by Kojeste et al. In 2012, it was investigated that bone gain in 1 or 2 patients and an average of 4.3 mm in the anterior maxilla was reported. Also, in a study by C.M. Mish et al. In 1997, surgical access to the symphysis has been described as being easier than that of the mandibular ramus. Shearlink and co-workers harvested block grafts from the iliac, ramus, and calvaria and used the grafts for the augmentation of large bone defects in the maxilla and mandible. But Boschlap et al. In 1990 has shown that intraoral harvested intramembranous bone grafts have an improved quality of bone with a shorter healing period when compared with that of extraorally harvested endochondral bone. Also, in a study by Hammocks et al., it was reported that corticocancellous nature bone harvested from the symphysis facilitate faster invascular growth, resulting in rapid integration. Furthermore, in a study by Mish et al. In 1995, experimental evidence has shown that grafts from the membranous bone show less resorption than endochondral bone due to early revascularization, better potential for incorporation in the maxillofacial region, and greater inductive capacity because of higher concentration of BMPs, that's bone morphogenic proteins and growth factors. Also, in a study by Schwartz, Erad et al. In 2002, it was reported that dense structure of the cortical portion of the graft offers improved implant stability and stress transmission upon implant loading. Regarding the use of piezoelectric unit, in a study by T.V. Erclotti et al. Has reported that micrometric vibration makes the instrument manageable and permit major interoperative control with a consequent increase in the safety, especially in anatomically difficult areas. Also, in a study by Mansoor Rehnama et al., it was reported that the oxygen molecules that are released during cutting action have an antiseptic effect, and the ultrasound vibration also stimulates cell metabolism, leading to faster regeneration and healing process. Coming on to limitations, a limitation of this case is the marginal bone loss measurement on the mesial and distal aspects owing to 2D imaging, and also post-operative morbidity of the mandibular bone harvesting was reported, which is mainly related to temporary or permanent neural disturbances involving inferior alveolar nerve and its branches. So upon concluding, autogenous block graft from the mandibular symphysis is a convenient source and provides dense quality rich reconstruction. Also, with the use of piezoelectric units, successful reconstruction of buccolingual width and apicocoronal height of alveolar ridge is achieved without any long-term complications. Thus, it can be confirmed that pitch augmentation using piezo is a clinical reality rather than considering it as a marketing hype. Thank you.
Dr. Saya, well, very nice presentation. But again, as said in the earlier presentation, the quality of the picture needs to be improved. And yeah, but no doubt it was a nice case. Can you just tell me about five thumb rule regarding the, when you take the bone graft from the parasymphysis region, autogenous bone graft from parasymphysis region. So 155 rule is there. Can you just tell about it?
It's not clear. Can you repeat the question, ma'am?
Am I audible, dear?
Yes, ma'am.
Yeah, there is 5 thumb rule is there. When you take the bone graft, autogenous bone graft from the parasymphysis region, there is 155 rule is there. Can you just elaborate on it?
Taking properties of the osteogenic, osteoconductive, and osteo.
No, dear, it's not related to that.
No, ma'am.
Okay, no issues. The second thing is, like, when you take the donor tissue, when you take the donor bone graft, so how, like, what you do, you just screw the autogenous bone graft to the recipient side, or you do some manipulations you do with the donor bone graft?
Here we have placed the donor graft direct to the recipient site, and then we screwed it, ma'am.
No, you do something with it. You need to do something with the donor side, because if you are taking it out through the piezotomes, then you need to do something with the bone graft. You need to round off the corners.
Yes, ma'am. Margin round off has been done, ma'am.
Yeah, that's the point. Yeah, yeah. That's from all from my side, Sumit sir.
So Dr. Sai, I have a few questions. First of all, why did you not use a particulate graft along with the block graft? Could you have done that? I think you could have filled up this.
We have seen studies where only placement of block bone graft has proven higher rich reconstruction procedures. Rich reconstruction has been seen. So we didn't include any particulate bone graft apart from the block bone graft here. So we also want to evaluate whether the block bone graft has a higher potential or.
No, I agree. But how do you manage the dead space here then? So naturally, it won't adapt properly to that recipient bed. So what happens to the dead space?
So to adapt it, we have placed the screw so that the stability has been maintained for the grafts here.
The screw will only stabilize it. It will not adapt it. You place a single screw, no?
Yes, sir. Yes, sir.
What screw you have used? What material?
I do not have idea on that, sir.
Could you have done also use a GTR membrane probably? Could you have done that?
No, sir. No.
Did you get primary closure after placing this?
Yes, sir.
So what kind of a flap design was used?
Undisplayed flap design, sir.
Huh?
Sir?
Which I didn't understand. Which one?
What kind of flap design, sir?
Yeah. At the recipient area, what kind of a flap design did you use?
I do not have idea on that, sir. Actually, this is a case done by my senior.
Right. Okay. Decent presentation. Thank you.
Okay. Thank you, Dr. Saichan. We can now move on to our next presentation by Dr. Subhradip Kayal.
Very good morning, everyone. I am Dr. Subhradip Kayal, and I am presenting a paper on restoring the pink aesthetics, a case report. Introduction: beauty lies in the eye of beholder, and in beauty, smile is a non-verbal communication and is a mean of socialization and attraction. The harmony of smile is attributable to a shape, color, and position of teeth in conjunction with gingival tissue. Excessive gingival pigmentation is a major aesthetic problem for many patients having a high smile line. Review of literature suggested oral melanin hyperpigmentation an aesthetic problem caused by a variety of local or systemic factors, including genetic factors, tobacco use, prolonged administration of certain drugs, such as anti-malarial agents and tricyclic antidepressant. The physiologic color of gingiva is due to the combination of different types of pigments like melanoid, carotene, reduced hemoglobin, soft keratin, and oxyhemoglobin. Hyperpigmentation of gingival tissues occurs when melanocytes deposit excessive amount of melanin concentrated mostly to the basal and suprabasal cell layers of the epithelium. Gingival color is not uniform and varies from person to person, and it has been observed that hyperpigmentation is normally found in individuals of African, East Asia, or Hispanic ethnicity. Although gingival hyperpigmentation per se is not a disorder or disease, it possesses an aesthetic challenge for an individual with gummy smile. Smile type: according to smile line, low smile line less than 75% of the clinical crown height or the maxillary incisors displayed. Average smile line 75% to 100% of clinical crown height or maxillary incisors displayed. High smile line about 2 mm of the contiguous maxillary gingiva is revealed. Tammet in 1960 proposed the following explanation for gingival pigmentation, and it depends on the intensity of the melanogenesis, depth of epithelial cornification, arrangement of gingival vascularity. Moreover, color variation may not be uniform and may exist as unilateral, bilateral, mottled, macular, or blotched, and may involve gingival papillae alone or extend throughout the gingiva onto other soft tissues. Score 0 is pink tissue, score 1 is mild light brown color, score 2 medium brown or blue-black tissue, score 3 is deep brown or blue-black tissue. Gingival melanin pigmentation index by Pal et al. In 1980-1982. Score 0, no pigmentation. Score 1, spotted pigmentation. Score 2, diffuse discrete pigmentation. Score 3 is diffuse continuous pigmentation. Alex Farnos in 1990 said that melanin deposits mainly in basal and suprabasal cell layers of the epithelium. Degree of pigmentation is attributed to the melanoblastic activity and density of melanophores in the gingiva. Now, case report: a 27-year-old male patient reported to Department of Periodontics, Guru Nanak Institute of Dental Sciences and Research, Panihati, with a chief complaint of poor appearance due to dark brown discoloration of front gum region. Patient observed the same the past 1 year. On examination, lips were competent. Intraoral finding of melanin pigmentation seen in maxillary and mandibular anterior region from premolar to premolar area. Melanin pigmentation was seen at attached gingiva, including papillae. Angles class 1 occlusion was seen. Mild stains and calculus were observed. Thus, it decided to perform a gingival depigmentation procedure. Treatment plan was complete oral prophylaxis, follow up on a 7-day after oral prophylaxis, gingival depigmentation using scalpel and bar. Materials required are mouth mirror, Burt Parker handle with 15 number blade, tapered Fisher diamond bar, local anesthesia, sterile gauge, metal suction tube, 2% povidone iron, periopack. Clinical procedure performed, thorough oral prophylaxis was done, follow up on the 7-day after oral prophylaxis. Blood investigation were performed. Bleeding time, clotting time, hemoglobin were checked. All were normal. Patient's consent was taken after explaining the outcome and possibility of recurrence in gingival depigment procedure. Infiltration given. Depigmentation was done using scalpel technique by using a 15 number blade, which was held parallel to a long axis of teeth. Procedure was started from mesial upper right first premolar up to a midline with combination of slicing with scraping. Minimal force was applied. Bleeding was controlled with sterile gauge or pressure pad. Now, bar technique for depigmentation with tapered Fisher diamond bar, revolving bar was used on the surface of pigmented gingiva, moved with feather-like strokes without giving any pressure. Procedure was started from mesial of left upper first premolar up to the midline. It was not kept at one place for a long time as it may result in thermal trauma and permanent harm to underlying tissue. Bleeding was controlled and checked for any pigmented area remained and removed it to prevent relapse. Bleeding was stopped by applying pressure. Removal of gingival melanin period should be performed cautiously, and adjacent teeth should be protected since inappropriate application may cause gingival recession, damage to anal periosteum and bone. Now, both the procedures were done on the same day, and patient recalled 7 days for follow-up. Surgical areas were covered, periodontal pack and post-operative instructions were given. Analgesics were prescribed. After 1 week, the pack was removed and surgical area was examined. Healing was uneventful and satisfactory. No post-surgical complications were encountered. In discussion part, oral pigmentation occurs in all races of humans. There are no significant differences in oral pigmentation between males and females. The intensity and distribution of pigmentation of oral mucosa may be variable, not only between races, but also between different individuals of same race and within the different areas of same mouth. Melanin pigmentation is frequently occurring by melanin deposition by active melanocytes located mainly in the basal layer of the oral epithelium. Pigmentations can be removed for aesthetic reasons. Different treatment modalities has been used for this aim. Selection or techniques for depigmentation of gingiva should be based on clinical experience, patient affordability, and individual preference. The process of healing in bar method is similar to the scalpel technique. It is known that the healing period for scalpel wounds is faster than other techniques. However, scalpel surgery causes unpleasant bleeding during and after surgery, and it is necessary to cause laminopropia of periodontal packs 7 to 10 days. It is safe, simple, and non-aggressive method which can be easily performed and readily repeated if necessary to eradicate any residual repigmentation. These techniques do not require any sophisticated equipment and hence economical. Pre- and post-surgical care is similar to that of scalpel technique. Extra care should be taken to control the speed and pressure of the bar so as to not cause unwanted abrasion or pitting of the tissue. Feather light brushing strokes with minimal pressure and copious saline irrigation should be used without holding the bar in one place to get excellent results. Conclusion: the depigmentation procedure was successful and patient was satisfied with the result. Though the initial results of depigmentation procedure was highly encouraging, there is a chance of repigmentation. This process may be attributed to the fact that active melanocytes from the adjacent pigmented tissue might migrate to the treated areas. Thus, we conclude that the procedures are simple, cost-effective, and less painful with minimal tissue loss. And above all, it causes less discomfort and is aesthetically acceptable to the patient. Thank you for listening.
Yes, Doc. I have one very simple question. That's about like, can you just throw some light on the reoccurrence of the pigmentation?
Yes, ma'am. If in the gingival depigmentation, there is seen that pigmentation also might occur again in some time because due to the migration of melanocytes from the adjacent tissues, ma'am. Also, in sometimes other factors like excessive sunlight exposure, hormonal any changes, genetic and ethnic factors. Also, these are other factors, ma'am.
Dr. Subhadip, you
So
can
you have a
on your
post-operative
video.
picture of. You have a post-operative picture
Yes, ma'am.
of this
I
case.
put a picture after 7 days, ma'am.
7 days. That's it.
Yes, ma'am.
If you're presenting a case report, you need to, have a post-operative picture of at least 4, 6, or 7 months, or like
Yes,
that.
ma'am. But due to lockdown and ma'am, due to COVID situation,
Okay.
I cannot take the picture, ma'am.
Okay, fine. So please.
You are a first year student?
Yes, sir. I'm first
What
year.
What are the other ways, modalities which you can use for gingival depigmentation?
Sir, other modalities like can use surgery, electrosurgery, and laser we can use, sir.
Which laser?
Sir, diode laser, sir.
Diode laser.
Diode lasers.
Do you think these techniques, these diodes and the electrocauteries, they offer any advantage over the scalpel or the
Sir, healing will be better, sir, in this method, sir. The laser method, or sir, in this method, sir.
Better as in faster?
Sir?
Better, you mean faster or uneventful? What do you mean by that?
Sir, uneventful, sir.
Uneventful healing.
Yes, sir.
Okay. So can you name any physiological conditions which lead to pathological conditions which lead to hyperpigmentation? Gingival hyperpigmentation?
Sir, excessive tobacco use, sir. If we use excessive tobacco physiological condition, it may lead to
pathological condition. I'm sorry if I said that. Pathological conditions. Can you name any? Right. Thank you, Dr. Subhadip. Thank you.
Thank you, Dr. Subhadip.
Yes,
we can now move to the last presentation of this session by Dr. Catherine Jean.
Greetings to one and all present here. The topic for my case presentation is gingival depigmentation with platelet concentrates, a Doppler study. Introduction. Aesthetics is one of the major causes of concern throughout the world, regardless of age, and hyperpigmentation of the oral cavity is one such cause of concern because the pigmentation is mostly confined in the anterior part of the oral cavity, giving it an unaesthetic appearance. So hyperpigmentation of the oral cavity is nothing but the excessive deposition of melanin by the melanocytes, which gives a black to brownish color discoloration. So this discoloration is not only confined to the oral cavity, but it is present throughout the body. And the prevalence of this is seen to be more in the African population compared to the Asian population. So the treatment for gingival hyperpigmentation is there are various techniques, but one of the best technique is the scalpel technique. So this uses a blade, and the superficial layer of the gingiva will be slowly scraped away, and the underlying tissue will be left exposed. So this exposed region will undergo secondary intention healing. In order to enhance the healing process, there are numerous materials that have been identified in the field of periodontics, and one such material is the platelet concentrates. So the use of platelet concentrates dates back to the year 1970, and from then on it was slowly evolving, and in the year 2000, Chaukran et al. Developed a material called as platelet-rich fibrin, which was again modified by the same person in the year 2014, and it was called as advanced platelet-rich fibrin, or APRF. So this material is said to be outstanding when compared to the other materials because it has the ability to enhance the soft tissue growth, release bone morphogenic protein, and also accelerate the vascularization process. So the concept of neovascularization and neogenesis can be assessed, or it can be diagnosed by various aids, and one such newly developed material is the Doppler ultrasonic flowmetry, which is a very non-invasive, simple yet an accurate test. So this uses the principle of recording high-frequency sound waves that have been produced by the moving red blood cells, and this will be captured by the Doppler ultrasound probe or a transducer, and it will be fed to the computer. So one of the highlighting feature of this technique is it will help in identifying the direction of the blood flow. So with all these known facts, the aim was compiled to compare and analyze wound healing after depigmentation procedure with and without platelet concentrates using Doppler ultrasonic flowmetry. After ethical clearance was obtained, the patients who came under the inclusion criteria were selected. That is, patients who were systemically healthy and fell under the age group of 20 to 30 years and who had the chief complaint of black gums were selected. So the exclusion criteria was gingival recession, thin gingival phenotype, patients who had the habit of smoking, and patients who were pregnant were all excluded from the study. So 2 patients were selected, one for each procedure. So both of them were told about the procedure in detail, and an informed consent was got signed from them. So both the patients fell under the scoring criteria according to Damat Gupta Oral Pigmentation Index. They were scored 3, that is mixed pink and brown or medium brown color oral pigmentation. So the the patients were divided as case 1 and case 2. In case 1, the patient was administered local anesthesia, and after which the number 15 blade was used, and the superficial layer of the gingiva was slowly removed along with a thin layer of connective tissue, and the underlying connective tissue was left bare. So this, once after achieving hemostasis, the periodontal dressing was placed over it, and the patient was asked to report back on the 4th and 8th day. So these are the pre-op picture, and this is the this picture was taken immediately after the surgery. So second case was similar to the first case. So after the superficial layer of the gingiva was removed, APRF that was prepared was placed over the denuded surface and it was sutured. So the APRF material was prepared by collecting 10 ml of blood from the patient, and it was centrifuged for about 1300 RPM for 8 minutes. So the end product was taken, it was split, and the gel form was squeezed, and it was made into a uniform thickness, and it was placed over the denuded surface and it was sutured. So this is the suturing technique, and it was done on the denuded surface. So at the end of 4th and 8th day, the patients were recalled and the ultrasonic Doppler flowmetric study was done. So at the 4th day, we could see that there was neovascularization that was evident in both the cases. Whereas at the end of 8th day, the neovascularization was very prominent in case 2 when compared to case 1. So there is this red structure that we see here is stating that the blood flow is towards the transducer, and the blue color spot is telling that the blood flow is away from the transducer. So these are the case photos. So these are the post-op picture which shows case 2. Case 2 shows better healing when compared to case 1, because case 1 had few erythematous areas at the end of 8th day. So the results, ultrasonic Doppler flowmetry showed significant difference in both the patients. In regards to neovascularization and wound healing, case 2 was better when compared to case 1. Discussion. This technique of gingival depigmentation usually leaves behind an exposed connective tissue layer. So in order to cover this area, this particular technique was followed. So APRF material was prepared and it was placed, and this particular region in which the APRF was placed was studied by Doppler flowmetry. So the use of APRF in this study can be justified by various evidences, such as Kobayashi et al. In the year 2016 used various platelet concentrates and found that APRF was best among them because it was able to give away growth factors for 10 days continuously. So with all these facts, we can be sure that the enhancement of the microvascularization will be able to take place, and this will guide the epithelial cells to migrate towards the surface and protect the uncovered wound area, and it will help in accelerating the wound healing. And according to Kual Devnath and Anirban Chatterjee in the year 2018, the use of PRF would be better when compared to the use of periodontal Copax. So this study by Dahiya R. et al. In the year 2019 used clinical histological evaluation of healing after PRF and Copac placement, and this study was very similar to our study, and it said that there was increased vascularization at the end of 5th day in patients who underwent PRF treatment, and another criteria was that patients who are in the PRF group had reduced pain after surgery when compared to the control group. So Doppler flowmetry is also gaining importance, and many authors are suggesting this in the field of periodontics because it is useful as a diagnostic tool. It can monitor and it can also give out prognosis for a treatment. And the most important thing is it can help in detecting early onset of pathologic alterations. So according to this study, there were a few limitations. That is, we used very small sample size, and there was no follow-up for long-term results because of various reasons. To conclude, we can say that the case that used APRF along with the depigmentation procedure had better neovascularization and wound healing properties when compared to the case which did not use APRF. Thank you.
So, ma'am, Sumit sir, you can begin the question answer session now.
Yeah, Dr. Catherine?
Yes, ma'am.
Yeah. Do we have any study which says that the growth factors can be released for 23 or 25 days or so?
I'm not sure, ma'am. I only saw the study that told that there will be release of growth factors for up to 10 days.
No, in the presentation, you have mentioned this study by Chatterjee sir.
Yes, ma'am. I mentioned the studies in which sir told that there was better wound healing property in the use of Copac. Instead of Copac, the use of PRF was
the growth factors needs to be growth factors can be released for how many days?
For up to 15 days, ma'am. In relation to PRF, platelet concentrates, it can be released for up to 10 to 15 days.
Okay, in the second case, you have sutured that APRF, right?
Yes, ma'am.
So which suturing material you used?
Trio silk, ma'am.
You can have used other suture materials apart from silk.
Yes,
would have got a better healing proportions. So?
Yes, ma'am.
Well, that's all from my side. Sumit sir, please.
It was a nice topic and a nice presentation. Why did you not do any baseline measurements for Doppler flowmetry?
I don't know, sir. We only thought of taking it after the surgery. We could have done it, sir.
And is there, so the interpretations seem to me to be subjective. Is there any way of quantifying the changes?
Yes, sir, we could have done a graphical method, but we weren't able to do it at the last minute because we only did this study by 1 or 2 weeks before the recordings, so we couldn't pressurize them to give out all the results. So we could have done we could have gone for a graphical presentation, but we are planning to go ahead for a longer study population. So we are waiting.
What is the principle of this Doppler flowmetry?
So here we use the ultrasonic Doppler flowmetry. So here this uses the principle of capturing the ultrasonic sound waves that will be produced in the moving blood vasculature. That is, it will be able to collect the sounds that are produced from the RBCs, and it will be able to picturize them. So it can it not only gives the picturization of the blood flow, but it also can give the direction, as well as it can differentiate between the arteries and vessels.
Right. Thank you, Dr. Khan. Thank you. Nice presentation.
Thank
you, Dr. Chalu, for being such a gracious co-judge. Thank you to the organizers also.
Thank you, Dr. Catherine. And I also extend my thanks to Dr. Shalu Vatla ma'am and Dr. Sumit Malhotra sir for chairing this session and being a part of this first ever virtual. Thank you, ma'am. Thank you, sir.
Good afternoon, sir.
Good afternoon, Shalu. How are you?
I'm good, sir. I'm good, sir.
Good. And Shailendra is also there, HOD of college. And how are you, Dr. Sumit?
Hello, ma'am.
Right, sir. Fine, sir. How are you doing?
I'm doing fine. I'm doing absolutely fine.
Nice
Chal
to see
raha hai bas. Nice to see you in this pandemic. All our faces after a long time. Hopefully, we meet virtually in Pune with the conference.
Really hope so, sir.
Okay. Thank you. Thank you, Shalu. Thank you, Shalu. Thank you. Bye.
Okay, sir. Bye.
So now we will start with our sixth session. Let me introduce to the chairperson of this session, Dr. Anirban Chatterjee sir. He is former vice principal and professor of head of department periodontics, the Oxford Dental College and Hospital, Bangalore, and he is the president-elect for the Indian Society of Periodontology for the year 2022. Along with him is Dr. Shailendra Singh Chaturvedi sir. He is professor and head of New Horizon Dental College and Research Institute, Bilaspur, Chhattisgarh. Well, welcome you, sir.
Hello.
Sir, we can
thank
start
you.
with.
Yeah, please start with the first session.
Yes, sir. The first presenter is Dr. Trupti Naikodi.
Hello, greetings to respected judges. The topic of my case report is today a multiple implant placement with immediate loading in chronic periodontitis case. Now, this patient Nandini, aged 30, female, graduate, came with a chief complaint of loosening of teeth in the lower front and back region of the jaw since 6 months. The history of present illness was as follows. The patient was apparently all right 6 months back until she noticed loosening of teeth in the lower front and back region of the jaw. There was bleeding associated with it. There were no other harmful factors. There were no any relevant medical and family history. The oral hygiene method that she followed was brushing technique was horizontal technique. Dentifrice used was Colgate. Frequency was sometimes and not everyday brushing, and tongue cleaning was not performed. On intraoral examination, it was observed that grade 3 tooth mobility was seen with the respective teeth, that is 31, 33, 34, 35, 41, 43, and 45. The class 1 malocclusion with maxillary protrusion was seen. Plaque was present. Calculus, both supra and subgingival calculus was present. Proximal contacts, spacing was seen between the maxillary and mandibular anteriors, that is between 1-1 and 1-2, 3-1, 3-3, and 3-4, 3-5, 3-7, 4-1, 4-3, 4-5, and 4-7. Coming to the gingival examination, in the maxillary jaw, as you see, the color of the gingiva was pink, the consistency was soft, suppuration was present, size was grade 2, stippling was absent, and suppuration was present as seen in region with 1-1 and 2-1. The position of the gingiva was apical to CJ with 1-1, 1-2, 1-3, 2-1, 2-2, and 2-3. Enlargement was seen between 1-1 and 1-2. Coming to the mandibular region, the color of the gingiva was red, the consistency was soft, the position was apical to CJ in 3-1, 3-3, 3-4, 4-1, 4-3, and 4-4 region. The size was grade 2 enlargement seed, and stippling was absent and bleeding was present. Coming to the occlusal view of maxillary and mandibular region, as you see, root pieces were seen with 1-6 and 4-6, and there was tooth malpositioning observed with 1-1 and 1-5. There were missing teeth that were 3-6, 3-2, 4-2, and 4-4. On periodontal examination, it was observed that there were 6 mm pockets present with 1-4, 1-5, and 1-6. Pathological migration was seen with 1-1, 1-5, and 1-6. Recession, class 1 recession was seen with 1-1, 1-2, 1-3, 2-1, 2-2, and 2-3. Class 3 with 3-3-1, 3-3, 3-4, 4-1, 4-3, and 4-4. Coming to the etiological factors, the local etiologic factors that were present were plaque, calculus, improper brushing technique, and poor oral hygiene maintenance. Investigations were done, and it was found that complete blood count, bleeding time, clotting time, and random blood sugar were done, which were in normal range. Finally, coming to the diagnosis, we come to the diagnosis as generalized chronic severe periodontitis. Coming to the prognosis of the teeth, it was fair for overall prognosis, whereas for individual prognosis, tooth prognosis, we see it was fair for 1-1, 1-2, 1-3, 1-4, 1-5, 1-6, 2-1, 2-2, 2-3, 2-4, 2-5, and 2-6. And it was hopeless in the lower anterior region, which was the concern, that is 3-1, 3-3, 3-4, 3-5, 4-1, 4-3, 4-5, 4-6, and 2-6. Now coming to the treatment plan options, and that was performed. First, the non-surgical phase was performed, in which patient was advised scaling and root planing. An extraction of root pieces and mobile teeth under antibiotic coverage was done, of the hopeless teeth also, like the root pieces. Then patient was advised modified Bass technique for brushing, and soft toothbrush was given to the patient. Patient was also advised to brush twice daily and clean the tongue with a tongue cleaner. Patient was advised for excavation and restoration of caries in 3-7, 3-8, 4-7, and 4-8. Patient was recalled for follow-up after 7 days to check for mobility and reduction in inflammation and pockets. Coming to surgical phase, after evaluation of the phase 1, there were residual pockets which were observed in the first quadrant. Hence, periodontal flap surgery was performed along with excision of the enlargement that was seen between 1-1 and 1-2. And finally, the patient was recalled after 7 days for the suture removal and seen for the healing, and if there was any other inflammation remaining around in the upper jaw, that is the maxillary jaw. Then the patient was advised CBCT, and implant planning was done for the mandibular arch where the teeth were extracted, as there were many teeth missing now. Then implant planning was done, and 5 implants, that is of Alpha Bio implants, were placed with a temporary immediate denture was prepared with the help of a plastic casting abutments, and it was placed on the very same day. The patient was then recalled after 7 days again to see for any discomfort or occlusal dysfunction. Then after 3 months, the patient was recalled, and the temporary denture was now replaced with permanent PFM metal bridge. The occlusion was checked for high points, and the patient was recalled after 10 days to check for any discomfort. Thank you. This is for the case.
I may invite Dr. Anban sir and Dr. Salendra sir to chairperson to chair this session.
Yeah, doctor, after how many days, you told it's immediate implant placement, after how many days of extraction did you place the implants?
So after 1 month of extraction.
But it can't be immediate placement then. Immediate placement is within maximum 48 hours.
So I meant immediate loading of implants. I mean immediate loading of dentures, sir, sorry.
But it was not mentioned
the
in the title.
denture was loaded that day when the implants were placed.
No, correct. But what your title says is immediate loading. That means you have placed this one immediate you have done. So do you think, okay, let me take it in the other way. Then 1 month later you have placed the implants. Do you think 1 month is sufficient enough to place the implants after extraction? You have not done immediate placement of implant. You have done after 1 month. Yes, so what is the regular time you need to wait for proper placement?
So for that, we would first see the actually the periodontal health status as this in this patient. We would see the
No. Here there is no question of periodontal health status now because already extraction is done. What I mean to say is you have told that you have placed it 1 month after the extraction, right? The implants, correct? So do you place an implant after 1 month or you place the implant after 3 months or 4 months after extraction is my question. Can you quote any studies where it says that within 1 month you can place?
So I actually don't remember a study, but I had read about this, so we could do it. And
okay, Shailendra. Shailendra?
Am I audible, Tripti?
Yeah.
Hello, sir.
Yeah, you're audible.
I'm audible?
Yeah, you're audible.
Okay,
Please ask.
Doctor. Okay. Doctor, tell me one thing. What is the classification as per the new class diagnosis of this patient as per the new classification? Did you understood? Have you read new classification?
yes, sir, the new
What is
classification.
the diagnosis as per the new classification? No problem. Acha, you have placed implants. So, what is the prevalence rate of peri-implantitis in such cases?
So there is a possibility of peri-implantitis in such cases because of the periodontal health status that was earlier being affected. But then because of supportive periodontal therapy, we can always keep on
What
recalling
is that
and
rate,
maintaining.
prevalence rate?
So one place I had read, I can't be sure of.
Okay, that's it. Good. Anyway, carry on. Okay, sir. Next. Thanks, Dr. Tripti.
Thank you, Dr. Trupti. We can have the next presentation now.
Yeah.
Good afternoon, everyone. The title of my paper presentation is Root Coverage Amulet to Beautiful Smile. Coming to introduction, root coverage is a periodontal plastic surgery procedure have long been used for treatment of gingival recession. The increasing aesthetic demands from the patient has compelled that the clinicians sharpen their skills and adopt newer and more novel techniques to satisfy these demands. The common etiological factors of gingival recession are local factors such as plaque, calculus, etc., periodontal diseases, mechanical factors such as aggressive tooth brushing, iatrogenic factors like orthodontic tooth movements, anatomic factors such as dehiscence, fenestration, a narrow band of keratinized gingiva, aberrant frenal attachment, etc., play an important role. Concomitant to development of flap and graft tissue-based surgical techniques, more refined and judicious treatment strategies have been developed and applied so as to establish good predictability and better clinical scenarios. Connective tissue graft technique is the most commonly used free soft tissue graft, showing predictable and reproducible results in root coverage. Thus, it is considerable as a gold standard, though it has its own limitation, which include the need of second surgical site and technique-sensitive procedures. Minimally invasive surgery has been harnessed in periodontics for root coverage and has been used extensively, such as modified vestibular incision subperiosteal tunnel access applies the principle of minimally invasive surgery to provide satisfactory results in root coverage. Coming to case report, a male patient aged 25 years visited the Department of Periodontology with the chief complaint of residing gums in relation to maxillary anterior tooth. On clinical examination, Miller's class 1 defect in relation to maxillary right central incisor and Miller's class 1 defect of 2 mm in relation to maxillary left central incisor was noted. Coming to treatment plan, considering the patient concern about his aesthetics, root coverage procedure was planned. Patient was in the good general health and bled Blood investigation, medical history showed no contraindication for the surgery. After obtaining written informed consent, vestibular incision subperiosteal tunnel access technique with connective tissue graft was planned for root coverage. Phase 1. The initial preparation of the recipient teeth included thorough scaling and root planing. About 2 ml of anesthetic solution was administered as infiltration. Coming to surgical phase, in the VISTA approach, a vertical access incision was made using number 15 blade close to the midline frenum. The incision was made through the periosteum so as to facilitate elevation of subperiosteal tunnel and exposure of facial and osseous plate. The microsurgical periosteal elevator 1 and 2 was used to create the subperiosteal tunnel, and it was extended 1 or 2 teeth beyond the teeth being treated to mobilize the gingival margin and facilitate coronal repositioning using microsurgical periosteal elevator 3 and 4. The subperiosteal tunnel was extended well beyond the mucogingival margin so as to allow low tension coronal repositioning of the gingiva. The tunnel elevation was extended interproximally under each papilla as far as the embrasure space permits, without making any surface incisions through the papilla. The connective tissue graft was then harvested using trapdoor technique from the premolar molar areas of the palate. The retrieved connective tissue was placed at the site through tunnel. The vertical incision was approximated and sutured. The anchor suture were fixed onto the mid-coronal point of the facial surfaces of affected teeth so as to facilitate low-tension coronal repositioning of gingival margin with flowable composite resin. Post-operatively, patient was prescribed with NSAIDs for pain management and maintenance with 0.12% solution of chlorhexidine rinsing 1 minute thrice daily for 14 days. Patient was recalled after 1 week. This is the post-operative picture of 1 week. The coronally anchored bonded sutures were removed. Post-operative picture 1 month. It shows clear healing, satisfactory healing. Post-operative picture 4 month. The healing is satisfactory. Marginal tissue is free of inflammation, and the marginal gingiva is stable. Coming to discussion, gingival recession is considered a mucogingival condition that can constitute important aesthetic and functional problems. The significance of any marginal tissue recession may vary considerably depending on the etiology, extent, and associated symptoms. Gingival recession defects present clinician with the significant therapeutic challenges, including restoration of protective anatomy of the mucogingival complex, re-establishment of the aesthetic balance between soft tissue and adjacent tooth structure, and ideally, regeneration of lost cementum, periodontal ligament, and supportive alveolar bone. Vista is a modified coronally advanced flap introduced by Zeta et al. In 2011 for coverage of class 1 multiple maxillary recession defects. This technique was further reinforced by PRF membrane for the treatment of class 1 and class 2 recession defects by Reddy et al. And Chatterjee et al. In 2013 and 14 respectively. Vista with connective tissue graft was introduced by Reddy et al. In 2016. The minimally invasive VISTA approach combined with connective tissue graft has a number of advantages for the successful treatment of multiple recession defects. In present case report, VISTA technique with connective tissue graft prevented relapse in earlier stages of healing and gave better results. Coming to conclusion, various treatment options exist for the treatment of gingival recession. However, the treatment of multiple gingival recession is always a greater challenge compared to single recession defects. Hence, VISTA technique with connective tissue graft is aimed to overcome the shortcomings of other treatment options and shown to give better results. Thank you.
Dr. Ume, it is only one-off case, right?
Yes, sir.
How much was the loss of bone, tissue loss?
In relation to maxillary right central incisor, it was 3 sir.
After you finished, how much was the thing?
So only 1 mm of marginal tissue gain was there. So
1
in
mm.
addition to 2-1, there was
Not
2
much
mm
of a defect was still persisting, correct? So did you feel any, only one case you have done, right? Why didn't you try PRF? Why didn't you try PRF instead of connective tissue? Because connective tissue, again, you have to injure another area, correct?
Yes,
So why didn't you take
this was
PRF? It
my
is a
first
simple way
case,
of doing, no?
yes, sir. This was my first case, sir. Actually, I am in first year now. I will be doing it further in my course.
No. I'm just asking you, why didn't you use PRF? Is it your dissertation study?
No, sir.
Not dissertation study.
No, sir.
Okay, because what I'm trying to ask you is, why didn't you use PRF instead of connective tissue? Because PRF is easier to access, and you did not have to again take connective tissue and make another injury to the palate on the area. That's the thing. And color matching also will be little. If you can see, after 4 months there is a margin of mark which is little different from the actual gingiva. Okay, fine enough. Anyway, Shailen, pucho.
Hello, doctor.
Sir,
Yeah. What is the ideal thickness of graft?
sir, sir, 2 mm. I'm not sure about it.
Okay. Okay, that's it. Chalo, good. Next, Mishra ji, next.
Yes, sir. Thank you, Dr. Rome. We can now move on to the next presentation by Dr. Lata Goyal.
Good morning, everyone. I'm Dr. Lata Goyal, Assistant Professor in All India Institute of Medical Sciences, Bhatinda. Today, I'm presenting case series on treatment of gingival recession associated with cervical abrasion. The association between presence of gingival recession and non-carious cervical lesion is a common finding in industry. And although traditionally majority of the professionals they treat non-carious cervical lesion only with conventional restorative procedure, and in the most cases we recommend combination of periodontal and restorative procedures. They provide the best aesthetic and functional outcome. So objective of this case series is to present different treatment modalities for management of gingival recession associated with non-carious cervical lesion, which is more patient-oriented.
Doctor, can you be little loud?
In this case series, I'm presenting 9 cases. 3 has been treated by coronally advanced flap, 3 with coronally advanced flap.
Dr. Lata, can you be little loud?
2 cases along with platelet-rich fibrin. In the first 3 cases, the treatment modality uses coronally advanced flap. You can see that in case 1, we have considered 2, 3, and 2, 4.
Sir, this is the maximum
in
volume.
The relative gingival recession, like from the incisor ledge to gingival margin, that was 15 mm, and in 2, 4, it was 13 mm. Gingival biotype of the patient was satisfactory. It was thick, and the coronally advanced flap has been performed. It was like horizontal incision, and then that from the line angle releasing incision was given. Full thickness flap was reflected till mucogingival junction, and then from the mucal junction it was released till it is a passive flap, and deepithelialization of the split papilla was done. Flap was coronally advanced in suture. This is immediately during the suture removal, and this is a 6-month post-op. We have gained 3 mm in case of canine, and in case of premolar, we have gained 2 mm. Earlier it was 15 mm, and here it was 11 mm. And in this particular, it was 13 mm, and post-op it is 11 mm. Patient's chief complaint was sensitivity. From the VAS scale, VAS score, it has been from 8 to 3. The patient's sensitivity, complaint of sensitivity was chiefly addressed. In case 2, there was 2 mandibular premolars, that is the right first premolar and the right lower second premolar. Same procedure has been done. There is decrease in the gingival recession, 1 mm in both the premolars. The simple coronally advanced flap has been done without any kind of restoration. In this case, also gingival biotype was favorable. This is the 3rd case where the chief complaint of the patient was sensitivity. Relative gingival recession was 11 mm, and here is the relatively gingival recession is 10 mm. We have gained 1 mm in post-op of 6 months. Second treatment modality is coronally advanced flap with restoration. In the first case, relative gingival recession is 12 mm, which has been constantly restored with the resin modified GIC restoration. The depth of the gingival recession here, the depth of non-curious cervical lesion was more than 0.5. In the similar method, coronally advanced flap has been performed, and the flap was sutured, and this is a pre-op and this is a post-op. We have gained 2 mm post-op 6 months. Here the relative gingival recession is 10 mm, and here the relative gingival recession was 12 mm. You can see that there is 100% root coverage in this particular case. In the case 2, it is upper premolar relative gingival recession is 11 mm, and we have gained 1 mm. This is a post-op 1 year. In case 3, the patient concern was sensitivity. In this case, canine, premolar, and molar has been managed by gingival recession by restoring the tooth with resin modified GIC restoration, and coronally advanced flap has been performed. There is a gain of 2 mm here, post-op, gain of 2 mm in the premolar, and gain of 1 mm in the second premolar. Then the third treatment modality was coronary advanced flap with restoration with platelet-rich fibrin. This is the first case. Relative gingival recession was 12 mm. You can see the depth of the defect was more than 0.5. It was restored with resin-modified GIC restoration. Platelet-rich fibrin was prepared. It was applied on the recession defect. And this is the pre-op and the post-op of the patient. We have gained considerably 2 mm. Patient chief complaint was elongated tooth as well as sensitivity, which has been post-oply very well taken care of. In the case 2, also it has been performed in the similar manner, tooth taken into account as of both premolars, and you can appreciate this is a pre-op and this is a post-op. It is case 3. Here the relative gingival recession was 13 mm. We have gained 3 mm in case of canine, and in case of first premolar it was 1 mm. Patients also here, the chief complaint was sensitivity as well as elongated tooth, and patient was aesthetically as well as from the sensitivity point of view, he was satisfied. Etiology of the non-curious cervical lesion that has been discussed extensively in the literature, and clinicians should consider all the etiological and modifying factors before completing the diagnosis and initiating treatment. The first treatment step should be elimination and control of all potential etiological factors which is associated with the occurrence of gingival recession and non-curious cervical lesion. Detailed clinical examination is of paramount importance for the identification of gingival inflammation, periodontal disease, traumatic toothbrushing, excessive consumption of acidic beverages. What is the importance of restoration in these kind of procedure? It reduces the stress concentration, decrease of fraction progression, prevent pulpal involvement, eliminate biocorrosion of enamel, prevent fracture, root caries, eliminate cervical sensitivity, and provide aesthetic comfort. When just a non-curious cervical lesion is treated with restorative procedure, the position of the gingival zenith is more apical because of persistence of gingival recession, which lead to a longer tooth and consequently a possible aesthetic disharmony. Moreover, it doesn't improve the width and the length of keratinized tissue, so mucogingival therapy is recommended as additional periodontal treatment. Surgical procedure alone, that will not be enough to rehabilitate the patient because depth of the cervical lesion, it will not allow adequate root planning, and it will not resolve any biomechanical problems which could influence the final result of the tooth. So here we advocate either treatment for the combination of the non-curious cervical lesion and gingival recession should be combined approach. Factors which affect the root coverage, width and height of recession, biotype of the gingival tissue, type of surgical technique used, and smoking status. Type of surgical technique, most of studies, they have considered connective tissue graft. It has been considered the gold standard. In here we have used platelet-rich fibrin as compared to connective tissue graft. It is also shown good results in terms of root coverage, and it also prevents the second surgical site, which is more patient friendly. So, to conclude, the combination of restorative and surgical protocol is important for full rehabilitation of non-carrier cervical lesion, particularly in case of deep lesion, when the damage affects both the tissue and the periodontal structure. Thank you. Hello. Good afternoon, sir.
Yeah. Shailendra, pucho.
Yeah. Doctor, can you tell me some indications of root coverage?
Indication of root coverage. So root coverage primarily depends upon either the patient concerns, like if patient says there is any symptomatic treatment like sensitivity is there, or you can say that elongation to aesthetic is a major concern for the patient, or sometimes it is difficult to maintain the oral hygiene of the patient. In these particular cases, like in cervical caries and something, if we not restore, if we no root coverage, then it can progress further. So there are different indications depending upon the patient's concern as well as periodontal structures.
What is the best option for root coverage?
Best option means the best procedure or
suited to as per the case, what you have done.
Sir, personally, I advocate among the groups that if the carrier cervical lesion is not deep enough, then we should go only for the perio treatment. We should not go for the restoration. But if the carious lesion is deep enough, then we should do restoration, and restoration should be followed by the periodontal treatment.
Okay. Yes, sir.
Yeah. Lata, good case. But what was, you have used PRF, right?
Yes, sir.
What was the centrifugation you used?
So centrifugation, I have used 3000 RPM on 10 minutes.
10 minutes. And
Yes.
did you use a horizontal centrifugation or vertical centrifugation?
Sir, we have angled rotor basically.
Okay. Which company?
Yes.
Remy?
Remy company, yes, sir.
Achha. Okay.
Yes.
Okay, fine. So, how much time did you take? Did you find any difference between a female patient and a male patient when you drew the blood, means the quantity of the PRF?
So no, sir. Particularly, I didn't notice anything.
Okay. Usually, the length of in a female patient will be 17% more than a male patient. Next time, if you can observe, as per Miron et al. And what was the time from the drawing the blood and starting the centrifugation?
Sir, immediate.
Immediate. Within
Yes.
1 minute?
Yes, sir, within 1 minute. We normally, we have a tabletop centrifuge and
Fine.
beside the chair.
Fine. Okay, thank you very much. Thank you. Nice presentation.
Thank you.
Thank you, Dr. Lata ma'am, for your presentation.
Thank you, sir.
Now we can move on to our next presentation by Dr. Sriharsha.
The title for today's presentation is 4I8 in parietal wound healing after pre-gingival graft, a case series. Starting with the introduction, adequate attached gingiva is required for maintaining periodontal health and optimal oral hygiene. Gingival thickness plays a very important role for long-term stability of the periodontium. In fact, gingival thickness plays an important role in preventing the recurrence of recession. A pre-gingival graft is an autogenous soft tissue graft that is extremely used and is accepted as a predictable method for treating mucogingival problems such as inadequate attached gingiva and gingival recession defects. Parietal region is usually the most preferred donor site in terms of anatomical advantage, ideal tissue thickness, and wide keratinized tissue. Despite the promising outcomes of pre-gingival graft, prevent surgeons and patients from choosing it for its post-operative discomfort. The surgical wound usually heals by secondary intention within 2 to 4 weeks and has been considered associating with post-operative discomfort for the patients due to painful wound and bleeding, which could lead to eating and speaking impairment during healing course. So the objective of this study is to evaluate the efficacy of post-operative morbidity and safety of an intraoral dressing ORA8 after pre-gingival harvest from the palate. Moving on to the materials and methods. Patient recruitment. A total of 4 subjects, 2 males and 2 females, age range between 20 to 50 years, diagnosed with mucogingival deformities or insufficient keratinized tissue around natural teeth, participated in the study. Patients with any uncontrolled local or systemic disease where periodontal plastic surgery might be contraindicated, and smokers were excluded from the study. All subjects received a Holly's appliance for better stabilization of the ORA8. Moving on to the first case of the clinical case series, here we can see the adequacy of attached gingiva, which is minimal, and also we can see a class 1 Miller's class 1 gingival recession with respect to the lower anteriors. And here a recipient from the after preparing the recipient site by giving a split thickness incision, A periosteal bed is prepared. After preparation of the periosteal bed, a free-gingival graft harvested from the palate, and after harvesting the free-gingival graft, we can see the raw wound surface on the palate. Now this raw wound surface is covered with the help of the ora-8 bandage. As you can see, the ora-8 bandage, the outline of the ora-8 bandage, which is covering the raw wound. Now, for stabilization of this ora-8 bandage, a Hollis appliance is usually used, and this is the post-op 2-week post-op image of the recipient site and the parietal donor site, which shows complete wound epithelialization after 2 weeks. This is another case wherein we can see the thin parental biotype with respect to the lower antigens. Same procedure was carried out. The split thickness incision was given and the periosteal bed was prepared. Now FGG was a free-gingival graft was harvested from the palate, and we can see the raw wound surface, which is being covered by ora-8 measuring 25 into 15 mm. Now this ora-8 is stabilized with the help of an Hollis appliance, and this is a 2-week post-op image of the complete wound epithelialization which can be seen in the palate. And this is a 2-week post-op image of the recipient site wherein we can see the increased amount of attached gingiva with the lower anterior tooth. The post-operative care, the patients were instructed to wear the stent in the first 24 hours without removing it. From 24 hours to 1 week, the patients were allowed to remove the stents carefully only for cleaning purpose. And in the second week, the stents were only installed during meals to prevent the friction from the foot to palate while eating. Now, the patient returned to normal life and did not wear the appliance for 2 weeks from the surgery. Now, for patients with no known drug allergy, they were prescribed with ibuprofen 400 mg as and when required and fluoxetine 0.12% mouth rinse twice daily for 14 days. The clinical parameters which were evaluated in this study were the wound healing index of Landry, Turnbull, and Howley, and wound epithelialization using the Ketley's test, wherein 3% hydrogen peroxide was used in this wound epithelialization test at the end of 7th, 14th, and 21st day. Now, also visual analog scale was used to assess the post-operative pain with no pain as 0 and to worst pain as 10 in the scores for 1 week. And also the number of analgesics taken as and when required were also noted using patient feedback forms. Moving on to the results of the study, all 4 subjects completed the study by attending the surgery and had completed the follow-up without any complications in the treatment or the surgical procedures or any of the follow-up. At 7-day follow-up, the palatal surgical wound was filled with granulation tissue, which is interpreted as poor with a score of 2 in wound healing index. And at the end of 14 days, there was no granulation tissue or suppuration of bleeding in the site, which is interpreted as very good with a score of 4 in wound healing index. Now, the wound healing test showed positive, that is bubbling at the site when 3% hydrogen peroxide was applied at the end of 7th day as well as on the 14th day, and it was negative on 21st day. Bubbling was not seen, which implies complete wound epithelialization at the end of 21st day. All subjects reported minimal post-operative pain from the donor sites, and the average scores being here 6 in the first 2 days of post-surgery, which reduced to 0 by the end of 4th day. Now, 3 subjects in this study took analgesics continuously twice daily till 3rd day, and 1 subject continued till 4th day. Moving on to discussion, post-operative pain and bleeding are the 2 most common complications following epithelial layer included free soft tissue graft harvesting from the parietal donor site. Collagen, gelatin sponge, platelet fibrin are commonly used dressing materials. However, these dressing materials require an additional surgical time to secure the materials with sutures. The main content of ora-8 used in this study is hydroxyethyl cellulose. Now, for wound healing, these hydrogels have been applied owing to its safety, high capacity of absorption of physiological exudates from the wounds, providing them a moisture balance and enhances the wound healing. Now, the employment of these hydrogels in wound dressings include the antibacterial activity, and also they can control the exudate of the wound and inhibit the bacterial growth as well as the existence at the wounded spot for a long period of time. With this, I would like to conclude by saying that this novel intraoral dressing provides the patient a nearly painless healing experience, protects the palate wound by covering it, and also guides the tissue growth to its original appearance. Thank you.
Shailendra.
Yeah. Hello. Hello, Dr. Harsha. Can you talk about creeping attachment?
Creeping attachment usually seen after the
You are not audible, Harsha.
Sir, am I audible now?
Yeah, please speak loudly.
Yes, sir. The creeping attachment is usually seen after usually after two months of the procedure. Maybe it usually up to 0.5 mm of creeping attachment is seen in the gingival margin.
Okay, what is the principle of working of ORAED?
Sir, it's an intraoral bandage, sir. It sticks onto the surface and it mainly consists of hydroxyethyl cellulose and also vitamin E. So this hydroxyethyl cellulose has shown in vitro studies have shown that they have this antibacterial effect and also helps in hastening the wound healing, fastening the wound healing. And also this captures the transudate which is released from the raw wound surface. So this transudate which consists of all the initial inflammatory cells, they are contained in that spot. So the healing is faster.
Okay. How many cases you have done?
Sir, actually this is an ongoing study, sir. Right now around 12 cases have been done, sir. In comparing with the control group, that is a normal gel sponge.
It's your dissertation?
No, sir. It's a short study.
Okay, okay. Yes, sir.
What is the difference between cyanoacrylate and this oral aid? Could have used cyanoacrylate, right? I
Yes,
just
sir.
want
Cyanoacrylate also could have been used, sir. And sir, also flowable composite also.
no, that is fine. But I'm just asking why instead of ORAED, means what is better, ORAED or cyanoacrylate is what I'm trying to ask.
Done. I'll check, sir. We haven't done any using cyanoacrylate.
But you have heard about cyanoacrylate, right?
Yes, sir. Yes, sir.
For wound closure and everything.
Yes, sir. Even sutureless HGT also.
Yes, exactly. That's what I'm trying to tell you.
Yes,
okay, fine. Thank you.
Thank you, Dr. Harsha.
I think this is the last, after the last one, no?
Yes, sir. We are moving on to the last presentation of this session. The presenter, Dr. Prerna Pandey.
Good afternoon, everyone. Today I am presenting paper on the topic effect of hyaluron and metronidazole gel in the management of chronic periodontitis. Hyaluronic acid is very much used in nowadays in periodontics. It is basically found in extracellular matrix of connective tissues, synovial fluid, and other tissues like skin. It is a key element in the soft periodontal tissues, gingiva, and periodontal ligament. Its properties like hygroscopic nature, viscoelastic properties, bacteriostatic, biocompatibility, anti-inflammatory, and antioxidant. These all properties makes it unique. The other uses of hyaluronic acid in dentistry are gingivitis, periodontal defects, swelling and trismus during immediate postoperative impacted third molar, wound healing, implant, and sinus lift procedures. Metronidazole gel, it is effective against P. gingivalis, prevortella intermedia, A. actinomycetocomatans, and can be used to treat NAC, chronic periodontitis, aggressive periodontitis. A local type of metronidazole gel present as gel that forms reverse hexagonal liquid crystals when come in contact with GCF. This can preserve the drug for longer duration by preventing the gel from the facial exit outside the pocket. Aims to find out the potential benefits of effect of metronidazole gel and hyaluronic gel on the clinical periodontal parameters. Criteria: 5 systemically healthy patients suffering from chronic generalized periodontitis are selected. Age should be between 33 to 51 and should have probing depth 5 to 8 mm in maxillary and mandibular posterior segment. Exclusion criteria includes systemic disease, chronic infections, smokers, alcohols, pregnant or lactating females, treatment with any medication such as antibiotics. Materials and methods. I have used hyaluronic gel and metronidazole gel. For hyaluronic gel, I have used Genji gel, that is of Recipharma Pharma company, and metronidazole gel includes metronidazole gel plus chlorhexidine gluconate, that is 20 gram tea in 1 tea. All the parameters of selected sites should be recorded. After that, scaling and route planning is carried out. Group A, application of 1 ml of 0.2% hyaluronic gel to the base. Group B, application of 1 ml metronidazole gel to the base of the pocket. And Group C only treated with scaling and root planning.
all the clinical parameters recording on day 0, that is baseline, and at the end of 1 week and 1 month. All the clinical parameters which needs to be recorded at plaque index, probing pocket depth, sulcus bleeding index, clinical attachment level. Result: 3 out of 5 patients showed only decrease in probing depth for both petrolidinol gel and hyaluronic acid gel after 1 week and after 1 month. All 5 patients have shown decrease in sulfur bleeding index, plaque index, and gain in clinical attachment level. Overall, this study analyzed the possible beneficial effects of hyaluronic acid and metronidazole gel as an additional local application during scaling and route planning on the clinical periodontal parameters. Further studies are needed for larger sample size. So this is the limitation of the study. Thank you.
What was the percentage, Prerna? What was the percentage of metronidazole?
Sir, it was 1.5% metronidazole and 0.5% chlorhexidine gluconate. It is a combined gel of metronidazole and chlorhexidine.
Okay.
That is Metrogel Denta.
Okay, but don't you think it's a combination of metronidazole plus chlorhexidine? It will be better effective than hyaluronic acid by itself?
Yes, sir. Yes, sir.
So then the comparison doesn't come into the being because it's 2 drugs against 1 drug, or not drug. I'll not tell hyaluronic acid as a drug, but it has been proved. But only 5 cases is too less a number.
Yes, sir. I have done till now only 5 cases. That's it.
No, I know, but what I'm trying to tell is to get to any conclusive statistical analysis also.
Yes.
It's too less a number.
Yes.
And how is the hyaluronic acid? How does it work?
Sir, it is basically found in extracellular matrix of connective tissue and PDL. So it the molecular part will bind to that tissue because it has a very highly viscoelastic and hygroscopic nature. It has a anti-inflammatory property also. So it binds to the tissue well, and it has been used nowadays in periodontal surgeries also.
Okay, fine. Shailendra,
hello, Prerna.
Yes, sir. Good afternoon, sir.
Good afternoon. Can you tell me the concentration of metronidazole in GCF?
Sorry, sir.
Can you tell me the concentration of metronidazole in GCF?
Sorry, sir.
That's it, sir. No problem. Best of luck.
Okay, thank you.
Thank you.
Okay.
So
thank you, Dr.
Amit,
Prerna.
thank you very much. Yeah, thank you very much for helping us sharing the session.
Yes,
Amit.
sir. Thank you so much,
Ashit,
sir.
sorry.
Yes, sir. Thank you so much, Anirban sir and Shailendra sir.
Okay. Mishra ji, namaskar.
Yes, sir. Sir, a gentle reminder to send the evaluation sheet to the mentioned email ID or WhatsApp.
Yeah. वो separate में भेजना है क्या मिश्रा जी?
Sir, either in the email or on the WhatsApp number, sir.
नहीं separate भेजना है दोनों का या दोनों का एक ही इसमें भेजना है?
No, separate, sir.
सर कहाँ से हो आप?
Sir, I am from Odisha, sir.
उड़ीसा के? अच्छा, वो अपने सुभाष के चले हो?
Yes, sir.
अच्छा, चलो मिलते हैं अगले साल.
Sir.
वहीं पे कॉन्फ्रेंस है ना?
Sir.
चलो.
Thank you so much, sir.
Bye,
Thank you, sir.
Okay. You can leave, right?
Yeah. Yes, sir. Now, with this, we have concluded the 4th session. We can now start with our 5th session. May I now introduce our chairperson for the 6th session, for the 5th session.
Hello, Dr. Asit. First to present and not yet joined.
First to presenter not yet joined. Also,
So we will
Prabhakar
start
sir
from
are also
third.
not joined. Prabhakar sir are also not joined. Dr. Prabhakar sir. Hello. Dr. Prabhakar sir.
Hello. There is a name in panelist 13X VAVAVE. What is your real name? Please tell.
I kindly request all the participants to rename their own rename their Zoom name to their own name.
Otherwise, we will unable to promote them to the panelist. 13X. If you hear me, please tell us your real name. I'm sending him back to the attendees. So Dr. Kavya Balan is not here.
Okay.
So we can skip and we can go to Dr. Saurabh Kumar.
Okay.
Yeah, please suggest.
Okay. Good afternoon. I may introduce the chairperson first for this fifth session. First is Dr. Prabhakar Rao. He is professor from Geetham Dental College, Visakhapatnam. Along with him is Dr. Anurupa Mahapatra. She is leader from SCV Government Dental College and Hospital, Odisha. Welcome, ma'am. Welcome, sir.
Good morning, Dr. Asit.
Good morning, ma'am. We can begin with the session. The first presenter is Dr. Saurabh Kumar.
Coming to presentation, as we all know, the gingiva is an uncalcified soft tissue structure of the periodontium. However, the calcification do occur in gingiva in certain pathological condition, as it is seen in the present case where the coexisting lesion of peripheral cemento-ossifying fibroma and osseous choriostoma was present in an isolated gingival enlargement. As the name suggests, choriostoma means some normal living tissue that is present at an abnormal location. As we all know, gingival enlargement is a frequent entity or observation associated with the multiple factors. According to etiology, it can be inflammatory enlargement, drug-induced enlargement, associated with a condition such as pregnancy, puberty, vitamin C deficiency, or certain systemic conditions such as leukemia, granulomatous disease. It can also be caused by benign tumors or malignant tumors. Now coming to the detail of the case, that is the peripheral cemento-ossifying fibroma with features of osseous choriostoma. A 23-year-old female patient reported in the department with a chief complaint of recurrent growth in lower right front tooth region. The lesion was extending from the mid-labial surface of lower right lateral incisor to the mid-labial surface of lower right canine. It is also extending on the lingual surface. On clinical examination, the lesion was pale pink, solitary, oval shape, pedunculated hard mass without any sign of ulceration or exudate. The dental history revealed recurrence was twice in last 4 years, which was managed by a local dentist. Soft tissue examination revealed the length and the width was 10 millimeter, and radiographically we can appreciate the bone loss in between 4.2 and 4.3. Now, after the complete clinical evaluation, blood investigation was done and excision of the lesion was planned using electrocautery. The electrode was taken care to be confined during excision into the gingiva only without involving the underlying bone. This was the excised specimen which was further sent for the histopathological examination. This was the clinical condition after excision. Now, to find out the probable etiology and to eliminate it, the full thickness flap reflection was done, and after that, complete debridement was done using the curate. Now, to proper eliminate and prevent reoccurrence, cauterization of inner side of the flap was also done. After that, the flap was replaced back and secured with the suture. Now, as we all know, the histology of nervous gingiva, there is no calcification is present, right? However, the histopathological finding of the present case revealed the presence of, when we have seen the magnified section of this region, the presence of compact bone in which the osteocytes were present in the ligament. That is a classical feature of osseous choriostoma. On the second hand, we can appreciate proliferation of spindle cells along with the basofiliar globular calcification that is suggestive of cementicles. That is a classical feature of cemento-ossifying fibroma. Now, this was the pre-operative and this was the second 2-month and 18-month post-operative picture showing no sign of recurrence and healthy gingiva. The lesion contained the feature of peripheral cemento-ossifying fibroma and osseous choriostoma. The first entity, that is the peripheral cemento-ossifying fibroma, it is a well demarcated encapsulated lesion that contains a variable amount of calcified tissue resembling bone and cementum. It accounts for 3.1% of all oral tumors and 9.6% of gingival lesions. It is associated or caused by irritants such as calculus, bacterial plaque, orthodontic appliance, adapted crowns, which can cause the trauma. And it is found to be originate from the periosteal cells or cells from the periodontal ligament. Peak incidence is second and third decade with the female predilection, as it is seen in the present case also. Clinically, it represents as a pedunculated or sessile nodular mass, usually originates in the interdental papilla. Color is similar to the oral mucosa and size usually less than 2 centimeters. However, more than 10 centimeters have also been observed. Mainly, it is seen in the incisors and canine region with the potential of tooth migration. The recurrence rate was reported to be 8.9 to 20%, and prognosis is excellent and recurrence is rare if correctly managed. This is the case represented by or article presented by Mohanty et al. In 2015, where you can see the similar type of cementicles as present in the present case also. Coming to the second entity, the osseous choriostoma is a rare tumor composed of lamellar pattern of bone occurring where the bone is not normally found. The proliferation is found to be reflects the embryonic rest cells as an origin, and the pluripotent stem cells has been found to be associated with the formation of the osseous choriostoma. Local trauma has also been seen that leads to the metastatic ossification. Clinically, it manifests as a 3 mm to 5 cm sessile or pedunculated mass. The color resembles normal mucosa. Age ranges between 5 to 73 years. Most of the cases are asymptomatic if occurs in the lung. However, some of the cases can cause to the pain, swelling, and dysphagia. A recent literature published by Yoshimura et al. In 2017 reported 97 cases of osseous choriostoma, in which the most of the cases were 76 on the tongue, and followed by 14 buccal mucosa, 2 alveolar mucosa, 2 in submandibular region, 1 submental, 1 mesenteric, and hard palate region. Another case reported by the Goswami et al., where you can appreciate the histological section, the presence of the dense type of compact bone along with the presence of osteocyte within the lacunae, as seen in the present case also. Now coming to differential diagnosis, first one is the pyogenic granuloma. As clinically pyogenic granuloma is more erythematous, more reddish in color, and on histological examination, it revealed presence of a number of blood vessels or channels. It is not present in the present case. Second one is the exostosis. For the exostosis, it should arise from the underlying bone, right? But in the present case, it was not connected with the underlying bone, as it is same. And osteoma is also a case where it originates from the osteus, where the osteocytes or osteoid tissue are already present. It is not present in a remote areas, right? Another one is the peripheral giant cell granuloma. As we can appreciate on the histological section, there is a presence of a multiple giant cells, which is not present in our present case, right? So what makes the peripheral cementosifying fibroma and osseous choriostoma as a special case? Because based upon the surgical history and histological examination, during the surgical excision, we have appreciated that the lesion was confined to the gingiva as it is not attached to the underlying bone, and it appeared bony hard. Second one, on the histological examination, it appeared lamellar pattern of the bone along with the cementicles. Now coming to the conclusion, in the present case report, the probable origin of the lesion was from the underlying periodontal ligament, which is the reservoir of stem cells from where the cementoblast and osteoblast may differentiate and form bone or cementum at the remote location or where it is not normally found. Now the key of success for the management of this type of cases is based upon the normal or the basic periodontal surgical procedure, that is the proper flap reflection and thorough debridement. Now, to the best of my knowledge, after literature search, no as such case report has been published where the coexisting lesion of peripheral cementosifying fibroma and osseous choriostoma is reported yet. So, thank you all.
Anrupa ma'am, I may invite you to chair this session.
Yeah. Dr. Saurav, it was a very well presented case.
Thank you, ma'am.
Good afternoon.
Dr. Saurav, you can on your video now.
Sir, it is asking the permission. You cannot start your video because of the host has disabled something like.
Okay. Ma'am, you can carry on.
Okay. Dr. Saurabh, can you told in the presentation that calcification in gingiva is extremely rare, right?
Yes, sir. It is not
Why do you
extremely rare,
think
but it is seen in some of the conditions such as peripheral cementosifying fibroma, osteoporostoma, or might be it can be a false type of enlargement due to the exostosis or osteomose type of cases.
Okay, so mostly it has a bony origin. Calcification is mostly a bony origin. So
No, it might be of cartilaginous, ma'am. It might be of lingual thyroid tissue also. It might originate from the cartilaginous tissue also, not only from the osteoid tissue. Yes.
Yeah, but my question is, why do you think the gingival tissue does not calcify?
Ma'am, because the basic constituent of the gingival tissue is cellular component, that is the keratocytes in the epithelium, and the cellular content fibroblasts and are present, and granulocytes are also present. Some of the defense cells are also present in the gingiva. There is no as such bone forming cells or calcifying cells are present in the gingival part, and it is separated from the underlying periodontal ligament. Means it is confined to the outer surface.
No, there is something in the ground substance that inhibits calcification in gingiva. Find that out, okay?
Okay.
You don't know the answer, find that out, okay? Good presentation. Dr. Asif, we can move on to the Dr. Asif?
Yes, ma'am. Dr. Prabhakar sir has not yet joined. We can move on with the next presentation.
Okay.
Dr. Gokulan M.
Good afternoon, respected juries. Today's my topic of paper presentation is management of thin gingival biotype and alveolar dehiscence post-orthodontic treatment, a multi-step approach. Into introduction. Post-orthodontic hard and soft tissue defects present a challenge to the treatment clinician. An alveolar dehiscence is described as a defect of the distal bone margin exposing the root surface. Controversy exists regarding the association between the lower incisor advancements and the incidence of bony dehiscence in susceptible individuals. In gingival biotype, visual plaque and inflammation are usual predictors of gingival recession. Periodontal phenotype is significantly related to labial plate thickness, the gingival position, keratinized tissue width, gingival architecture, and probe visibility, but unrelated to facial recession. Proper diagnosis and treatment planning is of utmost importance in minimizing the iatrogenic effects. From a periodontal point, such cases can be managed by regenerative techniques using hard and soft tissue grafting. This case report deals with the management of thin gingival biotype and alveolar dehiscence during orthodontic treatment as a multi-step approach to ensure a proper treatment outcome. Moving to case report, a 23-year-old male patient referred from the Department of Orthodontics to the Department of Periodontology, presenting with the clinical findings of thin gingival biotype showing prominent root surface and a minimal zone of keratinized tissue in relation to 4.3 to 3.3. In past dental history, patient gave a history of surgical orthodontic treatment done 2 years back, having fixed orthodontic therapy. Otherwise, patient was systemically healthy. Moving to clinical findings, patient presented with red melanin pigmentation in relation to 3.3, 4.2, 4.3. Consistency was soft in edematous. Rolled out margins was present in relation to 4.3, 4.2, 4.1, and 3.1. Probing depth range from 2 to 3 mm, generalized gradient mobility in the mandibular anterior region. Prominent root surface and minimal zone of attached and keratinized gingiva was present. As we can notice, the mucosa overlying the labial surface appeared to be thin. The outlines of the roots were clearly evident and prominent concavities were seen between the root surface. Moving to the radiographic findings, radiographic examination revealed very minimal crestal bone loss associated with mandibular anteriors. Further, on vitality test, teeth were vital using, for vitality test using electric pulpal testing. Correlating the clinical examination and radiographic findings, we arrived at a diagnosis as periodontal manifestation of acquired condition due to gingival phenotype, according to American Academy of Periodontology, 2017 World Workshop. Treatment plan. Etiotrophic phase was planned to do scaling and root planing, adequate patient education and motivation, oral hygiene instruction. In surgical phase, first stage was soft tissue augmentation using free gingival graft. Second stage, hard tissue augmentation using beta tricalcium phosphate with platelet-rich fibrin as a membrane. During maintenance phase, patient was instructed to use 0.2% chlorhexidine gluconate Motrins 2 times per day for 2 weeks. Subsequent follow-up visits at 4 weeks was planned. Moving to the treatment procedure, the first stage of surgical phase included preparation of the recipient bed, in the incision was placed and bleeding sites were induced on recipient side in order to adapt the soft tissue graft material. Then the FGG was obtained from the left side of the palate, and the free gingival graft were harvested, and the graft placed at the recipient site. The graft was stabilized, and 50 vicryl sutures was placed. Sutures were also placed at the donor site. Then the periodontal dressing was given. In postoperative 1 month, the graft had taken up only in the region of 4.1 and 4.2 apical region of the root surface. So the second stage of the surgery was planned from 1 month of the first stage, and then clavicular incision was placed, and full thickness flap was elevated. The flap was reflected beyond the mucogingival junction to expose complete root surface, since the defect has extended till the root surface. Upon entry, dehiscence were present on all the labial surfaces of lower anterior teeth. Significant defect was noticed in between the roots of the 3T and 2T. Intermarrow penetration extended slightly into the medullary bone. As no apparent irregularities were seen, it was decided to not to compromise the remaining bone present by performing decortication. Then beta tricalcium phosphate bone graft was placed. In preparation of PRF, 10 ml of blood was drawn from patient's antecubital vein. PRF was obtained, and PRF membrane was obtained using PRF box, and it was cut into 2 halves. Then PRF as a membrane was placed over the graft in relation to 3.1 to 3.3, and then the beta tricalcium phosphate bone graft was placed in the defect in relation to 4.1 to 4.3, and PRF as a membrane in relation to 4.1 to 4.3 was placed and sutured. 4.0 black braided sutures was placed, and periodontal dressing was given. In postoperative 1 month, adequate healing and increase in thickness of the gingival tissue was noticed. In postoperative 2 months, there was no recession, and completion of the healing was noted. The patient will be followed at subsequent intervals, and the surgical area will be observed. The patient may be subjected to the soft tissue augmentation procedure depending on the gingival thickness. Moving to discussion. Re-establishment of an ideal anatomical architecture following orthodontic tooth movement often involves both hard and soft tissue augmentation. This is usually as a result of the labial movement of the teeth outside of the envelope of the arch. Augmentation of bone volume can correct the associated root dehiscence, and alteration of the gingival biotype will allow for greater compliance with oral hygiene and create an environment less likely to be affected by plaque-induced inflammation. Correction of these defects may require multiple surgery to obtain a significant benefit. Maynard and Oshenbein suggest that teeth that shows minimal amount of the keratinized gingiva pre-orthodontically are prone to more mucogingival problems following tooth movement, and hence the mucogingival problem should be addressed prior to the initiation of orthodontics. In the majority of the patients who exhibit gingival recession, the alveolar plates of the bone are either thin or absent. It may be concluded that soft and hard tissue defects occur simultaneously. On the basis of literature evidence and to achieve significant outcome, in the current case, a multi-step approach was planned. The advantage of multi-step approach is that it provides significant benefits in correction of the complex hard and soft tissue defects. Hard and soft tissue augmentation also addresses aesthetic concern by providing more harmonious contours, and can also reduce the problem of root sensitivity and prevents the teeth from the future gingival recession. Moving to conclusion, this is a comparison picture showing pre-orthodontics, during orthodontics, and periodontal intervention post-op 2 months. We can clearly see the significant increase in adequate gingival thickness in post-op 2 months comparative to the pre-ortho. During orthodontic treatment, the alveolar dehiscence has become severe and the prominent concavities were seen, which was reduced in post-op 2 month picture. It is crucial to assess the amount of hard and soft tissue in comparison to teeth size and the anticipated orthodontic movement prior to start orthodontic treatment. In patients with thin gingival biotype, labial movement of the teeth outside the alveolar housing will predispose to the patient for future loss of supporting alveolar bone, and so recession compromising aesthetic and function. Treating a patient subsequent to the occurrence of labial dehiscence can be challenging. As a multi-step stage, soft and hard tissue augmentation using biological materials can be performed post-orthodontic treatment to prevent future recession and further loss of alveolar bone. Thank you.
Anurupa ma'am, and Prabhakar sir is yet to join. He is having some technical difficulties. You can proceed with the judging session, ma'am.
Okay. Dr. Gokulam, very good presentation. How many of such cases have you already done?
Ma'am, regarding this type, only one case, ma'am. Augmentation.
Only
procedure.
one case. Which year
Yes,
are you in?
I am in second year, ma'am.
Second year. Very good. Because it's a very technically sensitive procedure that you're doing. If you're doing it in second year, it's a very good thing. Okay. Can you classify gingival biotypes for me?
There are various classifications which I put on. There are more than 15 classifications. This presentation is mainly based on Siebert classification of 1989, where he has classified it into thin and thick.
Thick and thin, that's it?
Thin biotype and thick biotype.
So how does he
Yes,
how does he judge?
Thin and thick.
Okay. How does he judge thick and thin biotype?
He has said that yes, ma'am. In thin biotype, he has found a narrow width of keratinized tissue, and in thick biotype, it is a wide range of keratinized tissue, and it is more of cylindric teeth in the thin biotype, and in thick biotype, it is more of quadric teeth.
Okay, Dr. Gokulam. Thank you.
Thank you, Dr.
You can have the next.
Thank you, Dr. Gokulam. We can now move on to our next presentation by Dr. Parvati Tenappa.
Good morning, everyone. Today I'll be presenting you a paper on the topic Comparative Evaluation of Treating Isolated Deep Intrabony Defect with Anterior Papilla Preservation Technique and Conventional Technique, a case report. Moving on to introduction. The regeneration of periodontal support is one of the goals of periodontal therapy. Periodontal regeneration is influenced by patient-associated factor, site-related factor, surgery-related factor, which include early wound failure and exposure of the regenerative area. The papilla preservation flaps and minimally invasive surgical approaches are developed to reduce the risk of early wound failure. These techniques provide protection of the regenerating site and facilitate blood clot stability. Recently, a novel surgical approach, the anterior papilla preservation technique, has been proposed to treat isolated deep intrabony defect with periodontal regeneration by Aslan et al. In 2017. So the rationale of the anterior papilla preservation technique is to preserve the whole integrity of the defect-associated papilla to stabilize the blood clot and improve the wound healing process and to protect the regenerative material during healing. So moving on to the case report, a healthy 31-year-old male patient came to our department with a chief complaint of bleeding while brushing for past 3 years with no history of pain or difficulty in mastication or speech. Intraoral examination of the patient revealed probing pocket depth more than 5 mm in relation to 24251615 with bleeding while brushing and no tenderness on percussion was present. So we diagnosed the patient to be having chronic gingivitis with localized periodontitis in relation to 24251615. And the treatment plan that we decided for the patient was scaling and root planing, followed by a review, and following which we did a minimally invasive anterior papilla preservation in relation to 2425 and conventional periodontal flap surgery in relation to 1516. And the treatment procedure was explained to the patient, and we took a written informed consent before phase 1 therapy. So the anterior papilla preservation technique, preoperative photograph and radiograph showed a probing pocket depth of 8 mm and a radiographic bone loss of 0.6 into 1.5 mm. So after infiltration with local anesthesia, we made a buccal intraclavicular incision. A beveled vertical releasing incision was then made in the buccal gingiva of the neighboring interdental space and extended just beyond the mucogingival line to provide appropriate mechanical access to the intrabony defect. So a microsurgical periosteal elevator was used to elevate a buccal full thickness mucoperiosteal flap extending from the vertical incision to the defect associated papilla. The interdental tunnel preparation under the papillary tissue was achieved using a specifically designed tunnel elevator, and curettage was done. The bone graft that we used here was a composite graft, which consisted of a synthetic osteoconductive matrix, which we used was bioglass, and a growth factor IPRF, making them osteoinductive. These are shown to stimulate cell proliferation, differentiation, and eventually osteogenesis. And suturing we did here with simple interrupted suture, and the patient was advised to take antibiotic and analgesic for 3 days. and 0.2% chlorhexidine digluconate mouth rinse for 2 weeks, and post-operative evaluation was made 1 month post-operatively. And during 1 month follow-up, there was a decrease in bleeding on probing and a radiographic bone gain of 0.2 to 1.1 mm. And there was no recession observed clinically. And we thought of examining the probing pocket depth during 3 months follow-up, which we will be doing after this pandemic. So moving on to conventional localized flap procedure in relation to 1.5 and 1.6. The preoperative photograph in this region showed a probing pocket depth of 9 mm and a radiographic bone loss of 0.7 into 1.7 mm. And as always, we placed a normal clavicular incision and we located the defect and the curettage was done. And we placed the same composite graft here following the pre-suturing. And here also we made the same simple interrupted suture and the patient was advised to follow the same post-operative instructions. And during 1 month follow-up, here also we observed a decrease in bleeding on probing and almost same radiographic bone gain of around 0.6 into 1.5 mm. But here we observed a of 1 mm in relation to 1.6 and 1.5. So we were not able to make 3 months post-operative follow-up due to this pandemic. So based on this result, we observed a sudden decrease in bleeding on probing during 1 month follow-up using both the techniques, and the recession was present only in the conventional local flap treated area, and the radiographic bone gain was almost same, and both the defect were one wall defect, and the duration of the procedure was comparatively less in anterior papilla preservation procedure. Since we were not able to evaluate the probing pocket depth, I haven't mentioned it here. So moving on to discussion. The biomaterial exposure is a frequent complication during periodontal regenerative procedure. Papilla preservation techniques have reduced this complication to 30% and the minimally invasive procedure have reduced these complications to 10%. The anterior papilla preservation technique is designed to further reduce these complications. Anterior papilla preservation technique provides proper access to deep interproximal intrabony defect, preserves the integrity of the defect associated interdental papilla, reduces the risk of wound healing failure, prevents exposure of the regenerative material, and here also we have observed 100% wound closure during the whole healing period by Aslan et al. In 2017. An enhanced clinical outcomes without any soft tissue complication was reported by Aslan et al. In 2017 in a 1-year follow-up study. So in this case report, we observed that anterior papilla preservation technique produced post-operative gingival recession, did not produce post-operative gingival recession, and it was less time consuming, but at the same time, the visualization of the defect was difficult and it was also technique sensitive. The conventional flap treated areas experienced gingival recession of 1 to 2 mm, and it took comparatively longer time, but the defect visualization was easy. So the radiographic bone gain was same for both the procedure and didn't make any big difference. So the limitation of this anterior papilla preservation technique is that it can be done in areas with narrow interdental space where the risk of tearing the interdental papilla is high. And it may not be applicable for defects involving the lingual side of the teeth and not applicable for defects requiring the elevation of the interdental papilla for debridement of the defect, and it is also a technique sensitive procedure. So moving on to conclusion, this novel surgical technique without any incision of the defect associated interdental papilla seems promising to provide optimal biomaterial protection and healing condition. So these are my references, and thank you.
Dr. Parvati, Dr. Asad.
Yes, ma'am. Ma'am, you can go with the question answer session now.
Okay. Hello, Dr. Parvati. Parvati.
Hello, ma'am.
Is this your thesis topic or is it just a short study?
No, ma'am, it's just a short study, ma'am. I just did one case on this.
So you stopped doing further cases because of COVID, or you had planned just 2 cases only?
Ma'am, this is on the same patient, ma'am. We have done in contralateral sites, ma'am. So if I get a case suitable doing contralateral sites, then I'll start doing.
You are in which year?
Second year, ma'am.
So you've already started doing microsurgery in second year. That's really good. Pretty much everything is covered. Okay. Please continue doing the study. Huh? Don't stop in between because of this pandemic and all. Pretty much everything is covered. Good.
Thank you.
Thank you, Dr. Parvati.
Thank you.
Now, can we have the next presentation by Dr. T. Rohit Narayan?
Good day, ma'am, sir, and good day on all who's present here. My topic today is on lip repositioning and innovative treatment approach. So, introduction. The harmony of the smile is determined not only by the shape, the position, and the color of the teeth, but also by gingival tissues. Excessive gingival display, which is commonly described as gummy smile, adversely affects smile aesthetics and therefore is undesirable. It is one of the several developmental or acquired deformities and conditions that manifest in the periodontium. So, excessive gingival display is an easily concern for patients. There are different etiologies of a gummy smile. It may be like a vertical maxillary excess, a short and hyperactive lip, upper lip, altered passive eruption, anterior dental extrusion, or a combination of these causes. The objective of the lip repositioning is to limit the retraction of the elevator smile muscle. Lip repositioning results in shallow vestibule, restricting the muscle pull, thereby limiting gingival display during the smile. It is a condition in which an overexposure of the maxillary gingiva that is greater than 3 mm is present during a smile. Lip repositioning is a conservative surgical technique used to treat excessive gingival display. The technique was designed to be shorter, less aggressive, and to have fewer post-operative complications compared to the orthodontic surgery. So, lasers in dentistry, laser it's become one of the most captivating technologies in dental practice since Theodore Maiman in 1960 invented the ruby laser. Lasers in dentistry have revolutionized several areas in the treatment in the last 3.5 decades of the 20th century. So, introduced as an alternative mechanical cutting device, laser has now become the instrument of choice for many dental applications. Evidence suggests that its use in initial periodontal therapy, surgery, and most recently its utility in salvaging implant opens up a wide range of applications. So, clinical application of laser in a periodontal treatment, it may be used in initial periodontal therapy like scaling and root planing. It can be used for laser-assisted neoattachment procedure, like some reports suggest that LNAP can be associated with cementum-mediated new connective tissue attachment and apparent periodontal regeneration of the disease root surface in humans. So, surgical procedures, many studies showed increase in coagulation and related dry surgical field for and better visualization. So, and it may be also used in lasers and implants. Gingival enlargement is relatively common and around implants whenever they are loaded with removable processes. So, lasers can be used for hyperplacial removal as well as the treatment of peri-implantitis. So, aim of this case report is to compare between a scalpel and laser lip repositioning technique. 2 patients are selected for the treatment of gummy smile. For 1 patient, scalpel lip repositioning technique was performed, and in another, laser lip repositioning was performed. So, this is a 19-year-old female patient came with a complaint of incompetent lip with excessive gingival display on smiling. So, this is the post-operative picture of the patient, and a diode laser with 830 nanometer in 1.8 watt was used in continuous base strokes. So, procedure. As a general rule, we know it has been suggested that distance between the superior and inferior borders must be twice the length of repositioning desired in the smile. So the first incision was given at the level of mucosal junction, followed by second incision at the second incision was given 16 mm above it. So sutures are placed after the procedure has been completed. This wasn't using a laser. So this is the post-op immediate picture. It's a healing after 15 days, and it is a healing after 6 months. So after 6 months, we can see like the vestibular depth has been maintained, and there's a completed lip present for the patient. So scalpel lip repositioning technique in this, a 16-year-old male patient came with a complaint of incompetent lips with excessive gingival display. So similarly, scalpel technique was performed. First incision was given on the mucogingival junction, and second, 12 mm above the mucogingival junction was present, and sutures was placed. So pre-operative picture and this is the post-operative picture. So results, both techniques showed similar results, but post-operative complaints was better for patients treated with laser lip repositioning technique. So this report aimed to document the repositioning technique to decrease the amount of gingival displays in patients with gummy smile. The results showed that the employed surgical procedure successfully reduced the gingival display with low mobility. The procedure is safe and has minimum side effects. Reports in the literature have shown minimal post-operative bruising, discomfort, and swelling. Mucosal formation has been the most severe reported complications. So lip repositioning procedure began as a plastic surgical treatment, and since there are many variations have been reported, the original technique did not include severing the muscle attachment after flap deflection. However, some authors suggested performing myectomies to detach smile muscle attachment to prevent relapse. So another method to prevent reattachment of smile elevator muscles is the placement of spacer between the elevator muscles of the lip and the anterior nasal spine, thereby preventing superior displacement of repositioned lip. So some evidence like Ishida et al. In 2010 reported a reduction in gingival exposure for hyperactive lip through myotomy of the levator labii superioris muscle with frenectomy. So Storer et al. In 2014 combined containment like surgery of the elevator muscle of the upper lip with gingival recontouring, and Silva et al. In 2012 reported successful management of excessive gingival display in a study wherein 30 patients with excessive gingival display were treated with a modified lip repositioning technique. Treatment consisted of removal of 2 sets of mucosa bilaterally to the maxillary labial freedom and coronal repositioning of the new mucosal margin. Although these procedures were successful in reduction of the excessive gingival display, they were demanding the resultant functional mobility. So some contraindication for the procedure, it may be due to patient having inadequate width of attached gingiva in the maxillary anterior section and insufficient amount of tissue which poses difficulty in flap reflection, stabilization, suturing. Patient with severe vertical maxillary excess cases are also not ideal for lip repositioning procedure and should be treated with orthognathic surgery. So why is laser is good? Because it has reduced bacteremia with reduced post-op discomfort. It has immediate hemostasis. It has present in reduction myofibroblast, and it creates a breathless surgery and it promotes coagulation and has less chance of relapse and reattachment. So a major benefit in the laser in our case report was relatively less discomfort in post-operative period. When compared with scalpel, there are reduced intraoperative bleeding and reduced bacteremia, which can be attributed to sterile inflammatory conditions. An added advantage with laser was high patent accessibility of the procedure due to its ease and less mobility. However, a major limitation related to surgical procedure is the recurrence of gummy smile. Thank you.
Ma'am, you can begin the question answer now.
Dr. Rohit.
Good afternoon.
Good afternoon. First of all, your presentation was not very clear. Please try to be a little more clearer in your diction while
No, ma'am.
presenting.
Actually, I submitted the trial version, ma'am. This is my first trial, ma'am. Then I done another video. Instead of submitting that, I submitted this, ma'am. I didn't know.
No
I just
issue.
got it, ma'am. Okay, ma'am.
No issue. Are you in first year?
No, ma'am. I'm in second year, ma'am.
You're second year. Okay. So, Dr. Rohit, how did you select the cases for lip? If I'm not wrong, you did 2 cases, one with laser and one with scalpel, right?
Scalpel, ma'am. But scalpel, I was assisting the case, ma'am. It was done by my senior, ma'am. Laser only I've attempted it, ma'am.
Okay. So, what was the criteria for case selection? How did you select the cases? On what basis did you select the cases for lip depositioning and not referred them to the orthognathic surgery?
Ma'am, actually, lip repositioning is done when there is an overexposure of maxillary gingiva, ma'am, that is greater than 3 millimeter. So some lip repositioning, like it may be due to short and hyperactive upper lip, ma'am, and vertical maxillary excess, ma'am. And it depends upon.
So in which cases do you go for lip repositioning, and in which cases do you suggest orthognathic surgery?
Orthognathic surgery when the patient has very excessive vertical maxillary excess.
What is very excessive? How much is very excessive?
I'm not sure.
Dr. Rohit, there is a decision tree for lip repositioning. There's a decision tree. There is a very precise way of knowing which patients can go for orthognathic surgery, which patients can go for lip repositioning. Please go through the literature for that and find out. Okay, there's a decision tree. You should follow that. And what about the scarring? Was it comparable in the laser and your
ma'am? Actually, I was scalpel technique. I was just assisting my senior, ma'am. So I was not able to follow the patient post after the treatment, ma'am. And in laser treatment, I was able to follow up till 3 months, ma'am.
How much was the scarring? How much was the scarring? Immediately after, how much was the scarring? Okay, it's okay.
Okay,
it's okay.
Sorry.
Find out. Okay.
No
issue.
Thank you, Dr. Rohit. We can now move to our next presentation by Dr. Therese James.
Good afternoon, respected jury members and my dear fellow participants. The title of my case presentation is a two-stage surgical procedure for root coverage. In the current practice of periodontics, clinicians are faced with the challenge of not only addressing biological and functional problems present in the periodontium, but also providing therapy that result in acceptable aesthetics. The presence of mucogingival problems and gingival recession around anterior highly visible teeth exemplifies the situation in which a treatment modality that addresses both biological and aesthetic demands is required from the therapist. Gingival recession associated with root surface exposure is a complex phenomenon that may present numerous therapeutic challenges to the clinician. Recession may be accompanied by root caries, abraded surfaces, aesthetic defects, and root hypersensitivity. Gingival recession, along with inadequate attached gingiva, is identified as a mucogingival problem. During the past decade, a variety of regenerative procedures with the potential to correct gingival recession defects via augmentation of the width and height of keratinized gingiva, as well as to obtain partial or complete root coverage, have been proposed. The choice of the technique depends on defect size, localization in the aesthetic zone, and need for augmentation of attached gingiva. The aim of the present case was to treat an isolated region of gingival recession by a two-stage surgical approach. Stage 1, by free gingival graft to increase the width of the attached gingiva. Stage 2, by coronally advanced flap with PRF membrane placement for root coverage. Coming to the case report, a 27-year-old male patient reported to the Department of Periodontics with a chief complaint of tooth sensitivity and exposure of root surface in relation to the lower front teeth. On clinical examination, the oral hygiene status was found to be fair. Miller's class 3 gingival recession was found with respect to 3-1 and 4-1, along with inadequate attached gingiva, shallow vestibule, and aberrant frenal attachment. Loss of clinical attachment was found in relation to 3-1 and 4-1, 3-1 showing 7 mm, 4-1 showing 8 mm. On radiographic examination, mild to moderate bone loss was seen in relation to 3-1 and 4-1. The case was diagnosed as localized periodontitis, stage 2, grade 1. Based on the diagnosis, the following treatment plan was charted. Phase 2 therapy consists of 2 stages. Stage 1, augmentation by free gingival graft. Stage 2, coronally advanced flap with PRF placement. As a part of the phase 1 therapy, scaling and root planing was done with a combination of hand and ultrasonic scaling instruments. This was followed by the first stage of the phase 2 therapy, that is, free gingival graft. Free gingival graft was initially described by John in the year 1963. The term free gingival graft was first suggested by neighbors. Initially, a horizontal incision was placed from 3-2 to 4-2 to deepen the vestibule. The demarcated area was de-epithelialized using BP plate number 50. Palatal mucosa was used as the donor site for harvesting the soft tissue autograft. The harvested soft tissue autograft was placed on the recipient bed. The graft was stabilized by a combination of sling and interrupted sutures to ensure better adaptation to the recipient site. The donor site was then sutured and protected using an acrylic stent. The patient was recalled after 10 days for suture removal, and healing was found to be satisfactory. In the 2 months follow-up photographs, we could appreciate an increase in the width of the keratinized gingiva by 6 mm. Though the objective of the stage 1 surgery was to increase the width of the keratinized gingiva, we ended up achieving some amount of root coverage with respect to 3-1 and 4-1. The patient was then subjected to coronally advanced flap with a PRF membrane placement. A horizontal incision extending from 3-2 to 4-2 was placed at the base of the papilla. Vertical incisions were placed at the mesiobuccal line angle of 3-2 and 4-2 beyond the mucogingival junction to ensure the advancement of flap coronally. Root planing was carried out in relation to the exposed root surfaces of 3-1 and 4-1 using Gracie's curettes 1 and 2. PRF membrane preparation was done following the Chapran's criteria. 10 ml of blood was drawn from the antecubital vein. The collected blood was centrifuged at 3000 rpm for 15 minutes. This was followed by preparation of the PRF membrane using the PRF pulse. The obtained PRF membrane was placed on the defect, followed by advancement of the flap coronally using a combination of sling and interrupted suture. The area was then protected with a periodontal dressing. The patient was recalled after 10 days for suture removal and the healing was found to be satisfactory. The results after the second stage are promising in terms of vestibular deepening, width of keratinized gingiva, and root coverage. Coming to the discussion, the structure of the gingival tissues is the basis for healthy gingival function. The presence of a thick keratinized gingival covering serves as an effective barrier against physical trauma of mastication and thermal and chemical stimuli from the dietary components. Problem areas with inadequate keratinized tissue and gingival recession can be treated with free gingival graft, as it can create an adequate zone of attached gingiva and to cover the exposed root surface. The present case was treated by a two-stage surgical approach. Stage 1 for increasing the zone of keratinized gingiva, stage 2 for root coverage. The various treatment modalities for increasing the zone of keratinized gingiva include free gingival grafts, connective tissue grafts, and apically positioned flaps. Free gingival graft is a simple and highly predictable procedure. In the early phases, it is important to assure collateral circulation from the connective tissue bed bordering the defect. The utilization of free gingival graft in treating such cases aids in overcoming the limitations presented by the connective tissue graft, as the gingival graft ensures the development of the adequate band of attached gingiva. The subepithelial connective tissue graft, on the other hand, may result in root coverage and result little, if any, increase in the apicocoronal dimension of the keratinized tissue. Coming to conclusion, gingival recessions are one of the main aesthetic concerns of the patient. A large variety of plastic surgical procedures for coverage of exposed roots exist. These procedures are quite predictable and produce satisfactory solutions to the problems presented by mucogingival defects. The outcome of the present surgical technique suggests that the two-stage surgical procedure for root coverage is ideal in case of isolated deep recession and inadequate attached gingiva. Selection of the appropriate procedure, precise and meticulous surgical technique will provide successful and highly predictable results in the treatment of gingival recession. Thank you.
Ma'am, I hand over the mic to you.
Dr. Therese, very beautifully presented. The photographs are really good. Congratulations on that. There's only a minor issue. You said there was aberrant frenum in the beginning of the case. While you were presenting the case, you said there was an aberrant frenum. How did you find that out?
Ma'am, by performing the tension test.
Okay. So what exactly did you do?
Ma'am, the lower lip was retracted downwards and moved sidewards. So we could see that the gingival margin was moving away from the tooth.
So that's positive tension test, right?
Yes, ma'am.
So the recession was caused due to aberrant frenum?
Yes, ma'am.
Okay. In your entire management, did you do anything to address that issue?
Ma'am, no, ma'am.
Are you sure you have done nothing to correct the aberrant frenum, right? You've done nothing to correct the aberrant frenum. You only increase the attached gingiva and then you coronally advance it.
Yes.
You did not correct the attached aberrant frenum at all. You did nothing to do that. Okay, think about it. When you did the first horizontal incision, if you could have just gone a little deeper and excised the entire frenum, then you could have just, you could have done the frenectomy along with the first horizontal incision that you gave before placing the SGT, right? So yes. I'm sure you must have done it, but I think you right now you could not correlate it. So keep that in mind. Yeah. Okay. Very good. Congratulations.
Thank you.
Okay, thank you, Dr. Therese. Ma'am, we have now, our first presenter has now joined the
team. Yes, come back.
Yes, ma'am. We can have our presentation. Dr. Kavya Balan.
Good morning. I'm going to talk about a case report of role of periodontics in interdisciplinary approach. Moving on to the introduction. Dental treatment have advanced to a point where dentists alone can no longer solve the issues that patients face. Complex oral, facial, and cranial problems that patients present require a different approach. More importantly, patients have a particular demand and hope for the most natural looking restoration. These aesthetic considerations have influenced dentistry and have established the need for new treatment approaches that ensure the best possible results. That where a multidisciplinary dental treatment excels, talented specialists work together to ensure both functionality and aesthetics. What is an interdisciplinary approach? Basically, interdisciplinary dentistry refers to a dental treatment that uses more than one type of dental tactic. This type of multi-level care occurs when there are complex cases that need to be treated in many steps. Often we come across this type of situation when dental care has been put off or ignored for many years. The key is to build a team of like-minded, dedicated professionals who share a common goal of providing optimal oral health care to patients. These are some of the cases which have been done in our department of periodontics, such as lip repositioning, crown lengthening, papilla reconstruction, percussion involvement, frenectomy, ridge augmentation, and peri-implantitis. Some of the interdisciplinary approaches. Role of a periodontist in this is that periodontists often work along with the prosthodontist for a long-term periodontal care of patients' bone and gum tissue surroundings. They provide both preventive periodontal care as well as both surgical and non-surgical periodontal management of periodontal disease. Periodontic objective include treatment of gum recession via grafting procedures, minor bone grafting procedures for implants, preventive periodontal procedures such as supra and subgingival scaling. Moving on to the perio-prosto relationship, the natural artificial fusion, crown lengthening. The ultimate goal for crown lengthening is to provide a tooth crown dimension adequate for stable dento-gingival complex for the placement of a restorative margin so as to achieve the best marginal seal and an aesthetically pleasing final restoration. The biological width is defined as the physiologic dimension of the junctional epithelium and connective tissue attachment according to the pioneering study conducted by Gerulo et al. The connective tissue attachment of 1.07 mm above the alveolar bone crest and junctional epithelium below the base of the gingival sulcus of 0.97 mm. The combination of these two measurements constitute the width that is 2.04 mm in an average. Some pre-surgical analysis determine the finish line prior to the surgery, transsulcular probing in surgical and contralateral side biological width requirements will determine the amount of bone removal. Combination of biological width and prosthetic requirement determines the total amount of teeth to be exposed. Tooth surface topographic analyzed to determine osseous scallop and gingival form. This is one of the clinical presentations which have been come to our college, to the Department of Perio. The patient, this is the pre-operative photo. The patient complains of missing tooth, and this patient have been sent back to the Department of Endo for a root canal treatment. After the root canal treatment, they send the patient back to the Perio, after which everything is done. We have lengthened the periodontists have lengthened the crown, and then we have sent the patient back to the prosthodontics for getting a prosthesis. This is the post-op picture after getting a prosthesis. Moving on to the perio-endo, the inside-outside link, papilla reconstruction, one of the most difficult achievement in the periodontal therapy is the reconstruction of the interdental papilla that has been lost by periodontal disease. The poor aesthetic appearance caused by the black triangle, especially in the maxillary anterior regions. However, when the papilla destruction is followed by loss of contact, the use of different specialities is usually necessary to restore the interproximal embrasure, periodontic, orthodontic, restorative. The existent interdental papilla and a healthy gingiva harmonizing with the natural dentition affects dental treatment. Two types, pyramidal and coal-shaped tip, present immediately beneath the contact point. Coal-shaped, valvular depletion connecting facial and lingual papilla. According to Nolan and Torno, he gave three landmarks. That's the interdental contact point, apical extent of the facial cemento-enamel junction, coronal extent of proximal cemento-enamel junction. With these three landmarks, we can identify which type of black triangle is that a patient does have. This is a pre-op picture, and this is the post-op picture where you can see the space have been filled adequately. Another case have been came to our department with a complaint of sensitivity, and When we saw it was a furcation in grade 2 furcation in class 2 furcation involvement, a furcation management with a PRF and a bone graft. This is the pre-op picture, and this a picture while we after we placed with the PRF and bone graft, and the teeth has been sutured back. Moving on to the radiographic view, this is the pre-operative view where we can see greater amount of bone loss, and this is the post-operative picture where adequate bone loss have been formed, and yeah. Moving on to the discussion, in order to fulfill the challenging and increased functional and aesthetic requirements that have arisen nowadays and to deliver satisfying therapeutic outcomes, they consider embracing the interdisciplinary approach, especially when complex cases are being treated, according to Christina et al. From a periodontal point of view, contemporary treatment may incorporate various interventions such as surgical periodontal therapy, soft tissue management, regeneration, and bone augmentation procedures, which eventually are capable of preventing disease progression and enhanced dentition longevity, according to Christina et al. 2020. According to Teresa Pinho et al., the cooperation of the interdisciplinary fields such as periodontics, endodontics, and prosthodontics and orthodontics are required to achieve better results in regard to patient function, aesthetic, and satisfaction. Conclusion: a healthy periodontium is a prerequisite for success with any dental treatment. With strong interdisciplinary approach between other periodontists and other specialties, the outcome may compromise, and necessity, extensive, and expensive treatment may be needed. Hence, while planning treatments, consideration should be given to periodontal factors, even if they do not have a direct effect on the final modality. But the longevity of the process, aesthetics, emergence profile are critically controlled by the periodontal treatments. As a periodontist, it is very necessary to practice team approach to deliver a quality care. Thank you.
Anurupa ma'am, over to you. Hello, ma'am. Ma'am, you are not audible.
Ma'am, I think the battery of your headphone has been gone. You are not audible.
Ma'am, kindly speak directly through the computer.
I think there is a problem with the Mahapatra ma'am's computer. So I think we have to proceed for next session.
Okay.
Hello.
Yes, ma'am. Yes, ma'am. We can hear you now.
Okay. Dr. Kavya, I'm sorry I could not hear the last part of the session, but I would two things. If you don't mind, I'll tell you. First of all, your slides had too much text, so I could not read, and you were speaking too fast, so I could not hear. So both the things, either you are supposed to let me read or you're supposed to let me hear. Okay. First. Secondly, if I'm not wrong, what exactly did you do for the perio interdisciplinary approach? I did not understand it actually.
Yes, ma'am. I'll just explain you. The thing is, patient came with the furcation involvement teeth in the molar region. Like we have. You're asking about the crown lengthening part, ma'am.
No, I'm asking about the endoperio where you talked about the black triangle.
Not the black triangle. We just gave a thing, ma'am. In our department, our senior has done a study. Like she took 5 cases of black triangle.
Black triangle was a part of which interdisciplinary approach in your case report?
Endo.
Yeah, sure. I can see a question on your face. I mean, I don't need to ask the question. You yourself are questioning yourself, right?
No, ma'am, I don't understand actually properly. I couldn't hear it.
You have discussed the black triangle in the endoperio section, right?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
How can a black triangle management be a part of endoperio?
No, it is not.
Okay. Find that out before presenting the next time, okay? Bye.
Okay, thank you, Dr. Kavya Balan. With this, we are ending this session now. And thank you so much, Dr. Anupa ma'am, for taking out your valuable time and being a part of this session, chairing this session and this
Thank you, Dr.
virtual.
Asit. Thanks a lot.
And we are
I know
unfortunate that Dr. Prabhakar sir could not join here because of some technical issues.
I know the entire organizing team is working extra hard for this. So I would like to thank ISP for giving me this great opportunity to be a part of this first virtual event. And congratulations to the entire organizing team for carrying it out without a glitch. Congratulations, Dr. Asit, and the entire team. Thank you so much.
Thank you, ma'am. Ma'am, one gentle reminder to send
I'll
the evaluation
send it immediately. Yeah.
Yes, ma'am.
Yes, I'll send it immediately. Okay.
Thank you, ma'am.
Have
Thank
a
you
good
so much,
day.
ma'am.
Bye. I can leave now, right?
Yes, ma'am. Yes, ma'am.
Okay. Thank you so much. Have a nice
Thank
day.
you, ma'am. Now we can begin with the session, sixth session. It will be hosted by my co-coordinator, Dr. Swayam Pravasil. I may hand over.
Good afternoon, ma'am. I would like to invite our chairperson, Dr. Jayasri Garg, professor from the Department of Periodontology, Institute of Dental Science, Borelli, and Dr. Poonam Agrawal, ma'am, reader, SCB Government Dental College and Hospital, Cuttack. Ma'am, please chair this session. And now I would like to call our presenter, Dr. Naskat Savana. Sorry, ma'am. I would like to call the presenter, Dr. Mitha Matthew.
A very good morning to one and all. Today's my presentation is about unilateral solitary lymphangioma circumscriptum of gingiva, a rare case report. So these are my contents. So coming to introduction, lymphangiomas are benign malformation of lymphatic vessels, which are slowly growing pale soft tissue mass, and they are characterized by abnormal proliferation of lymphatic channels, and they are seen as superficial or deep ones. So these lymphangiomas, they can be either be seen as in superficial ones or deep ones, and the lymphangiomas that present in superficial location, they are known as they are been seen as solitary lesions which has a pebbly surface, and therefore, and again the lymphangiomas which are in deep locations, they are seen as diffuse nodular mass. So this lymphangiomas, they are seen more in head and neck region, and 50% of the lesions they are congenital, whereas 90% they arises within 2 years of age. So this lymphangioma, on the basis of histological classification, they are classified as capillary lymphangioma, cavernous lymphangioma, and cystic lymphangioma. So coming to the epidemiology, these are rare benign congenital lesions of unknown etiology, and the male-female predilection is about 1:1, and it occurs as an isolated disorder. It can be seen as an isolated disorder, or it can be in association with some disorders and or some syndromes, and these syndromes are known as Turner syndrome or Turner's disorder, that is Noonan syndrome, fetal hydrops, and fetal alcohol syndrome. Again, coming to the pathogenesis, there are 3 main pathogenesis, and that involve the cause of, or that involve the lymphangioma. The first one is failure of lymphatic system in order to connect with or separate from venous system. Next is abnormal budding of the lymphatic system from the cardinal vein, and the third is acute process, that is any trauma, infection, or obstruction that happens during life. So coming to the clinical features, always these seem to be the surface of the lymphangioma that always be in, they are seen as they have a pebbly surface, and the color, they will be always similar to the adjacent mucosa. And the site of occurrence, it's mainly seen in the tongue, and it is followed by palate, gingiva, lips, and alveolar ridge. So in the histological examination, so first of all, in histological examination, we can see the gingival tissues. They will be covered by a parakeratized squamous epithelium. And when we see deep into the epithelium, we will be able to see the lymph channels or the lymph vessels with of different sizes. And these channels or these spaces, they are lined by endothelium or endothelial cells that contains lymph. And coming to the differential diagnosis include pyogenic granuloma and hemangioma. And coming to the treatment options, the first one is, if the lesion, if it is small, we will go for surgical excision. And if we have a sclerosing, and the next one is sclerosing agent, that we will make the lesion small, and then again we will excise. Then next is about this, we can also follow cryosurgery, electrocautery, and embolization. So coming to case presentation. A 21-year-old female patient, she came to Department of Periodontics with a chief complaint on the complaint of gingival enlargement on her buccal as well as palatal aspect of maxillary left lateral incisor. So buccally, she had the gingival enlargement between the central incisor and lateral incisor, and palatally it was between the lateral incisor as well as canine. And her past dental history revealed that it is frequent oral ulceration. It is and her past dental history showed that there was a oral ulceration before, burning sensation was there, and erythematous gingiva. And her medical history showed that there was some respiratory problems. There was obstruction of the respiratory system. That means her chest X-ray also showed that there was hyperinflation of the lungs. So coming to intraoral examination, the lesion, it was mulberry-shaped lesion, and the surface of the lesion, it was intact without any presence of ulcer, and the swelling was about 0.5 to 0.4 centimeter in diameter, and the swelling was pebbly and non-tender on palpation. So we have undergone many investigation. First of all, routine blood check was done, and it was mostly it was normal range, and there was slight elevation of the leukocytes count, and the IOP of 2.2 and CBCT of 2.2 is taken, and the showed in IOP it showed widening of periodontal ligament, and CBCT showed 2 mm bone loss. So the treatment aspect, we have done surgical excision. That means we have excised the lesion, and that is both in palatal and buccal, in buccal and palatal side. And the surgical excision, and then sutures are placed and Copac is placed. Then after that, we have sent the excised tissue for the histopathology. So we have sent to the histopathology for histopathological examination, and the histopathology examination of this specimen showed that it shows parakeratosis satisfies squamous epithelium, and the juxtaepithelial contour tissue, they shows homogeneous eosinophilic areas that resembling the lymph that lined by endothelium with interspersed lymphocytes. So these are the histopathological images. And after that, in order to confirm whether it is lymphangioma or not, we have done immunohistochemistry. And the immunohistochemistry is done with D240 antibody, and this provides a confirmatory result for lymphangioma. So we have done immunohistochemistry with D240 antibody, and it showed that, and it's given a confirmatory result for lymphangioma. So coming to discussion, lymphangomas are considered with the hematomas that are arising from the sequestration of embryonic lymphatic canalage, and the lesion become clinically evident as areas of localized lymphatic channels or lymphatic status that develop due to congenital blockage of this lymphatic drainage. And the lymphangomas, they are divided into 3 groups, that is capillarly, cavernous, and cystic. And clinically, it is divided like microcystic, macrocystic, and mixed. And on the basis of this both clinical and histological findings, the superficial forms of lymphangioma, they include lymphangioma circumflex and lymphangectasia. So this lymphangectasia, it is the dilated lymphatic channels. Before it was normal, but due to any obstruction because of any trauma surgery, it caused obstruction of the lymphatic channels. That is known as lymphectasia. So this case, so coming to the conclusion, this case in the past medical history of the patient revealed that the patient had in her chest X-ray showed hyperinflation of lungs. So that means there was an obstruction into the respiratory illness. So we have concluded that any congenital malformation was there before, and it will be triggered by any respiratory problems, thereby it causing this problem, resulting into the acute lymphangioma. So this case report suggests the lesion to be solitary acute lymphangioma, and its occurrence in the gingiva is very rare. So these are my reference. Thank you.
Okay. Ma'am, you may start with question answer session.
Okay, ma'am. Your presentation was a bit, you would have, like in the middle, no, Mithla, you would have elaborated it a bit more. Like in between the slides, you skipped off some of the content of it, and no doubt you have some time foundation of like to finish it within the required time, 8 minutes, but at least you could have elaborated it a bit more. I would like to ask you the pathogenesis. Can you elaborate it a bit more regarding the pathogenesis of it?
So, ma'am, the pathogenesis mainly regarding the lymphangioma. The one thing is that it cannot, the lymphatic channels, there will be suppression in the lymphatic channels. They cannot connect with that, with the normal channels. The next in our pathogenesis of our case, we conclude it as because the patient already had respiratory problems, and this respiratory problem, this respiratory obstruction or any infection or this trauma can this can cause this pathogenesis of lymphangioma, because they cause the blockage of lymphatic system, or they will cause the lymphatic status. So that is the main pathogenesis what we see here, because the patient was normal for a long time, and before 1 year before, patient had this chest problems, this respiratory illness. So after that only patient had after 1 month of this, after 1 month, patient had showed this burning ulceration erythematous gingiva, and patient had this pebbly surface, the appearance of this lesion, and then we identified it as lymphangioma. So we think the most main pathogenesis for this case is to be trauma, infection, or any obstruction.
Okay. Dr. Poonam, you would like to ask?
No, ma'am. Thank you.
Okay.
We can go for next presentation.
Yeah.
Okay, thank you.
Very good morning, everyone. Today I'll be presenting a case series on soft tissue grafting in management of recession coverage. So just a brief introduction. What is gingival recession? According to Carenza, recession is the exposure of the root surface by an apical shift in the position of gingiva. Cohen defined gingiva as a apical migration of the junctional epithelium with the exposure of the root surface. Linde said that it is a apical displacement of the gingival margin from the cemento-enamel junction that results in root exposure. Now, coming to the treatment modalities for gingival recession, non-surgical treatment options. So basically the objectives of a non-surgical therapy are to maintain or to improve the periodontium and expose root surface, and findings and diagnosis that do not warrant a surgical treatment, or when contraindications to surgery exist. Basically, this non-surgical treatment option includes monitoring and prevention. We can use desensitizing agents, composite restorations, and removable gingival veneers. Coming to surgical management, there are various options before we plan a surgery. There are root coverage techniques, including your pedicle soft tissue grafts, your free soft tissue grafts, and additive treatment. Pedicle soft tissue, basically your rotational flaps, advanced flaps. Free soft tissue grafts can be non-submerged, 1-stage, 2-stage submerged graft. Additive treatments like root surface modification agents, enamel matrix proteins, guided tissue regeneration, and non-resorbable membrane barriers. Now, what are the key factors in selection of surgical procedure? We have to keep in mind certain factors before we plan a surgical treatment. We have to inspect the recipient site and donor site before doing any kind of soft tissue grafting, like check the recipient area. If the gingival recession, is it limited to one teeth or is it extending to multiple tooth? What is the degree of recession? How much amount and thickness of existing keratinized gingiva is there? Whether the recession is protruding labially from the dental arch, what is the relationship between the recession area and the smile line? Is it of aesthetic concern or not? And similarly, donor side needs to be inspected. How much is the amount of keratinized gingiva? How much is the thickness of keratinized gingiva? What is the size of adjacent interdental papilla? Thickness of alveolar bone covering the donor tissue, and thickness of the palatal soft tissue used as donor. So, coming to my case series, a brief summary. This is a paper that is viewing the various surgical procedures for covering of exposed root surface. 3 patients reported to the Department of Periodontology with chief complaint of receding gums in the anterior teeth region respectively. These cases were treated with a free gingival graft and a coronally positioned graft in order to achieve complete root coverage. Now coming to the first case report, this is basically of a 25-year-old male patient. He reported to the department with a chief complaint of receding gums in the anterior tooth region, and this recession he was observed after he got a orthodontic treatment done 1 year back. So we decided to place a free gingival graft to augment the attached gingiva to eliminate further recession, to facilitate oral hygiene and cover the root for aesthetic reasons. So this is a pre-operative view of the recession. So this is how there was a preparation of the recipient site. So after we administered LA, following a complete root planing of exposed root surface, we decided to give a horizontal incision was made with 15 number blade at the level of CAJ, creating a very well-defined bud joint. Then a vertical incisions, 2 vertical incisions were made along the distal proximal line angles. The overlying keratinized tissue was thoroughly excised. Donor side, we can see a graft was we prepared a template using aluminum foil, and we put it on the recipient side to harvest that graft. After placing a template on the palate, we gave an incision. You can see in this picture, an incision was given with the 15 number blade to demarcate the tissue which had to be harvested. And hemorrhage at the donor side, we controlled it with a pressure pack of moist gauze. So this is how the graft was harvested. This is the picture. Then the graft was sutured at the lateral borders and the periosteum so that it secured it in position. Initially, for initial stabilization, we use interrupted sutures. A horizontal suture was also given to stretch the graft and basically so at theoretic areas open the capillaries. Circumferential sutures were also placed. So this was the post-operative view of this after we gave a free gingival graft, the pre-operative view and the post-operative view of the patient after he reported to us after removal of sutures. Next case was about a 35-year-old man. He came to our department with just a chief complaint of sensitivity in the upper tooth region since 3 months. So in this case, as the recession was shallow and not pocket probing depth was also minimum, we decided to go for a coronally positioned advanced flap. So in this procedure, basically what did we do? A partial thickness flap was created, apical to the area of recession and then reposition. So basically after we performed all the proper intraoral sepsis, we did it with 0.12% chlorohexidine, anesthesia, LA was administered, then 2 vertical incisions. 2 vertical incisions were made on both sides. Afterwards, we can, this is a view, internal bevel incision was made from the gingival margin to eliminate the pocket. Flap was raised with a sharp dissection. This is a picture. Then thorough root instrumentation was done, root planing was done. Flap was sutured coronal to the original position. So this is after this was the sutures placed. Then this was 10 days post-operative view of the same patient who came to our department for a follow-up. Next is a case report of a 32-year-old systemically healthy male patient. He had a chief complaint of receding gum in the anterior tooth region. The gingival recession was treated. It was a Miller's class 2 recession. So we treated it with the free gingival graft after we explained the entire procedure to the patient and taking his informed consent. So this was the same. We prepared the recipient side. Incision was given. Flap was raised, thorough scaling and root planing was done. Periosteum, and we prepared the recipient side. The periosteum was left covering the bone. Incisions were given. Then there was a soft tissue graft was taken. We took it from the palate we took it from the palatal root of the first molar and the distal line angle of the upper canine, keeping in mind so that there is no neurovascular bundle injury. This was a graft that we harvested. We placed the graft. Suturing was done, interrupted sutures were placed. So this was his post-operative view. After 10 days, he came to the department. So one only disadvantage, a little bit of a free gingival graft we saw was the color of the donor tissue. It can be clearly seen because the color alteration is the only disadvantage we could see. So we concluded that management of recession and sequelae is basically based on thorough assessment of etiological factors and degree of involvement of tissue. The results obtained in the 3 case series were desirable and it holds great promise for successful management of marginal tissue recession. Most important factor in treatment of recession always depends on the patient compliance, but free gingival graft that we used here in 2 case series was to increase the dimension of attached gingiva, its autogenous character, its maintenance of keratinization, predictability of surgical outcomes, the ease of technique together with the possibility of implementation in a group of teeth. They lead the free gingival graft to be accepted as a golden standard to increase the attached gingival dimensions. Thank you.
Okay, ma'am. You may start with question and answer session, ma'am.
Okay, Sonal, I would like to ask that what are the precautions to be taken while harvesting a connective tissue graft or a free gingival graft?
Good afternoon, ma'am. Ma'am, first we have to take a few precautions to keep in mind whether there is a proper thickness, the donor tissue has proper thickness. Secondly, we have to
should be the ideal thickness.
Ma'am, ideally we have to take a graft size of 2 to 3 mm. From the palate we harvest 1.5 to 2 mm. So we have to take care that the neurovascular bundle that is there, it does not get injured. Any anatomical considerations do not get hampered, ma'am.
Apart from that, anything else?
Ma'am, Ma'am, I think this only.
Okay, then read it. Okay. You told right, I'm not saying this, but it's more to it.
Okay, ma'am, I'll find that out more.
Yeah, and my next question is that what are the factors that limit the amount of food coverage?
Ma'am, factors which limit, ma'am, first depends on the patient's compliance.
Okay.
There are certain factors, ma'am, whether there is a presence of adequate attached gingiva is there. Ma'am, another factors like plaque and predisposing factors, mechanical factors, if they are hampering recession, if the patient is not systemically healthy or he cannot manage the graft or the surgical treatment we are giving to the patient, it can hamper the recession treatment.
Okay.
हेलो डॉक्टर सोनल.
Yes, ma'am.
ये केसेस आपने किए हैं सारे?
Ma'am, I have assisted my seniors.
Okay, so what are the minimum follow-up you think it's required for the root coverage? Because I don't think that you have shown any 3-month or 12-month follow-ups of any cases. You just have shown a 10 days follow-up.
Yes, ma'am. Ma'am, we have, I have 10 days post when he came for suture removal, that was the time only we have taken the photographs.
Is this an ideal time, or you need a more time to observe
This is not
to
the
observe a
ideal
success
time.
of root coverage?
We need to keep the patient on maintenance therapy and check after 3 months, 6 months, and 12 months. Follow up is very important.
Okay. Ma'am, over to you. Any question?
No, ma'am.
Thank you, Dr. Sonal Mittal. Moving
Thank you,
on to our next presentation. The presenter here is Dr. Sifalika Sinha.
Shifalika Sinha, and today I'm here with my presentation on post-COVID-19 intraoral mucormycosis, a catch-22 situation, a case report. While the world continues to battle with the pandemic of coronavirus disease 2019, the issue of post-COVID-19 complications has emerged as a significant problem. Post-COVID-19 complications may be associated with a wide range of bacterial and fungal co-infections. The main reason behind the co-infection is the use of corticosteroids and other adjunctive therapies to arrest any possibility of cytokine storm syndrome that may occur in critically ill patients. And one such deadly post-COVID-19 complication which is on rise is mucormycosis, which is commonly known as black fungus. It is an aggressive opportunistic fungal infection known to be associated with poor prognosis if not diagnosed and treated on time. And before COVID-19 pandemic, it was a rare fungal infection caused by a group of molds called mucormycetes. Now let's have a look at the case. A 52 years old male patient reported to our OPD in the month of December 2020 with a chief complaint of pain and swelling in the upper front teeth region in 2 months. The history of present illness was given as the patient was apparently all right 2 months ago when he developed pain over right middle third of face, upper back tooth region, right temporal region. Pain was continuous pricking and radiating in nature to the ears and temporal region, and there were no aggravating and relieving factor. Upon dwelling the past history, there was history of COVID-19 infection 5 months ago, and he was put on tablet pre-days 4 and COVID-4. He was a known case of hypertension and type 2 diabetes mellitus since 10 years, but blood sugar monitoring was infrequent. There was a history of extraction 5 years ago with respect to 1/6. On extraoral examination, there was mild facial asymmetry noted on the right middle third of face, diffuse swelling noted on the right middle third of face, extending from the right ala of nose to right infraorbital rim and tragus, and inferiorly up to lower border of mandible. There was tenderness present on right medial canthus in frontotemporal region, and bilateral submandibular lymph nodes were tender on palpation. On intraoral examination, there was generalized gingival inflammation, bleeding on probing with 1/8 to 2/3, pocket with 1/7, 1/5, 1/4, 1/3, and ulcers on the attached gingiva with 1/3 to 2/3, periodontal abscess with 1/7, 1/5, 1/1, 2/3, and sinus opening was seen with 1/4. There were various grades of mobility with 7 teeth, as well as a palatal abscess was noted with 1 teeth. The provisional diagnosis of this case was given as generalized periodontitis, and the differential diagnosis was given as mucormycosis because we had started reporting cases of mucormycosis in COVID-19 recovered patients at our hospital around that time. The patient was subjected to blood investigations which revealed high blood sugar levels, and the pus was sent for culture sensitivity test and KOH staining, and the microscopy which revealed positive for fungal elements. Patient was subjected to various radiographic examinations, and the OPG here revealed loss of trabecular pattern from the distal aspect of 1/1 till the distal aspect of 2/4. CT scan revealed erosion of the alveolar process of maxilla on the right side crossing midline, extending up to the alveolar process and surface of 2/3. Circumferential mucosal thickening was noted involving right maxillary sinus, and mucosal thickening was noted in the left maxillary sinus as well. The bone biopsy was carried out, and figure 1 here reveals the fibrocollagenous tissue with various inflammatory components, and figure 2 shows the fungal elements with typical broad aseptate hyphae, and therefore histopathologically it was diagnosed as mucormycosis. After all the relevant examinations, the case was finally diagnosed as the mucormycosis of maxilla. After confirmation with the CT scans, the patient was admitted at our hospital and was administered 2 doses of liposomal amphotericin B, and thorough debridement and extraction of the teeth from 2/4 to 1/8 was done, followed by primary closure under general anesthesia. Postoperatively, intravenous injection of liposomal amphotericin B was given, along with antibiotics and analgesics. And these are the follow-up pictures after 1 week of surgery, which showed uneventful healing. Postoperative CT scan here was taken at 3 months, which showed hypodensity of the maxilla on the right side, indicating the hemimaxillectomy that was done as a part of the surgical procedure, and no further changes were seen. The patient is under regular follow-up. The diagnosis of our case, along with the possible etiologies like uncontrolled diabetes mellitus, administration of steroids, and other immunomodulatory drugs due to COVID-19, was in concordance with the results of various studies done by Mehta et al., Maini et al., and Garg et al. The exact incidence of mucormycosis in India is unknown due to the lack of population-based studies. The estimated prevalence of mucormycosis is around 70 times higher in India than that in global data. Now, there can be various predisposing factors for mucormycosis like uncontrolled diabetes mellitus, corticosteroid therapy, which was seen in our case, and other factors like comorbidities of organ or bone marrow transplantation, hematological malignancy, prolonged ICU stay, increased serum levels of available iron on which the Rhizopus oryzae causative organism tends to feed, and deferoxamine therapy. Let's have a look at the possible reasons for the association of diabetes and mucormycosis. Number one being the impaired neutrophil function, reduced binding of transferrin to iron in acidotic conditions, increased GRP78, and through structural and functional modification of platelet membrane properties. Whereas the association of steroids and mucormycosis is mainly due to hyperglycemia and impaired function of the neutrophil. Now, COVID-19 patients could be at high risk for mucormycosis for various reasons like lymphopenia, high dose and early initiation of steroids, uncontrolled diabetes, which was in correlation with our case, and high levels of IL-6 and ferritin, tocilizumab and other immunomodulators, neutropenia, prolonged use of broad-spectrum antibiotics. And this is where the title of this case report as Catch-22 is justified, because Catch-22 means a paradoxical situation wherein two factors are co-dependent and one factor is the cause for the other. And in our case, even though we knew that steroids could create a perfect environment for the fungus to grow in case of an uncontrolled diabetes patient, but we cannot refrain the patient from administration of steroids. Now, according to the recent guidelines issued by ICMR, if any COVID-19 patients, uncontrolled diabetics or immunosuppressed individuals have reported with following signs and symptoms like sinusitis, one-sided facial pain, blackish discoloration over bridge of the nose, toothache, loosening of teeth, jaw involvement, blurred vision, chest pain, then we need to suspect mucormycosis in such patients. Now, I would like to conclude this by saying that during this pandemic that we are dealing with, it becomes extremely important to keep a close watch on the post-COVID-19 complications in order to reduce any further discomfort to the patient. Any COVID-19 recovered patient that visits us in the first 4 to 5 months post-recovery with unexplained pain in the teeth, mobile teeth, multiple abscess, we need to suspect mucormycosis. Now, the take-home message here would be that dentists, especially periodontists, are going to play a key role and first window in the early diagnosis of this disease. And it's the need of the hour to create awareness amongst the population that after recovery from COVID-19, every patient needs to visit the dentist for regular dental checkups every week for at least 4 months, because this century's old quote by the famous Dutch philosopher Erasmus still holds true that prevention is better than cure. I would like to acknowledge the efforts and contribution of all my professors and colleagues who helped me through this case and presentation. Thank you.
Ma'am, Jayashree ma'am and Poonam ma'am, you can start with the question answer session now.
Okay, sir. Dr. Poonam, you would like to ask?
Hi, Shipali.
It was a good presentation.
Good afternoon, ma'am.
It was a good, yeah.
Thank
it was
you.
a good presentation.
Yeah, what I was asking, Shipali, what is the post-operative plan for this patient?
Ma'am, post-operatively, this patient is under regular follow-up. So we had done the hemimaxillectomy and basically we had removed all the necrotic bone or structures, whichever was involved. And after that, the proper closure was done and feeding plate has been given to the patient. He has to come back for prosthetic rehabilitation, but because of the COVID scenario, he hasn't reported back to us. But I think he came to our hospital till March of this year, but after that he said once the COVID scenario comes down, he would come for prosthetic rehabilitation. But right now he has been given feeding plate.
Okay. You have told that your patient is uncontrolled diabetic.
Yes,
right?
ma'am. Yes,
HbA1c is 8.9.
Yes, ma'am.
Okay. So was it uncontrolled diabetic before or after COVID or after or corticosteroid therapy he became uncontrolled diabetic?
Ma'am, actually, the patient's son had told us that the patient was always on the higher end of the levels, like his random blood sugar levels were always above 200. So he has this history of infrequent monitoring of the blood sugar as well. So even before the COVID infection, as per whatever history was given by the patient, he was on the uncontrolled side.
Okay. Thank you. Jayashree ma'am, over to you.
No,
It's okay.
Okay, thank you, Dr. Shifalika.
It was indeed a very good presentation by Shifalika. Everything was very clear and nice presentation.
Thank you so much. Thank you. Thank you.
Okay, thank you, Dr. Shifalika. We can now move on to our next presenter, Dr. Ritesh K.
Good morning, respected judges. Now, management of ridge defects in the anterior region aesthetic zone is often a clinician's challenge. There are various surgical procedures and techniques which enable us to restore the bone defects. Now, today I'll be talking about onlay graft for aesthetic zone augmentation, a case report. I'm Dr. Ritesh K. Now, coming to introduction. Now, tooth loss in the anterior region and subsequent ridge resorption affects the ridge architecture, resulting in horizontal and vertical ridge defects. Now, the deficiency of buccal bone has a negative impact on the aesthetic outcome and the implant stability. So, the restored implant should not only restore the function, but also aesthetically blend or with the hard and soft tissues of the adjacent natural dentition. Now, the various bone augmentation procedures to restore the ridge defects allows us to place the implant in a three-dimensional position to achieve long-term function and predictable aesthetics. Now, among the various bone augmentation materials available, the autogenous bone has the inherent features of osteoconductive, osteoinductive, osteogenic features. Now, also the absence of immunologic reaction makes it into a gold standard procedure. Now, the bone block grafts can be obtained either from an intraoral source or an extraoral source. The intraoral source commonly is from the symphysis and the ramus area, and the extraoral source is the iliac crest or the tibia. Now, coming to the case report, 28-year-old female patient with a missing lateral incisor wanted a fixed replacement for the same. The patient gave a history of mobility of the tooth and subsequently got it extracted. On clinical examination of the ridge area, a three-stage treatment plan was planned. Now, the first stage involved restoring the bone defect with an onlay graft. Now, the second surgical stage involved the implant placement. Now, the third stage involved exposure of the implant. So that is the second stage surgical procedure for the implant exposure and also prosthetic restoration of the implant. Now, the pre-op photographs shows the ridge defect can be appreciated in the 2-2 region. The marking of the ridge defect showed that the dimension of the ridge defect was not adequate enough for implant placement. There was a horizontal defect, and restoring the bone volume by using an onlay graft was planned. Now, the first surgical stage was carried out under local anesthesia. A remote palatal incision was given at the edentulous site, extending intracircularly on one tooth on each side with a divergent vertical releasing incision. which provided better access to the recipient or the defect site, and also allowed for the movement of the flap after the graft placement. Now, obtaining the block graft. Now, the block graft was obtained from the ramus, right ramus body of the ramus using a piezosurgery, the variosurge. Now, the advantage of using the piezosurgical unit is the precise cuts along the bone margins, bone block, can be obtained using piezosurgery compared to surgical drills. However, piezosurgery takes slightly more time than compared to the surgical drills. The block graft which was obtained was trimmed for better adaptation to the recipient site, and it was immersed in the saline to prevent any dehydration. 1.3 mm diameter bone graft fixing screw was used to fix the bone block. Now, fixation of the bone block graft at the recipient site. Now, prior to the fixation of the block graft at the recipient site, the recipient site was perforated using a high-speed round burr under copious irrigation, and then the block graft was placed and fixed onto the recipient site. Now, this perforations created at the recipient site creates a bed for the block graft, and the surrounding area after the fixation of the block graft was filled with the synthetic hydroxyapatite graft. And after the graft was placed, bone graft was placed, a pre-operative membrane was prepared and placed over the block graft, and a tension-free flap closure was obtained by giving periosteal releasing incision, and a complete closure was obtained over the graft. Now, the second surgical stage. Now, the second surgical stage was planned after a post-op period of 6 months of healing. In the image, the definite increase in the bone volume can be appreciated. A fill thickness flap was reflected, and on exposure of the surgical site, the bone block had integrated well at the recipient site. An implant placement was planned. Now, prior to the implant placement, the fixation screw was removed, and an MIS 3.3 by 11.5 implant was placed, and achieving about 25 NCM torque. Now, the flaps was sutured, and immediate post-op IOP shows the position of the implant. Now, coming to the third stage. Now, the third stage involved the exposure of the implant, or the second stage surgery of the implant. Papilla sparing incision was planned to maintain the height of the papilla, to preserve the height of the papilla. Now, a papilla sparing incision along with a roll flap was done in order to augment or to preserve the keratinized mucosa around the implant. The roll flap was sutured, and thereby able to achieve or improve the keratinized mucosa around the implant. After a healing of 2 weeks and the formation of a nice epithelial cuff around the implant, the prosthetic phase of the implant restoration was started, and a cement retained crown was given to obtain the optimal aesthetics. Coming to the discussion, onlay graft is a viable treatment option, and the use of intraoral donor sites from the symphysis and the ramus has several advantages compared to the extraoral sites with less resorption and faster revascularization. However, bone harvesting and also the bone harvesting can be performed under local anesthesia without the need of general anesthesia. Now, coming to the conclusion, onlay bone grafting is considered as a gold standard for augmentation of the resorbed alveolar ridge, and bone grafting done in this case was the block graft was obtained from the mandibular ramus and was able to restore the bone volume adequately, allowing us a delayed 3-dimensional implant placement and also providing successful functional and aesthetic outcomes for the long-term survival of the implant. Thank you.
Can I ask with question and suggestion?
Good afternoon, ma'am.
Good afternoon, Ritesh. It was a good presentation, but initially when you had started off, it seemed as if there was complete lack of energy. Totally, somebody had drained out the energy from out of you. So always keep that. Later on, you gained up the momentum and you came into the flow. But starting was a little bit slow. In your next presentations, make it like the momentum should go on from the beginning till end the same.
Okay, ma'am, sure.
The presentation was good.
Dr. Ritesh,
Yeah, ma'am, tell me.
is it your case?
Yes, ma'am, it's my case.
Okay, but I think photograph must be better, little better. Intraoperative photographs are not clear.
Yeah, but ma'am, whatever, because I've been working in the implant department for past 10 years. So this is a follow-up case only. The photographs, yes, ma'am, because you will be doing it and the photographs will be taken by either your PGs or anyone. So sometimes, yes, we cannot get the exact photographs required.
Okay. Okay, overall, it was a nice presentation.
Thank you, ma'am. Thank you.
Thank you, Dr. Ritesh. Ma'am, we'll move on to our next presenter, Dr. AJ Asmi.
Yes.
This topic is about Vilcodontics, a contemporary approach for orthodontic tooth movement, a case report. And these are my contents. Coming to the introduction, the orthodontic treatment is benefits for various ways for the aesthetic demands and improved occlusion and aligned teeth. So, therefore, for the patients with malocclusion, for the aesthetic problems, the orthodontic treatment is very necessary. But since there is many problems associated with conventional orthodontic problems, the orthodontic treatment, that is the longer duration of the time, dentofacial aesthetics, and the type of appearance what they causes the further complications. So this conventional orthodontic treatment normally takes up to time of 18 to 24 months to achieve the desired result. But in complex cases, when the time prolongs, it may cause the periodontal disease and bone loss, and further it can also cause the relapse cases. So the patients are in need to remove the braces for the aesthetic demands. So the various methods to overcome this problems, there are various methods to accelerate the tooth movement rapidly. So by this we can avoid the short duration. We can do the short duration of the time, and we can move the faster treatment process. So there are many ways. One is the drugs, surgical method, physical and mechanical stimulation methods. So surgical methods are better than other methods they have been said, and most effective methods. The various surgical approaches are said to be corticotomy, Vilcodontic, and physiosession. So recent surgical orthodontic therapy, which was introduced by Wilco and brothers, which involves the combination of selective decortication process with the alveolar augmentation, which is initially called as the accelerated osteogenic orthodontics. Therefore, orthodontics is the technique used to reduce the orthodontic treatment and to achieve the faster tooth movement when compared to the traditional or conventional orthodontic. So it is based upon the theory called as the regional accelerative phenomenon. That is, it is achieved by two main features. One is them to decrease the regional bone density and to accelerate the bone turnover. So other names have been said as periodontally accelerated osteogenic orthodontics and corticotomy facilitated osteogenic orthodontics. And indications: it is indicated in class 1 with moderate to severe crowding, class 2 with extractions, and mild class 3 cases, and also it is indicated for arch expansion, molar uprighting, and molar distalization. Like that, it is various in various cases indicated. Contraindications: in severe class 3 cases we cannot be used, and in active periodontal diseases or with gingival recession we cannot be used, and it should not be considered alternatively for the surgically assisted palatal expansion, and inadequately treated endodontic problems also they cannot be considered. Now we can come into the bone biomechanics, how it is worked, this PO, how it is worked. This PAO surgery is not a technique to remove of the bone. It is just to the external surface of the bone is removed by the process called as the decortication. The bone then undergoes process of the process called as the osteopenia, where the mineralization and the protein content is reduced and the regional accelerative phenomena is activated, and thereby the tissues of the alveolar bone releases the rich number of the calcium from the spongiosa consisting of the osteoclasts and osteocytic. And this, it will takes about, this process, the tissues of the alveolar bone releases the calcium, it will take about 20 to 55 days. So after the alveolar bone is in the transient phase. Transient phase, the braces can move the teeth quickly because the bone becomes softer and less resistant, and there is a less resistance to the force from the braces. So recovery of the PAO surgery, the total recovery is considered to be 7 to 10 days. There might be a swelling and pain like that, and the analgesics and antibiotics with chlorhexidine mouthwash can be prescribed. What is the significance of the velcodontics? There is an increased width of the alveolar bone by placing the alveolar graft, that is the alveolar graft for alveolar augmentation, shorter treatment duration, and greater post-treatment stability and decreased apical root resorption. And what is the current concept of the velcodontics? In cases of thin gingival biotip, there is a chances of recession or the exposure of the ring. In that cases, we can use the autogenous soft graft, which is harvested from the palatal, keratinized palatal tissue. Otherwise, we can use the platelet-rich plasma, platelet-rich fibrin, and the growth factors. And the advantages of the PAO surgery: reduced treatment time, history of the relapse is low, and more bone support compared to the conventional treatment. And then disadvantages, which includes the extra surgical cost and pain and swelling, recession, post-surgical crustal bone loss. In my case, a patient was reported from the orthodontics for the face closure. After the orthodontic treatment has been completed for it is incomplete, but still in the 1 year of the treatment phase, there is a need for the space closure, and we have attempted the PAO surgery. There is a medical history, no allergies or medical problem, no TMJ dysfunctions, and her intraoral examinations reveals that the upper anterior, first initially there was an upper anterior spacing, and there is a closure between, it is a mild space between the molars and the premolars, as you can see in the palatal view and in the lingual view. And first, the submarginal incision is placed to preserve the marginal integrity of the tissues. So the flap was, then the mucoperiosteal flap was elevated, and using the stripe fissure bar, using with the micromotor, they have placed them. We have placed the vertical grooves between the two interradicular spaces, and then placement of the graft is placed. I have used the osteograft, demineralized bone matrix. It have been used, and contents and then sutures and copax were placed. And these are the 2 months post-operative view. That is, we can see the various difference between the molars and the premolar teeth region, the palatal side. Now coming to the discussion, the procedure for the velcodontics is advantageous when compared to the conventional treatment because it takes lesser time and lesser root resorption is achieved. And Haji et al. Has been said that the average time of the velcodontic treatment is reduced to 1/3 of the time compared to the conventional treatment. And this case reported the further space closure and faster treatment duration when the PU was attempted. So, and also, as I said before, it activates by the regionally accelerated phenomena. And also, first I have done the velcodontic, then by decortication and the alveolar graft placement, and the post-operative complication also lesser, and good space closure was also seen. And coming to the conclusion, this technique favors the shorter treatment duration, which covers the simple and the complex malocclusion with good clinical stability. So, I have said when compared to the convention, I was said that this case, in my case report, it was shown the very good space closure after the 2 months itself. So, as it has to be a new procedure, long-term follow-up studies has been needed with increased sample size to prove the efficacy of this technique. And these are my references. Thank you.
Ma'am, you may start with questions session.
Okay, Ashmi, I want to ask you that how is this the movement different from the tooth movement with a conventional orthodontic treatment?
From the baseline and from the post-operative, after the recovery of the velcodontics treatment, the measurement with the space closure was measured using the vernier caliper, ma'am. There was various difference between the pre-operative view and the post-operative view, ma'am.
Did you get my question?
Ma'am,
were you able to understand what I said?
Ma'am, once again, ma'am, please.
How is the movement different? इसमें जो तुम ये प्रोसीजर कर रही हो ये कैसे डिफरेंट है जो नॉर्मल हम कन्वेंशनल ऑर्थोडोंटिक ट्रीटमेंट करते हैं उसमें जो टूथ मूवमेंट होता है और इसमें जो होता है उसमें कुछ
मैम तमिल मैम
is there any difference in the movement? Like which when you do a conventional orthodontic treatment and like इसमें जो कर रही हो
Yes, ma'am. Because when doing the rapid while doing the micro trauma to the bone, there will be a difference between the normal traditional and the velcodontic procedure because the bones become softer than the normal one. So therefore, the remineralization of the bone happens here, ma'am. So thereby, the faster and rapid tooth movement will happen through the help with the help of the systemic and the local inflammatory markers such as the cytokines and like that, ma'am. Because the compression and the tension forces will act on the tooth, ma'am. It will differ from because of the inflammatory markers, ma'am.
Okay, I wanted to ask you that what is the rationale of adding bone graft in the pound technique?
Because the alveolar bone thickness will increase, ma'am. The alveolar bone thickness and the bone augmentation will help for further tooth movement to happen.
What would be the ideal bone graft material? What will you use? What is the choice of bone graft material which you will use?
Ma'am, alloplast is nowadays it is sufficient. It is each bone graft will have several disadvantages, but allograft and alloplast is nowadays used.
Are you sure what is the choice of material for the decorticated areas?
The allograft they will use.
Okay, read it.
Okay, thank you.
Okay. Dr. Ashmi, it was a nice presentation, but can you tell me what are the contraindication of this technique?
Yes, ma'am. In periodontally active diseases, we cannot use this technique, ma'am. And bimaxillary protrusion cases, we cannot use. And then class 3 malocclusion, we cannot use this velcodontic procedures. Because in periodontally active diseases, the more number of bone loss will be present. So when the periodontitis is in accelerated phase, then when we are using this velcodontic procedure, there will be for the treatment outcome will be less favorable.
Okay. Over to you, ma'am.
Thank you, Doctor. Okay, ma'am. Thank you, Dr. Asmi. With this, we end our session. Dr. Poonam ma'am and Dr. Jayasri Garg ma'am, thank you very much for taking out your valuable time and being a part of this virtual PG convention, ma'am. Okay, ma'am. Thank you very much. I have to move on to the next session, ma'am.
Okay, thank you.
Okay. Thank you.
Thank you, ma'am. Thank you very much.
So we can leave now, na?
We can leave now then.
Yes, ma'am. Ma'am, a gentle reminder, please do submit that evaluation sheet to the Subhash Chandra Sir's number.
Okay.
Yes, ma'am. Yes, ma'am. Thank you, ma'am. Now, I would like to invite our next chairpersons, Dr. Elora Madan ma'am, professor from the Department of Perology, Kuthiwala Dental College and Research Center, and Dr. Gatha Mohanty ma'am, reader from Department of Periodontology, Institute of Dental Science, Bhubaneswar. Ma'am, heartily welcome.
Hello, ma'am. Thank you so much. Hello, ma'am.
Please, ma'am.
Thank you so much.
to chair this session. And our presenter here is Dr. Naskata Savana.
Good morning to one and all. Today I am going to present a title on Gold Standard Approach to Restore Aesthetics, a case report. As everyone knows, gingival recession is one of the most common aesthetic concerns associated with the periodontal tissues. Major therapeutic goal in plastic surgical procedures are correction of aesthetic problems, hypersensitivity, and shallow root caries lesions. Till now, several techniques such as pre-gingival graft, laterally positioned flap, coronally advanced flap, and double papillar graft have been proposed for the correction of various mucogingival deformities. Among those, coronally advanced flap with the connective tissue graft is considered as gold standard treatment of gingival recession due to high predictability of treatment results. In the recent systematic review, according to Chambron et al. In 2015, subepithelial connective tissue graft-based procedures together with coronally advanced flap demonstrated best clinical outcomes. Connective tissue graft is considered superior to other soft tissue graft procedures because of its high predictability and aesthetic outcome. This is a case report of a 21-year-old male patient reported with a chief complaint of receding gums and sensitivity in relation to O3. Intraorally, gingival examination revealed Miller's class 1 recession in relation to O3. Recession depth was about 3 mm and recession width was about 2 mm. On periodontal examination, probing depth was about 1 mm. There was no mobility present and the total loss of attachment was about 4 mm. Treatment plan of following case was phase 1 therapy, which include oral hygiene instructions and brushing techniques were given. Patient was motivated and further scaling and root planing were carried out. In surgical phase, coronally advanced flap with connective tissue graft was done. Coming to the surgical procedure, under COVID-19 protocol, patient preparation was done and local anesthesia was given. Then circular incision was made on the labial aspect of the O3, followed by two vertical incisions were made on the distal and mesial line angles, which was continued beyond the mucogingival junction into the alveolar mucosa. Then trapezoidal full thickness flap was raised beyond mucogingival junction, and beyond that, partial thickness flap was raised in the alveolar mucosa. Next, the dimensions of defect was measured by using a periodontal probe in order to harvest the connective tissue graft. At donor side, single incision was made 2 mm apical to the gingival margin of palate from lateral incisor to first premolar region. Here, the blade was placed perpendicular to the long axis of the tooth. Then, the partial thickness flap was raised as apically as required in accordance with the defect size. Then, the blade was angled perpendicular to the palate through the same incision. Followed by the connective tissue was elevated from the underlying bone by using a periosteal elevator. Then two vertical incision was made on the mesial and distal end of the graft, and horizontal medial incision is made to release the graft from the surrounding tissue. Finally, connective tissue graft was harvested. Then this harvested connective tissue graft was adapted in the involved region of O3 to cover the exposed root surface. Then the full thickness flap was coronally advanced and sutured in combination with sling suture and interpret suture to ensure the complete coverage of connective tissue graft. Then donor site was also sutured and custom-made acrylic stent was placed. Patient was recalled after 10 days. On examination, healing was found to be satisfactory. In this slide, the first picture shows preoperative picture in which periodontal probe is used to measure the recession length. Then second picture shows postoperative picture of 10 days. Third picture shows 6 months follow-up picture. Coming to the discussion, the success of surgical procedures for root coverage depends on several factors such as elimination or control of the etiology of gingival recession, interproximal bone level, and choice of the most appropriate surgical technique, which are inherent to each clinical situation and region to be treated. Several mucogingival techniques have been introduced in literature aiming to correct marginal tissue recessions. During the decades of 1960s and 70s, commonly used techniques were coronally positioned flap, laterally displaced flap, and the combination of coronally positioned flap with the pre-gingival graft. The coronally advanced flap procedure has been used long as an aesthetic root coverage procedure and as a treatment modality for tooth sensitivity as a result of gingival recession. It should be kept in mind that coronally advanced flap alone has a positive effect on keratinized tissue width because the biological activity of the granulation tissue is derived from the periodontal ligament. In 1985, Langer and Langer described a technique of subepithelial connective tissue graft for root coverage in the treatment of recessions at single or multiple areas, attributing the procedure success to the double blood supply for the graft's nutrition originating from the connective tissue of both the periosteum and a flap. Several studies have shown favorable results with the use of connective tissue graft in the treatment of gingival recession. In 1987, Nelson suggested the use of a full thickness flap to cover the subepithelial connective tissue graft. However, other studies showed no difference from those of a partial thickness flap. Ritz in 1985 suggested the envelope technique in which subepithelial connective tissue graft is placed in the space between the partial thickness flap and the denuded surface of root, with or without a strap of marginal epithelium, without vertical releasing incisions. Then, placement of the connective tissue between the flap and denuded root surface is referred to as a bilaminar technique. Coronally advanced flap with the connective tissue graft is considered gold standard of treatment of gingival recession due to its high predictability of treatment results. In this case, single incision technique was advocated to reduce the trauma and pain experienced by patient at the donor site. The present treatment modality resulted in significant root coverage with healthy keratinized tissue and resolution of hypersensitivity of the exposed root after 6 months. Finally, I'm concluding wide array of surgical procedures are available in the management of gingival recessions. Connective tissue is considered as gold standard techniques in terms of achieving color match and width of keratinized gingiva. Ideal case selection is essential to achieve success in root coverage. Aesthetic outcome achieved with the combination of coronally advanced flap and connective tissue graft has shown promising results at the end of 6 months. Thank you.
Ma'am, you may start with question and answer session.
Am I audible? Good afternoon. In the present case, what was the classification? I mean, the two that you took up for recession coverage, what was the grade of recession, class of recession?
Ma'am, Miller's class 1 recession, ma'am.
Okay, what about class 3 and class 4? See, class 1 is very easy to cover up. What treatment modalities would you suggest for class 3 and class 4 recession?
For class 1 recession, coronally advanced flap with a connective tissue graft. Class 2, class 3 recession with the gingival augmentation, two-stage technique, like gingival augmentation, then second stage technique with the pre-gingival graft. In second stage, laterally sliding flap with root coverage. No?
Okay, fine. And what about palatal recessions? Have you ever tried that? Okay. Gatha ma'am, please go ahead.
Yeah, Dr. Sabana, it was a very good presentation. But I would like to know, why did you choose a canine?
Canine.
Do you have? Is there any other disadvantages while we choose a canine?
Actually, the canine is a corner tooth of the arch, ma'am. Because of the root prominence and there are more chance to recession occur because of that faulty brushing technique. Also, because of that corner tooth, that faulty brushing technique give more pressure to that specified canine region, ma'am. That's why the recession is more common in the canine region. Then my patient felt hypersensitivity also. So
what was the cause? What was the cause of the recession? Did you find out?
Cause of the recession is root prominence, ma'am. Then thin gingival biotype. My patient have thin gingival biotype. Then root prominence. Then faulty brushing technique also. That's why, ma'am.
Okay.
Thank you.
Thank you, Dr. Savana. Our next presenter is Dr. Sadaf.
Good morning, everyone. I'm a third year postgraduate student of Meghna Dental College. I'll be presenting a case report of the conditioned gingival enlargement. I would like to give my thanks to my HOD, Sir Dr. Hemachandra Babu, and my guide, Dr. Lakshman Bayopati. Gingival hyperplasia is an atypical increase in the number of healthy cells in normal alignment in a tissue. Gingival hyperplasia can be a result of unusual tissue to the inflammation caused by local irritants such as plaque and calculus, or it might also be caused by systemic disturbances or hormonal changes or medication, especially like cyclosporin, nifedipine, and phenytoin. Enlargement can also occur during puberty. It can occur in both females and males. In areas of plaque accumulation, the size of gingival inflammation can exceed can usually is usually seen in association with the local factors. It is usually seen in marginal and interdental papilla, and it is characterized by bulbous interproximal papilla. Puberty is a complex process of sexual maturity resulting in an individual capable of reproduction, which induces changes in physical appearance and behavior, and it is induced by hormones, primarily testosterone in males and estradiol in females. These hormones exert effect on different tissues. In gingiva, these six steroid hormones can influence in cell division, growth and differentiation of fibroblasts and keratinocytes. There might be also alterations in blood vessels, which is caused by estrogen and stimulation of the production of inflammatory mediators, mainly by progesterone, which can lead to exaggerated response of the gingival tissues. Puberty associated gingival enlargement falls into the category of conditioned gingival enlargement, as the presence of plaque is necessary for such type of enlargement. In addition, Capnocytophaga species, another gram-negative bacteria, also increases the incidence as well as in proportion. The main objective was to identify the typical case of puberty-induced gingival enlargement and the healthy form and consistency of the gingiva was to be achieved. A 14-year-old female patient reported to the Department of Periodontics in Meghna Dental College, Meghna Institute of Dental Sciences, Nizamabad, with a chief complaint of swollen gums in the left upper back teeth region since 1 year. The growth gradually kept increasing in size since its inception to its noticeable current size. It was associated with bleeding from gums on brushing. The medical history revealed that the patient started menstruation 1 year back, and the gums had also started swelling almost concomitant with it. Dental history revealed that there was no history of trauma to the upper front teeth region. These are the occlusal photographs of the patients, preoperative photographs of the patient, and these are the occlusal photographs of the patient. On intraoral examination, a reddish pink bulging of the interproximal papilla with blunt and rounded marginal gingiva was found on the facial surface extending from the mesial surface of 2-3 to distal surfaces of 2-7. It was soft, edematous, and friable and bled on slightest provocation. There was a presence of some amount of marginal plaque and calculus. On radiographic interpretation, the IOPA did not show any abnormalities involving the alveolar bone, periodontal ligament space, or the lamina dura. Treatment plan: after routine oral prophylaxis was performed, the patient was recalled after 1 month. On re-evaluation, the inflammatory component of the enlarged gingiva had subsided, but there was still presence of fibrous component that compromised the routine oral hygiene measures, and so gingivectomy was performed to excise the bulge of the tissue and to regain the health form and consistency of the gingiva. The tissue was sent for histopathological examination. This was the tissue excised for histological examination. On histological examination, histological findings revealed that hematoxylin and eosin stains show the presence of hyperplastic parakeratinized stratified squamous epithelium. The underlying connective tissue showed intense chronic inflammatory cell infiltrate with small and large endothelial lined engorged blood vessels. The connective tissue moderately had collagenous stroma. These are the post-operative photographs after 1 month. Post-operative evaluation. After the patient was recalled after 1 month, there was no recurrence of the gingival enlargement. The gingiva was in normal consistency with normal contour. The patient was given an oral hygiene instructions, that is, the patient was asked to use oral rinses and interdental aids like oral floss and interdental brushes. Thank you.
So that was a nice presentation. Now, what is the current classification system as offered by the 13th edition of Karenza? What is the current, the latest classification given by Karenza of gingival enlargement? And how is it different from the previous one?
Ma'am, earlier the gingival enlargement, it was known by different names like gingival hypertrophied gingiva or gingival hyperplasia. Now the current terminologies are gingival enlargement or gingival overgrowth.
I completely agree. I'm talking about the classification. Previously, in the 10th edition of Karenza, it was a very elaborate classification system. It is still followed to an extent. What is the change that has been made in the 13th edition?
Conditioned has been divided into hormonal and
okay, what are the other examples of conditioned enlargement apart from puberty?
According hormonal are pregnancy and puberty, ma'am, and other examples are non-specific conditions are like pyogenic granuloma and also allergic, ma'am. Because of allergy.
Gatha ma'am, over to you.
Okay, Dr. Sadaf, it was a good presentation, but I could not see the pictures very clearly. Exactly. So, yes, so once you do a presentation, the pictures have to be really clear. We wanted to see the kind of enlargement. You could see the redness, which is typical. Okay, that we could not see. We didn't see how you did the gingivectomy procedure also. So you should have given better pictures because this is a presentation based on what you are doing, isn't it?
Yes,
so for the next time, you keep that in mind. Now, if I say, what did you use? Gingivectomy, how did you carry out? With the scalpel?
Gingivectomy was done by diode laser, ma'am.
Okay, you used a laser. So what are the advantages of laser?
Ma'am, it is a bloodless process. Patient does not have any pain. So patient was very cooperative during laser therapy, ma'am. So it was very easy to do with laser rather than scalpel.
Okay.
Thank you, Dr. Sadaf. Our next presenter is Dr. T. Hudson Jonathan.
A very good morning to the respected judges and other participants of PG convention. I am here to present my topic on laser depigmentation brings back the confidence in my case series. So these are my contents. So coming to introduction, a beautiful smile surely enhances the individual's self-confidence, and normally the harmony of smile is attributed to the shape, color, and position of teeth in conjunction with the gingival tissue. So the gingival health and appearance are essential components for an attractive smile, and so the removal of unslightly pigmented gingiva is a need for a pleasant and confident smile. So the pigmentation of gingiva is considered to be unaesthetic by patients, and it may have a psychological impact on them, especially those who are having a gummy smile where there is excessive gingival display. So the physiological pigmentation is mainly due to genetically determined factors and like endocrine glands, ultraviolet radiation, smoking, medication, and also these can cause hyperpigmentation. So coming to gingival hyperpigmentation, it is defined as a darker gingival color beyond what is normally expected. So the pigmentation is normally contributed by melanin, melanoid, carotene, oxyhemoglobin, reduced hemoglobin, bilirubin, and iron, and or pathological diseases and conditions. So melanin is said to be a brown pigment located in basal and suprabasal layers of gingival epithelium, and due to the excessive deposition of melanin, it results in this hyperpigmentation condition. So the gingival depigmentation procedure, it can be defined as a periodontal plastic surgical procedure where the gingival hyperpigmentation is removed or reduced by various techniques. So it's not a clinical indication, but a treatment of choice for the aesthetics, and is desired by the patients. So various techniques are available for a depigmentation procedure, and it includes the chemical method using the alcohol, phenol, ascorbic acid, surgical methods, conventional techniques like gingival abrasion, split thickness epithelial excision, scalpel surgical techniques, free gingival grafting, acellular dermomatrix, electrosurgery, lasers, cryosurgery, and radiosurgery. So the gingival depigmentation using laser. So the laser is an acronym for light amplification by stimulated emission of radiation. So it functions by stimulating the emission of light energy from a given medium in a collimated focused monochromatic ray of light. So this energy beam reacts with the target tissue by being absorbed, reflected, or scattered depending on the wavelength and absorption characteristics. So various lasers are used for depigmentation. That is carbon dioxide lasers, diode laser, neodymium young lasers, erbium young lasers. So here we are going to speak specifically about the use of diode lasers, and the method is after application of topical anesthesia. So the depigmentation is done with the light brushing strokes, and the tip is kept in motion all the time. So now the remnant of the ablated tissue is removed using sterile gauze dampened with saline solution. This procedure is repeated until the desired depth of tissue removal is achieved. Then the wound is covered with periodontal pack and patient is recalled for it. So where we can see here the till the basal layer, the remnant of the pigmented tissue is removed. So the diode laser with 810 nanometer wavelength is used in soft tissue for coagulation and cutting, and this laser radiation also has bactericidal effect, resulting in hemostasis. So having a high affinity to penetrate into hemoglobin and melanin pigments makes it the preferred laser for depigmentation of gingiva. And the lasers can be used both in pulsed and continuous mode. An application of the laser in pulsed mode prevents overheating of surrounding tissues that may cause necrosis and geoparadise healing. So the repigmentation may also occur depending on the technique used and the race of the patients. So according to the theory, melanocytes migrate from the adjacent pigmented tissue to treated site, resulting in repigmentation. So coming to case series. So this is a 21 years old male patient, and this is a preoperative view where we can see a generalized hyperpigmentation, and is treated with the diode laser 1.0 volt. And this is the immediate post-op, and this is a post-op 9 months where we can see a nice healing and depigmentation. Pigmentation is reduced. And this is the case 2 of a patient age 25 years old male patient, where we can see a pigmentation seen in areas of anterior region, and the diode laser is applied. This is the immediate post-op, and this is a 3-week post-op where we can see a complete healing of the treated site with the reduced pigmentation. And this is the 2.5 years post-op where we can see a repigmentation happening when there is a longer follow-up. And this is a case 3. It is a 23 years old male patient where we can see a generalized dark gingival hyperpigmentation is there, and it's treated with the diode laser. And this is the immediate post-op. It's a 10 days post-op, and this is the 4 years and 10-month post-op where we can see the reappearance of the pigmentation. So coming to advantages, they enhance hemostatic activity, good visibility at the surgical site, ease of access to interdental papilla, fewer post-operative complications such as the pain, bleeding, edema, and infection. And disadvantages like it is a sophisticated, made with a sophisticated equipment, occupies larger space, expensive method. Inappropriate application can damage the gingiva alveolar bone, causing gingival recession, gingival fenestration, and delayed wound healing. So, coming to conclusion, in this case series, the use of 810 nanometer diode laser for depigmentation of gingiva resulted in complete healing after 1 to 2 months, but recurrence is seen in longer duration of follow-up. Relapse or repigmentation is a critical concern and depends on the technique employed and follow-up period. So, these are my references. Thank you.
Again, a good presentation. What are the indices that are used to assess pigmentation? Can you name any one index which is used to assess gingival pigmentation?
Dummet index from
index, yes.
1960.
Okay. Now, what is the range what range of wavelength within which the diode laser operates? You mentioned one, right? There's a range. So you perform this surgery at the range in the, I think, 810 nanometers. But what is the range?
From 800 to 910 nanometer wavelength.
Yes, most of the diode lasers we get operate in this range. But we have diodes that operate in the range of 650 nanometers as well. Okay, they're mostly used for diagnostic purposes. Ma'am.
Okay, Dr. Hudson, you showed us case series of this. What was the, why did you want to show us laser case series? And why didn't you compare it with something else? There are so many methods available. So why didn't you compare it with any other method, like a scalpel or something, any chemical method of depigmentation?
But in our college, we have done more laser cases, so it is suitable for us to correlate with each patient for longer period of follow-up is also available.
So you have shown us 3 cases, right? And in the 3 cases, one case we could see that there was some amount of repigmentation after 2.5 years. So did you see the repigmentation in all the 3 cases? Has it happened, or it is in one of the cases?
Actually, longer duration of follow-up, there seem to be higher repigmentation is seen occurring. In first case, there is only a minimum as there is a follow-up of 1 year. After 1 year, it showed only a minimum repigmentation only. But in later 4 years post-op, we have seen more of repigmentation occurring.
Okay. So do you follow the concept of pack here?
I didn't get, ma'am.
Do you give a co-pack? Do you give a co-pack or you don't give a co-pack?
Co-pack is not preferred in laser cases. If need, it can be given.
Who will need it? The patient won't tell you. The patient won't tell you that I need a co-pack, isn't it? Yes. Do you prefer giving a co-pack? I want to know what is your take on that?
No, ma'am. Co-pack not needed.
Okay. Thank you so much.
Thank you.
Thank you, Dr. Jonathan. Our next presentation by Dr. Asna Maria Beni.
A very good morning to one and all. Today's my presentation is about unilateral solitary lymphangioma circumscriptum of gingiva, a rare case report. So these are my contents. So coming to introduction, lymphangiomas are benign malformation of lymphatic vessels, which are slowly growing pale soft tissue mass, and they are characterized by abnormal proliferation of lymphatic channels, and they are seen as superficial or deep ones. So these lymphangiomas, they can be either be seen as in superficial ones or deep ones, and the lymphangiomas that present in superficial location, they are known as they are been seen as solitary lesions which has a pebbly surface, and therefore, and again the lymphangiomas which are in deep locations, they are seen as diffuse nodular mass. So this lymphangiomas, they are seen more in head and neck region, and 50% of the lesions, they are congenital, whereas 90% they arises within 2 years of age. So this lymphangioma, on the basis of histological classification, they are classified as capillary
excuse me, ma'am.
Lymphangioma and cystic lymphangioma.
Ma'am, excuse me, ma'am.
Ma'am,
this is not Asna Beni's video. Hello.
Yes. I think that was plasma cell gingivitis.
Yes, that was before Helder, ma'am.
Okay. So she is?
She is, ma'am, before one was Martha Matthew, and now Asna Veni is here.
But the ma'am, topic is
Topic is,
different,
ma'am,
right?
topic different. Plasma cell gingivitis here.
But she is presenting something on
Ma'am,
lymphangioma.
excuse me, ma'am, this is not my presentation.
Yes, it's not you.
So I didn't get you actually.
Asna Benny, so Asna Benny, would you like to share your PPT yourself?
Yes, sir, but sir, I have to connect it from my laptop. Then right now I'm connected from my phone. Can I present at the end of this session, sir?
Yeah, sure. Okay.
Yes, sir. Thank you, sir. Thank you.
Okay, then we'll move on to next presentation by Dr. Abdul Naim.
Respected dignitaries, I'm here to present a case report of minimally invasive single flap approach in the management of intraosseous defect. Coming to introduction, single flap approach is a minimally invasive procedure for periodontal reconstructive and regenerative therapy, which is achieved by elevation of periodontal flap to access the defect only from one side. This was introduced by Tromboli et al. In 2009. When considering the technical aspects of periodontal reconstructive procedures for intraosseous defects, there are two major factors seems to be more important to rate the success of a successful outcome. One is to eliminate or reduce the post-surgical infection and contamination, and the second one is to minimize the post-operative soft tissue recession on the interproximal and buccal aspect of the treated tooth, with the result of compromising the pre-existing aesthetic appearance of the patient. In the present case report, a minimally invasive procedure, the single flap buccal approach in conjunction with autogenous bone graft with the bioabsorbable membrane was performed for the management of intraosseous defect. A autogenous bone graft was preferred because it is considered as a gold standard because of its high osteogenic potential and virtually no side effects. Moving on to the case report, a 32-year-old female patient was reported to the Department of Periodontology with a chief complaint of food lodgement in the upper right side back tooth since 4 months. The oral hygiene status of the patient was found to be fair. On a gingival examination, there was grade 2 bleeding on probing and gingival recession and loss of attachment in respect to 3.1, 3.2, 4.1, and 4.2. The probing pocket depth in relation to 1.5 was 5 mm, 1.6 was 7 mm, and 1.7 it was 6 mm, and in relation to 2.5, 2.6, and 2.7 it was 5 mm. The mobility and furcation involvement was absent. On radiographic assessment, it was appreciated that there was a vertical defect mesial to 1.6 and horizontal defect distal to 1.6. The patient was diagnosed with generalized periodontitis stage 2 grade B. The treatment plan was explained to the patient and informed consent was obtained. The phase 1 therapy included patient education and motivation along with scaling and root planing. And the patient was recalled after 4 weeks and the periodontal parameters were reevaluated. Since the average pocket depth was 5 to 7 mm after the phase 1 therapy, treatment consisted of periodontal flap surgery. On further examination, an intra-bony defect was observed in respect to 1.6 and presence of excessive bone growth in relation to 1.5, 1.6 and 1.7 was appreciated. After proper isolation of the surgical field, the operative site was anesthetized. Clavicular incision was made using Bart Parker number 15 blade on facial aspect of the teeth with segment or areas involvement. A full thickness mucoperiosteal flap was reflected using a periosteal elevator, taking care to preserve the maximum amount of gingival connective tissue in the flap. The defect was thoroughly debrided and root surface was planed. Removal of granulation tissue tags was done to minimize the bleeding and was followed by irrigation with betadine and saline solution. Resective surgery was carried out using bone ronger and rotary cutting instrument. As we can appreciate, that the dissected bony particle were mixed with saline and blood and utilized as autogenous bone graft for filling the intra-bony defect mesial 2.16. Followed by pre-suturing, a membrane was placed to ensure the total coverage of the defect on occlusal and lateral aspect as well. The flap was secured using 3-0 black braided suturing material, and periodontal dressing was placed. The patient was recalled after 1 week for suture removal and the healing was found to be satisfactory. A 3-month follow-up could appreciate a proper soft tissue contour and sufficient amount of bond fill achieved. Moving on to discussion, the ambitious goal of periodontal therapy is to restore the periodontal attachment apparatus to its pre-diseased state. The case report presented here describes the management of periodontal osseous defects which have been treated with a single flap approach from the buccal aspect along with autogenous bone graft and collagen membrane. The case was followed up to gather clinical and radiographic evidence of attachment gain. Single surgical re-entry and histological method were not feasible due to the requirement of unnecessary second procedure. Radiographs were used to assess the defect fill. A single flap approach represents a new surgical approach for the management of soft tissue in periodontal reconstructive surgery. It consists of a mucoperiosteal flap elevated only on one side, leaving the soft tissue on the opposite side intact. A single flap approach based on buccal flap provides better surgical access for soft tissue management, root debridement, grafting, membrane positioning, and suturing procedures compared to single flap approach with a palatal approach. It is indicated in intraosseous defects involving the interproximal aspect, where exhibiting limited to no extension on the lingual or palatal side. It is indicated when buccal access allows an appropriate root and defect debridement and application of proper reconstructive therapy. The proper placement of graft material for the infrabony defect are one mode of therapy that attempts to restore the lost periodontal attachment apparatus. The bone graft material provides regeneration through inductive or conductive processes. The conductive graft act as a scaffold to support the new tissue growth and replaced by host tissue. The inductive graft stimulates the host tissue to regenerate the lost structures. The minimally invasive approach adopted in this case have minimized the surgical trauma during the manipulation of soft tissues. Coming to conclusion, single flap approach along with placement of autogenous bone graft with collagen membrane was appropriate as the clinical and radiographic evaluation revealed the involvement of only the buccal aspect. This conservative procedure was able to achieve our primary goal of regaining the periodontal health with glimpses of periodontal regeneration confirmed through radiographic and clinical evaluation at 3 months. Thank you.
Good afternoon,
ma'am. Okay, there's one thing I'd like to say. Like you said, this is missed, right? Hello, am I audible?
Yes, you are.
Yes.
Yeah, ma'am.
So, is it exactly the missed technique that was proposed by Cortellini?
Ma'am, this was a technique introduced by Tromboli in 2009, ma'am.
So how is modified mist different from mist? Mist is minimally invasive surgical technique, and then there's a modified
minimally invasive surgery. But like here we have introduced like a single approach, ma'am, either buccal or palatal approach.
See, what I'd like to tell you is that it is not whether raising a single flap on one side that is classified or defined as mist. I would personally say that mist or minimally invasive technique refers to the raising of very small, palatal and buccal, whether palatal or buccal flaps, right? So this
causing less traumatic
this looked like a Kirkland flap to me.
Exactly,
More like a Kirkland flap with lot amount of bone removal. There was receptive osseous surgery as well.
Osseous surgery as well, and
he has done.
Yes, ma'am.
He has used the files and yes.
There was a bony growth, ma'am, in relation to 1.5, 1.6, and 1.7, ma'am. So
you
we had to remove that, and we had used it as an autogenous graft, ma'am.
Was it a buttressing? Was it a buttressing or what was that?
Exostosis, ma'am.
It was an exostosis. Okay. You removed that exostosis and you used it again to fill up the
graft. Used it as an autogenous graft in relation to 1.6, ma'am. Mesial to 1.6, there was a vertical defect. So we had harvested the bone graft and we have used it as an autogenous bone graft.
But this appears to be more of a conventional procedure rather than mist.
Correct. And if you are not raising the palatal flap, you are not going to remove the granulation tissue. If it is a vertical defect, okay, you are talking that it's a vertical defect and you are not raising the palatal flap. So how do you ensure that good amount of debridement has been done? Because you are just raising the buccal flap.
Palatally, the probing depth was 2 mm. like around 2 mm in relation to 15, 16, and 17. That's why we haven't done any surgical procedure towards the parietal surface, and we could approach the defect only by raising the buccal flap, ma'am.
Okay.
Thank you, Dr. Abdul Naeem. Our next presentation by Dr. Abdullah Khan.
My topic for paper presentation is comparative evaluation of root coverage using volumizing ossified collagen membrane versus human chorion membrane along with coronally advanced flap in the treatment of Cairo-RT1 gingival recession. Then a case report. Introduction. Gingival recession is characterized by the displacement of gingival margin apically from the cemento-enamel junction. Several modifications to the conventional technique have been developed in an attempt to obtain optimal root coverage and a better aesthetic integration. Coronally advanced flap is a mucogingival procedure which is based on the coronal shift of the soft tissue on the exposed root surface. Resorbable membrane like volumizing ossified collagen membrane and human corneal membrane are used along with coronally advanced flap for root coverage. Rationale. Favorable root coverage has been observed by using volumizing ossified collagen membrane after 1 month of post-surgery. Volumizing ossified collagen membrane is a biodegradable and novel sugar crossing technology has been shown to increase the barrier capacity of collagen membrane, making them impermeable to cellular infiltration. It is thick and expand when wet, safe and effective, and generate positive effect on the soft tissue quality. Case presentation. It is a case report design. Ethical approval and informed consent were obtained from the patient before commencing the surgical procedure. Method of measurement. Selected site diagnosed with Cairo-RT1 gingival recession would be included in this study. The selected bilateral site would be grouped as site A as volumizing ossified collagen membrane with coronally advanced flap and site B human chorion membrane with coronally advanced flap. Recall after 1 month post-operatively. Clinical case. 38-year-old male patient was referred to the Department of Periodontology for the treatment of gingival recession. Patient has blood pressure and under medication for the same. Patient underwent root canal treatment in 2018 for a single tooth in the lower right back region of the jaw. Treatment plan. After extensive clinical and radiographic examination, it was determined that a selected site diagnosed with Cairo-RT1 gingival recession would be included. The selected bilateral site are grouped as site A, which is volumizing ossified membrane with coronally advanced flap, and site B, human chorion membrane with coronally advanced flap. A trapezoidal flap was elevated by a sharp dissection to raise a combined full partial thickness flap beyond the mucogingival junction. Respective membrane were placed at the site and the flap was sutured. The patient was prescribed oral antibiotic therapy and amoxicillin plus clavinate potassium 1 gram every 12 hours for 6 days, that is augmentin, and non-steroidal analgesic ibuprofen 600 mg. Suture were removed after 7 days. This is surgical procedure. Inside a volumizing ossified collagen membrane with coronally advanced flap. Pre-operative view in pre-surgical measurement with a periodontal probe and custom athletic strain. Horizontal and vertical incision were made. Elevation of the flap in a full split approach, de-epithelialization of papilla, and adaptation of volumizing ossified membrane. This is volumizing ossified collagen membrane, and then membrane were placed on and sutured. The flap was coronally advanced and sutured. After that, periodontal pack was given. Inside B, human chorion membrane with coronally advanced flap. This is pre-operative view, pre-surgical measurement with a periodontal probe and custom acrylic strain. Horizontal and vertical incision were made, and then elevation of the flap in a full split approach, the epithelialization of the papilla, and then adaptation of the chorion membrane. This is human chorion membrane, which is secured from the Tata Memorial Hospital tissue bank. After that, adaptation of human chorion membrane, and then the flap was coronally advanced and suture. After that, adaptation of periodontal pack was given. Follow up at 1 month in site volumizing ossified collagen membrane with coronally advanced flap at baseline and after 1 month. Follow up at 1 month in site B human chorion membrane with coronally advanced flap at baseline and after 1 month. Result. In site volumizing ossified collagen membrane coronally advanced flap. The gingival recession depth at baseline is 2.7 mm and after 1 month is 1.6 mm. Therefore, the mean root coverage percentage is 40%. In side view with human chorion membrane and coronary advanced flap, gingival recession depth at baseline 2.1 mm and at 1 month 1.5 mm. Therefore, the mean root coverage is 28%. Discussion. Volumizing ossifying collagen membrane could be a successful material in the treatment of multiple recession compared to human chorion membrane. The use of resorbable membrane has proven to be a better option in terms of reducing morbidity because it eliminates the need for another surgical field, which allows the application of this material in everyday clinical practice. As statistical result, volumizing ossifying collagen membrane proved to be a superior, but not significantly. Human chorion membrane achieved slightly weaker result. Limitations. No data related to soft tissue biotype was acquired, so it was not possible to assume that different biotype may result in different dimension changes. Conclusion. Volumizing ossifying membrane show better root coverage than human chorion membrane along with coronally advanced lab at 1 month follow-up. This is my references. Thank you.
Okay, so what was the difference between the commercial values of the two membranes? Which one was more economically reasonable? Of the two membranes two different membranes that you used, which one was more reasonably priced?
Ma'am, it was human chorion membrane. It costs less. The Volumax is quite expensive. It comes in 4 different sizes.
Not able to hear. Could you please repeat it once? Could you please repeat it?
Ma'am, human chorion membrane it has less price as compared to Volumax collagen membrane, and Volumax collagen membrane comes in 4 different sizes.
4 different sizes. Okay, different sizes are available. Okay. So, is there any data, any other study supporting your results? Has there been any other comparative? Has there any other comparative study been made?
No, ma'am. This is, ma'am. I have there was an article with comparative study was with comparing volume Ossif Volumax with CTG connected tissue graft.
With connected, not with chorionic membrane.
Yes, ma'am.
Over to you, ma'am.
It was a good study. So was it a split mouth technique or did you choose different patients?
Ma'am, it's a split mouth technique.
Okay. So what was the time period like between 2 techniques? What was the time period? Did you leave?
Ma'am, actually, the time period, the root coverage is it's from at baseline at one month, 3 months, and then 6 months. So I have recorded the patient at till 1 month. The patient is not yet come.
So you have recorded both the data at 1 month?
I have recorded both the data at 1 month, but for 3 months, the patient is not yet shown because of the pandemic.
Okay, because of the pandemic. So why did you choose the multiple recessions? You didn't have any data, so you could have gone for single tooth recessions. Was there any? And one more thing, you have used Cairo et al. Classification. So what was the idea behind using Cairo et al. Classification? Because very less people use that.
Ma'am, actually, the patient was come and in the OPD, and I wanted to perform the surgery with the human chorion membrane, Volumax membrane. So I just did it, ma'am. The patient was agreeing.
What ma'am is asking is, why did you use the Cairo's classification system? Now, why not the Miller's one?
Ma'am, the Cairo classification is the advanced 2007 according to 2017 classification. So I was going according to the 2017 classification, ma'am.
So why is it so considered to be so good? What are the better aspects of the Cairo classification system?
Ma'am, the Cairo classification are given the 3 aspects RT1 and RT2 and RT3. The RT1 in which where there is no interproximal attachment loss, and in RT2 where there is a interproximal attachment loss, and the amount of interproximal loss is less as compared to the buccal attachment loss, whereas in RT3 the attachment loss is more as compared to buccal attachment loss.
Fine.
Thank you, Dr. Abdullah Khan. Next, we'll move to Dr. Asna Beni's presentation.
Thank you, ma'am.
Asna Beni, are you ready now?
Yes, ma'am. I'll share the screen.
It's not audible, Ashna. Ma'am, it's not audible. Your presentation is not audible. I can't hear it. If you can see the presentation, can you read your presentation?
Yeah, sure, ma'am.
Okay.
A very good afternoon to the panel of judges. Today I'm going to present a case report on plasma cell gingivitis. Coming to introduction, plasma cell gingivitis is a rare benign condition of the gingiva characterized by sharply demarcated erythematous and edematous gingivitis, often extending to the mucogingival junction. The most common clinical presentation of plasma cell gingivitis is an inflammatory, either generalized or localized edematous macular lesions with cobblestone or nodular or velvety appearance with a sharp demarcation at the mucogingival junction. So areas of whitening, epithelial sloughing, and erosions have also been observed. This epithelial sloughing can be due to acanthosis. Yeah, it can be due to acanthosis and increase in cellular spaces between keratinocytes with an alternate area of atrophy. So the most consistent symptoms include oral pain, pruritus, burning sensation, and bleeding. So the laboratory investigations are usually within normal limits, and sometimes an elevated erythrocyte sedimentation rate can be seen. So the prognosis of this benign condition is considered to be good because of no malignant transformation potential. So the other names of this condition are idiopathic gingivostomatitis, plasma cell gingivostomatitis, atypical gingivostomatitis, allergic gingivostomatitis, and plasmacytosis. So coming to the prevalence, it was first described by Zoon in 1952 as a plasma cell infiltrate, and he found this lesion on the glans penis. And in the oral cavity, it was first reported in 1970 as plasmacytosis of the gingiva, and no sex or age predilection was seen. So these are the predisposing factors, that is toothpaste, food, mint, candies, chewing of cart leaves, colocasia leaves, and it can also be of an unknown origin. So the usual investigations are a routine blood examination, radiographic and a histopathological examination. And the treatment options are mostly symptomatic to eliminate the allergen, and it can also be topical steroids, gingivectomy, cryosurgery, or laser. So this case report is about a 30-year-old female patient who visited the department with a complaint of swollen gums for 1 week, and she revealed a history of bleeding on slight provocation and burning sensation on consumption of spicy food. The swelling was first noticed after the patient changed her toothpaste 1 week back. And history of presenting illness was that the swelling was sudden in onset, and it appeared small and grew to a considerable size within a duration of 1 week, and pain and bleeding on provocation were present. And there was no relevant medical history, and there was a dental history of crown placement in the upper front tooth region for exactly 1 year back. And the personal history is that the patient is allergic to metals. That is, it was noticed by an allergic reaction to watches. If she wore a metal watch, she got erythematous blisters. And next, the extraoral examination and her general examination did not show any abnormalities. So on intraoral examination, the swelling was approximately 5 into 8 mm in dimension in relation to the 2-1 and 2-2 region on the labial aspect. And on the palatal aspect, it was 3 into 3 mm in size in relation to 1-2. And the labial and palatal lingual marginal gingiva and interdental papilla were edematous and erythematous, and there was loss of stiffling. So on palpation, the gingiva was friable along with bleeding on minor provocation, and the swelling was soft in consistency. So these are the pre-operative photographs. There was a very less bacterial plaque deposits, and pseudo pockets of about 6 mm were seen in relation to 2-1, 2-2, and 2-3 regions. And this swelling covered the cervical part of the crown on the labial aspect of 2-1 and 2-2. So the radiographs just showed only a horizontal bone loss, and they were not consistent with the swelling. And the OPG also showed a generalized horizontal bone loss. So the investigative hematological examination did not reveal any significant findings, and a negative Nikolsky sign was there, which ruled out pemphigus, and a provisional diagnosis of plasma cell gingivitis was made, and excisional biopsy was done to confirm the diagnosis. So the differential diagnosis can be desquamative gingivitis, lichen planus, atypical gingivitis, leukemia-associated gingivitis, and pregnancy or puberty-associated gingivitis. So the treatment for this patient was oral hygiene instructions and patient counseling was given, and the patient was instructed to change her toothpaste, and scaling and root planing was done, and excision of the lesion was done, and followed by prescription of antibiotics and analgesics. So on intraoperative photographs, an external bevel gingivectomy was done, and then after the external bevel incision, a clavicular incision was given, and after the swelling was removed, suturing was done, and Copac was placed, and the excised tissue was sent for histopathological examination. So the histopathological report revealed an ulcerated squamous epithelium, inflamed fibrovascular connective tissue, and the connective tissue showed inflammatory cell infiltrate, predominantly consisting of plasma cells, macrophages, and budding capillaries. So the post-operative, there is a 1 week post-operative photograph, and there's a 2 week post-operative, and up to 1 year post-operatively we followed with the patient, and there was no recurrence of the swelling after change of toothpaste. So coming to discussion, plasma cell gingivitis is considered to be a rare condition of the gingiva and represents a hypersensitive reaction with predominant plasma cell infiltration of the connective tissue. It has been hypothesized that the immunological reaction to some allergic antigen might be the possible causative agent. So the common predisposing factors are the toothpaste, chewing gum, cinnamonaldehyde, strong spices, chilies, and chewing of cart leaves. And based on the etiology, plasma cell gingivitis can be categorized as lesions of an unknown cause owing to some allergen, or it can be of neoplastic origin. So this entity is thought to be a B cell mediated disorder with T cells augmenting the response. So as in this case, the change in toothpaste has thought to be the most likely etiology. So cinnamonaldehyde that is added to dentifrices to reduce the unpleasant taste of pyrophosphate has been closely related with the advent of plasma cell gingivitis. Cinnamon, when used as a flavoring agent in toothpaste, was also determined to be an etiological factor in cheilitis. So in our case, the patient also had a metal allergy, and a metal crown was a metal ceramic crown was placed in 2122 region, and this can also pose as a possible etiology agent. But the fact that the swelling appeared 1 week after the change in toothpaste highlights that some component of the toothpaste must have triggered the allergic response. Also, there was no recurrence of the swelling, though the patient did not change the metal ceramic crown after the treatment. So it can be considered that the toothpaste was the etiological agent, or it might have exaggerated an already present immune response. So in this case, there were no radiographic findings, and the histopathology showed an excessive infiltration of plasma cells, which concluded that it was plasma cell gingivitis. So on conclusion, plasma cell gingivitis mimics other serious conditions such as leukemia and myeloma, and an early diagnosis would direct the clinician towards an appropriate treatment plan, especially for unusual conditions which are masquerading and which are continuing after refractory conventional therapy. So this case emphasizes the negative effects of components of both toothpaste and metal processes, thus emphasizing the need for a comprehensive history taking, investigation, and exact diagnostic step to arrive at a correct treatment plan. So these are my references. Thank you.
In the present case, after how many days was surgery carried out? How many days after scaling and root planing was the surgery carried out?
Ma'am, after 2 weeks, ma'am.
Exactly 2 weeks. So don't you think you should have waited a bit longer? Once the possible allergen had been removed, was it not a possibility that the swelling might have subsided on its own?
Ma'am, initially we told the patient that it might have been due to her metal crown, because when she reported to the department, she had blisters on her hands where she placed a wristwatch. So we actually advised her initially so that we will remove the swelling and immediately removal of the crown. But the patient was not willing to remove the crown due to financial reasons, so she wanted to continue with it, and she also changed her toothpaste. So after that, there was no recurrence.
So after how long?
Because we wanted to change the crown,
So you went ahead with the surgical procedure. And one more thing, early on, when you're talking about the possible treatment modality, you talked about laser. That laser is also used as a treatment modality for the management of plasma cell gingivitis. How? Which laser and how?
Soft tissue lasers, diode laser can be used.
For excision of the enlarged part.
That's for excision. Excision, yes, ma'am.
Ma'am, on to you.
So are there any cases reported on this, like use of cinnamon component in a toothpaste?
Yes, ma'am. Cinnamon components have been reported, and one more is acacia.
Is it reported on plasma cell gingivitis? But that was reported on stomatitis, right? I have seen your references. But has any case been reported on plasma cell gingivitis? And here we
cinnamon
could
note
see
from
that
early
the
acacia
patient
in
had
the
crowding.
taste.
Did you see that? The patient had crowding.
Yes, ma'am.
So why don't you think crowding could be one of the possible reasons for such inflammation? We see these kind of inflammation in crowding patients as well. Of course, you got the histopathological
she had,
reports of plasma cell gingivitis, but still, as ma'am said, that we should have waited for some more time.
Crowding has been there for a long time, but since there was a sudden swelling, so there must have been some etiological factor that triggered it suddenly.
Thank you, Dr. Thank you, Dr. Asna Beni. Ma'am, with this, we end our session. Thank you, Dr. Elura Madan ma'am and Dr. Gatha Mohanty ma'am for taking out your valuable time and being a part of this first virtual PG convention. Ma'am, thank you very much. Ma'am, a sincere reminder to send evaluation sheet on the superstars number. Ma'am, thank you, ma'am.
Sure. It was a very interactive session. Thank you, Dr. Elora. A nice meeting.
Thank you so much.
And I
Same here.
thank you, the organizers of the virtual conference. Thank you so much.
Thank you so much.
Then moving on to next session, I would like to invite our next chairperson, Dr. Sivasankar Pradhan, Reader, SCV Government Dental College and Hospital, Cuttack, and Dr. Swati Agrawal, ma'am, Reader, Department of Periodontology, Puthiwala Dental College and Research Center. Ma'am and sir, please do chair this session. I would like to request Dr. Gitu An Varghese to present her presentation.
Good afternoon, respected jury members. Title of my paper presentation is Multidisciplinary Approach to Aesthetics and Functional Restoration, a case report. Periodontal tissue form the foundation for proper aesthetics, function, and comfort of the dentition. Biological bricks act as a barrier to prevent the penetration of the microorganism into the periodontia. Restoration of a tooth without the regard of the biological width results in poor periodontal response. Surgical crown lengthening provides enough sound tooth structure by re-establishing a healthy periodontia, particularly the biological width at a more apical level. The objective of treatment in the present case was to establish access to restorative management by performing surgical crown lengthening while preserving the biological width. Moving on to the case report, a 32-year-old male patient was referred to the Department of Periodontology from the Department of Conservative Dentistry and Endodontics with a complaint of fractured maxillary anterior tooth 2 months back. Patient gives a history of trauma of tooth due to road traffic accident. There was pain during the initial 15 days, which then subsided later. There was no pain at the time of examination. Patient was systemically fit. Intraoral examination revealed good oral hygiene with minimal plaque and calculus deposits. In relation to one tooth, generalized probing pocket of 2 mm and on the palatal region of 3 mm was noted. The tooth was firm and stable. On clinical examination, fracture, that is involvement of enamel, dentine, and compromising the pulp of the maxillary right lateral incisor was observed. IUP revealed coronal fracture with no root fracture or any other periapical changes. So it was diagnosed as Ellis class 3 fracture of the crown. Treatment plan. In phase 1 therapy, scaling and polishing was done, followed by oral hygiene instruction, and patient was prescribed with chlorhexidine mouthprints for 2 weeks. In phase 2, root canal treatment was done in relation to 1-2, followed by periodontal surgery. In phase 3, post-implant placement was done and prosthetic rehabilitation was provided. After each phase, the maintenance phase of phase 4 was followed. After scaling and polishing, single-sitting root canal therapy was done. 2 weeks after root canal therapy, crown lengthening was done. Internal bevel incision was placed to reduce the thickness as well as to re-establish the physical contour of the tooth. It is followed by clavicular incision to reflect the full thickness flap in radial and palatal aspect, and the flap was reflected using the periosteal elevator. The number 15 blade was used to give incision. After flap reflection, osseous reduction of 4 mm was carried out using rotary cutting burr with continuous saline irrigation, and care was taken not to damage the root structure. The flap was repositioned and sutured using 3-0 silk suture and interrupted suture technique. Patient was recalled after 10 days for suture removal. Antibiotics, that is amoxicillin 500 milligrams, and analgesics, that is paracetamol 650 milligrams, were prescribed for 5 days. Healing was found to be satisfactory 10 days post crown lengthening, and suture was removed. Following this, post-space preparation was done, and fiber reinforced composite resin post was placed, and composite resin buildup was done to support the fixed ceramic crown processes. 1 month after crown buildup, crown preparation was done, and temporary crown was given. Patient was recalled after 3 months, that is, 4 months post-crown lengthening procedure for restoration of the tooth by the ceramic crown processes. Moving on to discussion, functional, aesthetics, and biological restoration of the fractured incisor often presents a daunting clinical challenge. Various treatment approaches have been indicated for fractured teeth, including gingivectomy and osteotomy, that is crown lengthening, orthodontic extrusion with or without gingivoplasty, forced surgical extrusion, extraction followed by surgical implants, or fixed partial denture. The treatment performed and presented in this clinical case report is one of the many possible options that could have been used to restore the condition of this patient. Selection of the treatment plan should be made based on the advantage, disadvantage, and considering various periodontal factors. Generally, dental trauma can involve pulp both directly and indirectly, so endodontics is considered to play an important role to evaluate and treat the dental injuries. Fractures that involve the edge of the gingival area need an endodontic treatment, followed with crown restoration using post and comb. Fiber reinforced posts were used in this case as they have shown superior performance as compared to metal posts due to its dentine-like elastic modulus and exceptional aesthetic properties. The restoration of endodontically treated tooth might be complicated in cases with an inadequate height of the remaining coronal wall. Therefore, a crown lengthening with osseous reduction may be indicated before restoration of the endodontically treated tooth. Crown lengthening with osseous reduction procedure aims to expose the surface of root by placing the gingival tissue and the alveolar crest apically. The clinical significance to re-establish the proper intra-tooth gingival zenith position of the maxillary anterior teeth during periodontal crown lengthening plays a very important role in aesthetics. Ceramic crown was used in this case to restore endodontically treated tooth. We offered more favorable aesthetics by mimicking the optical properties of the teeth. It can be concluded that the success of restoration is determined by retention, stability, aesthetics, especially in the anterior region, as well as biological aspects. This case showed that traumatic injury on maxillary incisor can be treated by interdisciplinary approach to restore the tooth function and aesthetics optimally. Thank you. Good afternoon, ma'am. Good afternoon, sir.
Yes.
Dr. Sivasankar, sir, you're. Okay, ma'am. You carry on, ma'am.
So, Gitu, can you tell any other modality? It was indeed a nice presentation. But can you think of any other probable modality you could have opted for instead of going directly for crown lengthening?
Ma'am, orthodontic extrusion was one of the option, but we didn't opt because it was a compromised crown root ratio, as well as root length was short, ma'am. So that's the reason we opted for.
Actually, it would have been the same. You have gone for crown lengthening, so crown root ratio is the same in either of the cases, but it would have give you a better smile line, as I feel.
Yes.
If at all owing to the gingival line and the gingival margin is considered, it would have given you better results. Indeed, it was a nice presentation. Sir, you can ask, sir.
Dr. Sivasankar Pradhan, please kindly unmute yourself first.
Dr. Gitu,
Yes, sir.
nice presentation. One
Thanks, sir.
thing I want to ask, what other investigations you have done in this case? Means except probing depth.
Bone sounding was done. Radiographs were examined.
So what is the ferrule in palatal aspect?
Palatal.
Where is the ferrule? Where is the ferrule in palatal aspect? In palatal aspect, where is the ferrule? What is ferrule?
Ferrule, it is the margin of the crown that will provide
The
attachment
healthy
to
margin
the
of the crown.
crown, sir.
Okay. So where it is in palatal aspect?
So
Because it looks like it's a bit deeper in means you have to remove a lot of bone on palatal aspect to get
in
ferrule.
the subgingival.
Yeah, subgingival is there, but the for healthy crown margin you have to remove most probably a lot of bone in palatal aspect.
Yes, sir.
So the crown root ratio is adequate in this case. To go with a crown or immediate implant will be better in this case.
So we didn't go for the implant as the patient wanted to save the tooth. So that's the reason we opted for this treatment plan.
Okay.
And there was
Okay.
sufficient crown root ratio, sir.
So what is the other term for biologic width according to 2017 classification?
Supracrystal epithelial attachment, sir.
Supracrystal attachment. Okay. Okay, done. Next presentation.
Supracrystal tissue attachment, sir.
Yeah. Swamprava, next presentation.
Thank you, Dr. Gitu. Our next presenter is Dr. Shreya Sethi.
Good afternoon, respected jury members. The title for my paper is Alluring Smile with Recontouring of Bone, a case report. Tori, exostosis, and osteomas are nodular protuberances of mature bone, the precise designation of which depends on anatomic location. Torus palatinus and torus mandibuloris are the two most common typical intraoral osseous outgrowths. Buccal and palatal exostosis are multiple bony nodules that occur less frequently than tori. Exostosis are bony hematomas which are asymptomatic, benign, exophytic nodular outgrowths of dense cortical bone that are relatively avascular. They are mainly of two types, buccal and palatal exostosis. Maxilla is shown to exhibit the highest prevalence rate of 5.1:1 in comparison to mandible, with male population affected more than females, 1.66:1 in all intraoral locations. The etiology of tori has been investigated by several authors. However, no consensus has been reached. Some of the postulated causes include genetic factors, environmental factors, masticatory hyperfunction, and continued growth. Buccal exostosis occur as bony growth along the facial aspect of the maxillary and or mandibular alveolus, commonly found to appear in the premolar molar region. On palpation, the exostosis are hard bony mass. The overlying mucosa appears to be stretched but intact and normal in color. The histological features of tori and exostosis are identical. A very small exostosis and tori consist entirely of compact bone, but when large and nodular, it consists of cancellous bone surrounded by cortical bone. With a growing emphasis on cosmetic dentistry and aesthetics, especially among youngsters, surgical removal is routinely warranted for such lesions. Coming to the case report, 55-year-old female patient reported to the Department of Periodontology, Yenapoya Dental College, Mangalore, complaining of swelling in the lower anterior region of the jaw, interfering with her smile and aesthetics. History reveals slow but steady enlargement of the mass. Over the past 2 years, no associated symptoms with this region. The patient had no history of trauma to the involved area. No contributory medical history was reported. On gingival examination, it revealed that the gingiva was pink in color, consistency was firm and resilient. Overgrowth was located on the buccal aspect of the mandible in the incisor and canine area. Generalized moderate gingivitis was seen. The lesion was bony hard on palpation, overlying mucosa was thin and blanched, non-ulcerated. Periodontal examination revealed presence of false pockets in relation to 4.1 and 4.2. The bony mass was oblong in shape, extending from mesial of 3-3 to mesial of 4-3 and found to be diffused. It did not interfere with speech, chewing, or other oral functions. Occlusal evaluation showed Angle's class 1 malocclusion with overjet and overbite of 2 mm. Radiographic examination did not reveal any abnormalities. The bony protuberance caused by the thickening or enlargement of the cortical plate of the facial surface of the mandible without any systemic abnormality helped us to draw the diagnosis as buccal exostosis. Routine blood investigation was carried out and was found to be within normal limits. Treatment plan included etotrophic phase, which includes patient education and motivation, oral hygiene instructions, and scaling and polishing, followed by maintenance phase. Next was the surgical phase that included resective osseous surgery, followed by maintenance phase. This is the preoperative picture, which shows bony mass extending from mesial of 3-3 to mesial of 4-3. Local anesthesia was injected, and pocket depth was then marked using Crane Kaplan's pocket mark. As the contour of the gingiva was uneven and there were false pockets, gingivectomy was carried out in relation to 4-1 and 4-2. This was followed by vertical and sulcular incision. Full thickness mucoperiosteal flap is elevated to gain complete accessibility and visibility of the bony mass. The bony outgrowth was removed using bone rongeur, and osseous recontouring was done with bone cutting carbide burr number 702 SS white under copious saline irrigation. Care was taken that the crest of the marginal bone was left undisturbed. After removal of the osseous growth, the flaps were positioned on a trial basis and surgical site was palpated to determine the need for further recontouring. On obtaining the desired result, the flap was secured with 30 Mercier simple interrupted sutures. The resected bony spicules were collected in a bottle containing formalin and were sent for histopathological examination and found that the material was indeed its native bone, that is exostosis. Routine postoperative instructions were given. The medications prescribed were 500 mg amoxicillin 8 hours for 5 days and 400 mg ibuprofen every 8 hours for 3 days. Patient was recalled after 1 week for suture removal. Patient did not have any postoperative discomfort. Subsequently, the patient was viewed after 1 month, 3 months, and 6 months for further postoperative follow-up. Discussion. Buccal exostosis are non-malignant lesions of little clinical significance. The multiple masses in the maxilla are consistent with multiple buccal exostosis, which are bony protuberances that arise from the cortical plates in the maxilla and mandible. It enlarges slowly over time. Etiology remains unknown, although it has been suggested to be the outcome of a mild chronic periodontal inflammation. The diagnosis is based on clinical and radiographic findings. It does not require treatment unless it becomes large enough to interfere with function and denture placement, cause recurring traumatic surface ulceration, or if it is used to get autograft as it is a potent donor site. As the prime concern of the patient was aesthetics, case was subjected for surgical intervention. In the mandible, they simulate lesions such as bone deformities, osteomyelitis, and the Gardner's syndrome, but anamnesis and appropriate laboratory tests can easily provide the definite diagnosis. The mucosa is normally superficial and it has a normal appearance, but if it is exposed to trauma, it may become whitish and ulcerated. Buccal exostosis occur along the buccal aspect of the maxilla or mandible, usually in the premolar and molar areas. Its occurrence on the canine region is an extremely rare occurrence. It has been suggested that the bony outgrowth may be due to increased occlusal forces due to malalignment of the teeth or occlusal interferences. Osteoplasty and osteectomy techniques were carried out using a combination of rotary and hand-cutting instruments. Conclusion. An exostosis is described as a localized peripheral overgrowth of bone, the base of which is continuous with the original bone. The etiology is still not clear. Exostosis should be differentiated from an osteoma, an uncommon finding which produces a similar clinical, radiographic, and histologic picture. Proper diagnosis and treatment plan is key in the management of bony exostosis and tori, as it can pose aesthetic as well as functional problems. Clinician has to be careful in the osseous recontouring, which is critical in the management of bony growth. Thank you.
Ma'am.
Good evening, sir. Good evening, ma'am.
Good evening.
Sir, आप पूछ लीजिए sir. Please ask questions.
Okay. Dr. Shreya,
Yes,
what
sir.
are the anatomical landmarks you have to taken care of during doing this surgery in this region, mandibular anterior region, what are the landmarks we have to take into account?
So the marginal bone, we need to take care that while doing the surgery, the marginal bone is kept intact. And
No, anatomical landmarks. Where you have given your vertical incision?
So the vertical incisions is given, followed by the sulcular incision.
Where the vertical incisions are given?
Sir, it should not be given along the line angle of the tooth. It should be not over the root surface, and it should be not at the interproximal papilla. It should not be given along the interproximal papilla.
No, in your case, where you have given your vertical incision?
So from mesial of 3.3 to mesial of 4.3.
What is the major anatomical landmark present in that region?
So the canine.
No, anatomical, any nerve, anything else like that? Any opening, foramen?
So
yeah, mental foramen. Where it is present?
Mental foramen.
Which region?
So premolar region, sir.
Okay. So you have taken care of that?
Yes, sir. The care was taken that the mental foramen was not disturbed.
Okay. And what are the radiological investigation you have done for this case?
So OPG was taken, and according to the findings, no pathology was detected.
Is there any lingual involvement?
Sorry, sir?
Is there any lingual exostosis?
No, sir. No lingual exostosis. Only buccal exostosis was present.
Okay. What is the histological difference between exostosis and normal bone?
Sir, there is histologically exostosis contains cortical bone, sir, mature dense cortical bone, and it is small exostosis will contain cortical bone, whereas if it's a large exostosis, then it contains cancellous bone, which is surrounded by cortical bone.
It's there is more marrow space in exostosis. Okay, large exostosis. The marrow spaces are large in case of exostosis. Okay. Histologically. Is it audible?
Yes, sir.
Okay. Okay, ma'am, you can ask me.
So Shreya, it was a well done case. I wanted to ask you one thing, that tell me what are the morphologically deciding factors for the underlying bone? What would be the morphology of underlying bone? What are the factors that decide?
Ma'am, morphologically, the bone, there was a bony growth of the mass that was present.
You understand you understood my question? I'm asking, can you tell me the factors that decide the morphology of underlying bone? Clinically, what are the factors that you can think of that are deciding the morphology of bone? Amongst which one factor was present in your clinical case? There was enough crowding in your case, so that's why also the bony contour would have followed the overlying gingiva would have followed the underlying bone. So if that would have been corrected, I think much of your surgical part would have been skipped out. And one more thing, have you looked for trauma from occlusion, whether any kind of traumatic occlusion was present or not?
No, ma'am, trauma from occlusion was absent.
Like deep bite, as far as I can evaluate, might be deep bite would have been present in this case.
Yeah. So, but ma'am, but trauma from occlusion was excluded from the etiology of this case, ma'am.
Do you excluded trauma from occlusion in this case?
Sorry, sir?
How you excluded trauma from occlusion in this case?
Sir, there was just less amount of adhesion that was present. There was not much adhesion.
Do you taken any IOP radiographs other than OPG?
The OPG was taken, sir.
So trauma from occlusion, we can identify with OPG.
No, sir.
Okay.
It
You
has
have
to be
taken
seen
occlusion.
clinically.
Yes.
Okay, so but anyways, it was a nice presentation. Thank you.
Thank you.
Thank you, Dr. Shreyas Chetty. Our next presentation by Dr. David Manjali.
Hello everyone, Dr. David Manjali. I'm a first year postgraduate student from the Department of Orthodontics and Implantology, Manubai Patel Dental College and Hospital, Baroda. Today in paper presentation, I'll be presenting a case report on gingival depigmentation through two distinct approaches. A smile has the ability to enhance a person's personality. A beautiful smile is characterized by a harmonious relationship between the teeth and the gingiva. Gingival hyperpigmentation occurs due to excessive deposition of melanin pigment. Melanin is produced from the melanin granules, which are produced by melanoblasts located in the basal cell layer of the epithelium. Black gums are a common complaint these days amidst youngsters, especially the ones who have a high smile line. Gingival pigmentation shows racial predilection. It is seen more in dark-skinned individuals. Several methods have been suggested for gingival depigmentation, which are as follows: scalpel method, gingivectomy, gingivectomy with pre-gingival autografting, acellular dermal matrix allografts, electrosurgery, cryosurgery, abrasion with diamond bore, and various types of lasers. In this case report, two different cases treated with scalpel method and electrocold respectively have been presented. Moving on to the first case, a 29-year-old female patient reported to the Department of Periodontics and Implantology with a chief complaint of black-colored gums. She was an unmarried woman with good socioeconomic status. She had no relevant medical history and no history of smoking. It was revealed by the patient during history taking that the pigmentation was present since childhood, indicating that it was physiological pigmentation. Intraoral examination revealed gingival pigmentation extending from the central incisors to the second premolars in all four quadrants in both maxilla and mandible. Methodology. After initial phase 1 therapy consisting of scaling and root planing, patient was explained about the procedure and a written consent was obtained. Scalpel method was used for depigmentation in this patient. After administering the local anesthetic solution, a Bart Parker handle with a 50-number blade was used to scrape off the pigmented epithelium along with a thin layer of connective tissue. Pressure was applied with a sterile piece of gauze to control the bleeding in the operative site. After the procedure, a periodontal dressing was placed after irrigating with normal saline solution. After 1 week, the patient was recalled. There were some areas at the tip of the interdental papilla where the pigmented epithelium was still present. So the patient was advised to undergo the treatment once again. After 1 month, the patient was recalled for follow-up. It was observed that the healing was uneventful and satisfactory. There was no complaint of postoperative pain or sensitivity. Moving on to the second case, a 32-year-old male patient reported to the Department of Periodontics and Implantology with chief complaint of dark-colored gums. He was unmarried with a good socioeconomic status. He had no relevant medical history and no history of smoking. The pigmentation was present since childhood, indicating that it was physiological pigmentation. Intraoral examination revealed gingival pigmentation extending from the central incisors to the first premolars in all four quadrants in both maxilla and mandible. After initial phase 1 therapy, patient was explained about the procedure and a written consent was obtained. Electrocautery method was used for depigmentation in this patient. After administering the local anesthetic solution, a diamond electrode was used to remove the pigmented epithelium. Extra care was taken not to keep the tip at one place for a prolonged time because it would cause excessive heat buildup and ultimately damage the epithelium. After the procedure, the operative area was irrigated with normal saline solution and a periodontal dressing was applied. After 1 week, the patient was recalled. It was observed that the healing was not satisfactory. There was erythematous area near the central incisors So it can be considered as one of the disadvantages of the electrocautery method. The patient was recalled after 1 month for follow-up. So it was observed that although the healing was satisfactory, there was mild amount of gingival recession near the central incisors. This can be the second disadvantage of electrocautery method. The factors responsible for giving color to the gingiva are vascular supply, thickening of the epithelium, degree of keratinization of epithelium, and presence of pigment-containing cells. Gingival depigmentation is not a clinical indication, but is done only for aesthetic concerns. Out of the various techniques employed for gingival depigmentation, most commonly used technique is scalpel method. Adhikari B. et al. In the case report observed the scalpel technique was found to be more economical, clinically effective treatment modality for the management of gingival depigmentation, leading to an aesthetically pleasing outcome. Survey P. et al. In the study on gingival depigmentation using scalpel technique and sieve method of diode laser techniques concluded that sieve method of diode laser therapy showed a significant improvement in gingival pigmentation as well as reduction in pain intensity as compared to surgical scalpel technique. Boyapati R. et al. The study observed that with scalpel method, the healing process was normal. The patient did not notice any discomfort except pain experience for 3 days postoperatively. At the end of 1 month, reepithelialization was completed and healing was found to be satisfactory. Concluding this case report, gingival pigmentation has become an aesthetic concern among the young population. Technique to be employed for gingival depigmentation depends upon the ease of availability of instruments, preference of the patient, recurrence rate, and the clinical expertise. This case report proved that although both techniques contributed in improving the gingival aesthetics, scalpel technique performed better in terms of wound healing, comfort, and was economical. These are my references. Thank you.
Ma'am, please start. Swati ma'am.
Good evening, sir.
Good evening.
David, I want to ask you one thing.
Yes, ma'am.
Can you tell me that what should be the minimum healing post-operative you have to see in depigmentation cases?
Ma'am, 1 month.
Decide like how that will decide that which technique is better. So what is the minimum recall time at least you should have?
Minimum it should be 1 month. We can follow it to 1 year or 6 months and then 1 year.
1 month is like very, very short time in which you cannot decide whether repigmentation will occur or not.
Yes.
Especially in that with the scalpel.
Yes.
And can you tell me what is the repigmentation time for different techniques? Like all the cases have some amount of repigmentation reoccurring post-operatively.
Yes.
But what is the time? Like pottery has, there are various articles and various supporting articles which claim that lasers are better, burrs are better, cryosurgery is the best. So can you tell me what is the repigmentation rate of different techniques?
Ma'am, in scalpel technique, it was observed by Dummett that repigmentation had occurred after 7 years.
No. 7 years is a very long time. That too with the scalpel. Repigmentation is occurring for after 7 years in scalpel. No. Indeed, scalpel is considered the most the technique which has the highest recurrence rate.
Yes.
Yeah. So, Dr. David,
yes,
what do you think? Is it electrocautery is better or laser, according to you?
Sir, both methods are technique sensitive. But laser is comparatively better than the electrocautery because it has less chances of scarring if the technique is appropriate. In electrocautery, if the tip is not used in the light brushing strokes, then it can cause heat buildup and cause damage to the tissue. And the scar formation is more in case of electrocautery method.
Any other drawback of electrocautery? Major drawback, underlying bone.
Sir, if the proper technique is not used, it can also damage the underlying bone, as well as care should be taken to avoid avoid the vital teeth.
Yeah. So you told that there is chance of recurrence with scalpel. Why there is recurrence in case of scalpel depigmentation?
Sir, currently it is, according to a theory, it is because of the migration of the melanocytes from the adjacent epithelium, which can cause the depigmentation.
Yeah. So melanin pigments are found in which layer?
In stratum basal and stratum spinal.
In one disease, you can find melanin pigment in connective tissue. Which disease? Can you tell?
Sir, in Peutz-Jeghers syndrome, you can see that in Addison's disease, and in Kaposi's sarcoma.
Do you know about lichen planus?
Yes, sir.
Yes, post lichen planus melanin pigmentation is there after healing. In that case, you can find melanin pigment in common. Okay, thank you, Dr. David.
Thank you, Dr. David. Our next presentation by Dr. Pallavi Sharma.
A very good morning to all of you. Today I'm going to present a paper which is on the novel approach in implant osteodensification, which is an answer to the deficient alveolar bone to increasing the stability of dental implant. Starting with the introduction, dental implant have revolutionized the field of oral rehabilitation, as we all know. The goal of the implant placement is to achieve the primary stability, which is an essential factor for achieving the successful osseointegration. Maintaining the bone bulk and density during the implant site preparation is an essential for initial bone implant contact and the biomechanical stability. Now, osteodensification is a newer technique of preparation the implant bed to develop a condensed autograft surrounding the implant, which enhances the implant stability. This technique was first given by the Salha Huwais in year 2013. The main concept of this technique that the drilling design create an environment which enhance the initial primary stability through densification of osteotomy site wall by means of autografting of bone. Unlike the traditional bone drilling technology, osteodensification does not excavate the bone tissue. It is carried out by the special design burrs to increase the bone density as they can expand the osteotomy site. As you can see in this picture, this is the Densa burr kits, which includes the total 12 number of the burrs, and these burrs have a major diameter and minor diameter. I can see in this picture, and it has a marking which is started from 8 mm and up to the 20 mm. And these burrs have a negative rake angle and can be used with the 18,800 to the 1500 RPM. And these burrs can be moved in two directions, either clockwise direction or the anti-clockwise direction. If it is moved in the anti-clockwise, that is a counter-clockwise direction, it is in the densifying mode. That means densifying the bone, and it can be used as an autograft. It is in the non-cutting direction. And it is moved in the clockwise direction, it is in the cutting direction, which cuts the bone. And it is always used in the bouncing pumping motion. This pumping motion creates a rate dependent stress to produce a rate dependent strain and allow the saliva solution pumping gently and pressurize the bone wall, which increases the bone plasticity and expansion of the bone. Now coming up to the case report, a 20-year-old patient with the chief complaint of the missing upper two front teeth and wanted to get restored them. Medical history was non-contributory, and the dental history date back 8 years when the patient fell from the cycle and lost his front two teeth. Patient was on removable prosthesis for the past 7 years. Due to the aesthetic concern, patient wanted to replace the removable prosthesis with a fixed one. As you can see in this picture, this is the clinical representation showing the missing teeth, that is the 2-1 and 2-2, and this is the radiographic representation showing the missing teeth. And the ridge width was also less than 2.5 to 3 mm. Now the treatment option with their potential risk and benefits are presented to the patient. A final treatment plan was finalized to utilize the patient of 2 implant to receive the 2 abutment for the prefixed prosthesis to receive the teeth. Consent was given to the patient to utilize the osteodensification site preparation for ridge expansion with immediate implant placement and the possible addition bone grafting. Now, starting with the procedure, first of all, local anesthesia is given, and after that, the crestal incision is given, and after that, a full thickness flap is raised. After raising the flap, as you can see, there is initial pilot osteotomy was created. After that, this initial pilot osteotomy with the pilot drill rotated at 1200 RPM in the clockwise direction and up to the 12 mm of the depth. Once the implant position was confirmed, or horizontal ridge split to allow 10 mm depth was created for the further buccal plate flexibility. And osteotomy site was prepared with a denser burst. Now the placement of the implant in the 2-1 and 2-2 region, that tapered implant with the 3.4 mm diameter and the length is 10 mm, and another implant which is a 3.4 mm diameter and the length is 12 mm is used. After placing the implant, healing cover screw is used. After doing the osteodensification, there is a less than 1.1 mm of the buccal bone in this region. So we plan to place a alloplastic bone graft material. After placing the bone graft, as you can see in this picture, the bone graft is placed, and placing the bone graft, the GTR membrane is placed over the bone graft to stabilize the bone graft, and the flap is placed and it is sutured with the interrupted suture. This is the picture showing post-operative implant placement. After the 5 months, abutment is placed, and after that, final prosthesis is given, as you can see in this picture. Now, coming up to the discussion, this is given by the Meyer and Hughes et al. In 2014, when the densifying burr is rotated 800 to 1500 RPM in counterclockwise direction or non-cutting direction. Downward surgical pressure coupled with a steady external irrigation create a gentle pressure wave inside the osteotomy site that work with the team to generate a densifying layer through compaction and autografting the surrounding bone and expanding the bone ridge at the same time. Now, according to the Trisha et al. In 2016, he also stated that the osteodensification technique increases the bone volume around 30% around the implant as compared to the conventional implant. Now, also, the Salah Hughes in 2015 reported a case with ridge expansion in Siebert class 1 ridge deficiency with the osteodensification burr. Now, the Faleco et al. In 2016 also did in vivo study and also state that there is an increase in the bone volume around the implant by using the densification burrs. Now, coming up to the contraindications of this technique, that these burrs does not work with the cortical bone, as the cortical bone is a non-dynamic tissue which lack the plasticity. And also, the densification of xenograft should be avoided because they have a biomechanical different than the bone tissue, as they have only inorganic content and they just provide the bulk without any plasticity. So coming up to the conclusion, the patient demand for the shorter or the final treatment with the introduction of special design burr, which make possible not only to reduce the treatment time, but also give a successful implant outcome. Osteodensification is a promising concept which creates an autograft layer of the condensed bone at the periphery of the implant bed by using the denser burr, which enhancing the implant stability and the success. It is ideal for the patient with poor bone quality and providing a good primary stability. Thank you. Good evening, sir. Good evening, ma'am.
Good evening. Dr. Pallavi, actually, how you decide the size of implant for this case? Am I audible, Dr. Pallavi? Hello. Dr. Pallavi.
It's not audible. So can you repeat the question?
Now I am audible, Dr. Pallavi.
Yes, sir.
Yeah. How you decide the size of implant in your case?
Dr. Pallavi, sir is asking, how did you decide the size of implant in your case? Now is the question clear to you?
Most probably her internet is not working.
No, it's not clear. I think there's some signal issue from my side.
Are we audible to you?
Yeah.
Sir is asking, how did you decide the size of implant in your case?
Okay, we radiographically evaluated by taking the OPG.
OPG, how you decide the width of the implant?
The width, first we evaluate the width of the ridge with the help of the bone gauge.
Means during surgery, na? That is. From OPG, how we will decide the width of the ridge? Hello? Ma'am, Swati ma'am, am I audible?
Yes, sir, you are audible to me.
Most
Dr.
probably
Pallavi, sir is asking, how did you decide the width of the case? Bone gauge you use during surgery or before surgery?
Before the surgery.
Hello? Before the
Before
surgery?
The surgery.
Okay. You did not have done CBCT in this case?
No, sir. Actually, sir, I'm from the Sundarnagar. In that area, so there is no CBCT. For the CBCT, we have to send the patient in the Chandigarh. It's very far away from our college.
Okay. So basically, DEMSA bore what it does in the ridge during means drilling. Can you understand? Am I audible, Pallavi?
No, yes, sir. Now you are audible.
Okay. I just wanted to know what the DEMSA did during drilling.
During?
The ridge. Drilling.
So, denser bus, the main it is that it densifies the bone. Na? That bone can be used as a autograft.
Autograft.
Yes.
Means it expands the ridge. Okay.
Yes, it also expands the ridge when it is moving in the counterclockwise direction. It densifying the bone and it does not remove the bone like other conventional implant drills. It densifies the bone, which can be used as the autograft and also expand the bone.
Okay.
And which increase the width of the ridge.
So, what is the primary stability? Means what is the torque during insertion in your case?
So it's from 40 to 50 Newton centimeters.
40 to 50. So prosthesis when you give in this case?
Yes, sir.
Prosthesis when you gave in this case? Prosthesis, crown when you gave crown in this case?
Sorry, you're not audible.
Okay, there is some.
Sir is asking about the prosthesis, Dr. Pallavi. Sir is asking about the
50 Newton centimeters.
No, when you gave prosthesis in your case, prosthesis, crown, when you gave.
Yes, sir. Yes, sir.
When you gave the crown, sir is asking when you gave the prosthesis in the case.
Yes, ma'am.
Sir is asking when you gave the prosthesis in your case.
After 4 months.
Why not immediate loading, Pallavi?
Yes, sir.
Why not immediate loading? Because your torque is around 50.
Immediate loading. So actually, there is also buccal deficient buccal cortical plate. We also use bone graft there and membrane there. So for the region, so for that we can't give immediate prosthesis there.
So primary
So there
stability
is a
is 15 mm, 15 Newton per centimeter square, na? Primary stability in your case.
Yes, sir. So, but there is a deficient buccal cortical plate, no?
So from where it get primary stability your implant? Okay, ma'am, you ask me. It's Sati ma'am.
Yeah, yes. I just wanted to ask one thing. Have you done more bone mapping, Pallavi, Dr. Pallavi? Prior to implant placement, have you done the bone mapping in your case?
No, ma'am.
It should have been done. If you have not done the CBCT, it should have been done.
Okay, ma'am.
Okay.
Thank you, Dr. Pallavi Sharma. Now I am.
Thank you.
The next presentation by Dr. Amrut Ganesh.
Very good evening to one and all attending this presentation. I'm Dr. Amrut Ganesh, and my topic of presentation is Save the Bone to Save the Day. Coming to introduction, alveolar ridge preservation, also known as socket preservation, is described as procedure developed to eliminate or limit the negative effect of post-extraction resorption, maintain the soft and hard tissue contour of the ridge, promote bone formation within the socket, and facilitate implant placement in a prosthetically driven position. The objective of the treatment in the current case was to preserve the original contour of the bone by limiting normal post-extraction resorption using xenogenic bone graft substitutes and collagen membrane, followed by placement of implant and prosthetic rehabilitation. Success of every case largely depends on the case history, a proper diagnosis, and an appropriately laid out treatment plan. A 35-year-old male patient reported with the complaint of pain in the upper right back tooth region. Clinical and radiographical examination revealed dental caries involving pulp in relation to 1/6 and with hyperplastic pulpitis. An individual poor prognosis was obtained for endodontic management. A treatment plan of atraumatic extraction with rich preservation using xenogenic bone graft material and collagen membrane, followed by implant placement 4 months post-operatively and prosthetic rehabilitation 3 months after implant placement was suggested to the patient. In this slide, the clinical and radiographical presentation of grossly decayed 1/6 with the hyperplastic pulpitis is noted. Now, let's move on to the most important and interesting part of the case, the procedure. As step 1, atraumatic extraction of 1/6 was done using osteotome, periosteal elevator, and extraction forceps under local anesthesia using 2% lignocaine hydrochloride with adrenaline at 1:80,000 ratio. Care was taken to preserve the wall of the socket. Degranulation of the socket was carried out using bone curette. Socket was irrigated using sterile saline solution. A full thickness flap was reflected in such a way that adequate space was available for stabilization of the collagen membrane between the soft tissue and bony wall. Collagen membrane colloguide was placed on the buccal half prior to the placement of bone graft material in the socket. Xenogenic bone graft bio-os pen was used to fill the socket. Graft was placed incrementally from the base of the socket and compressed gently to ensure proper packing of the graft in the socket space without any voids. Collagen membrane was used as a barrier membrane, and the other half of the membrane was inserted towards the palatal flap to ensure a complete seal. 4 silk sutures was placed to stabilize the membrane, and antibiotics and analgesics were prescribed. Post-operative instructions were given, and oral hygiene instructions were reinforced. As part of post-operative follow-up, post-operative healing after 14 days was satisfactory. Oral hygiene instructions were reinforced, and 0.2% chlorhexidine gluconate was prescribed. 2 months post-operative healing was also satisfactory. As step 2, 4 months post-operatively, implant placement was planned and performed. A crestal incision was given from the distal aspect of 1/5 to mesial aspect of 1/7. A full thickness flap was elevated buccally and palatally, exposing the underlying bone crest. A noble biocare conical connection 4.3 to 11.5 mm implant was placed. During the implant placement, the viability of the bone was appreciated, and a 3/0 silk sutures was placed, approximating the buccal and palatal flaps using simple interrupted suturing technique. At step 3, 3 months post implant placement, stage 2 surgery was done for exposing the implant and placing the healing abutment. 2 weeks later, as step 4, prosthetic rehabilitation was done and cement retained porcelain fused metal crown was fabricated and placed. The case was followed up for a period of 5 months post prosthetic rehabilitation. Coming to discussion, the healing process of the alveolar bone after extraction is divided into two phases. Bundle bone is quickly resorbed and replaced by oven bone. The external surface of the alveolar bone is resorbed, causing horizontal contraction. Systematic review by Lang et al. Stated the dimensional changes of alveolar bone within 6 months after tooth extraction into two halves. The mean horizontal reduction in ridge width was found to be 3.8 mm, and the mean vertical reduction in ridge height was 1.24 mm. Post-extraction maintenance of the alveolar ridge minimizes the ridge resorption and facilitates subsequent implant placement, satisfying aesthetic and functional criteria. Implant placement after alveolar ridge preservation and immediate implant placement have been proven to be effective over the past several decades to resolve the problems occurring after tooth extraction. Xenografts have been shown to have excellent properties of GBR, like its biocompatibility, formation of scaffold, slow resorption rates, and ability to define and maintain the volume of the bone gain. Bio-Ospen was selected as the graft material due to their reproducible results with acceptable success rates and low rate of complication, besides providing lower morbidity for the patient. Barrier membranes have been shown to preserve alveolar ridges and provide beneficial results following tooth extraction in clinical trials. The artificial membrane could seal off the socket for a healing period of up to several weeks. Extraction sockets covered by porcine-derived collagen membrane alone showed significantly lower vertical and horizontal bone changes compared to spontaneous healing. In the current case, the treatment options suggested were atraumatic extraction with ridge preservation followed by delayed implant placement, and atraumatic extraction followed by immediate implant placement. In order to preserve the ridge contour and to prevent pneumatization, atraumatic extraction with ridge preservation followed by delayed implant placement was selected as the treatment of choice. Studies have suggested that the bone resorption in the immediate implant placement was more than the sites treated with ridge preservation. Coming to conclusion, the current case with 5-month follow-up demonstrates a successful bone formation at the site managed by ridge preservation technique using xenogenic bone graft materials and collagen membrane. The management of an unrestorable tooth by extraction and preservation of contour of the bone until implant was placed 4 months later proved that ridge preservation is a viable treatment option with a predictable outcome. Mucograft seal can be considered for obtaining a complete seal of the socket, while it does not require a flap elevation, unlike the GTR membranes. A flapless approach, when used, can reduce patient morbidity, and use of materials like mucograft seal may help in preserving the attached gingiva. Therefore, can be considered for a more predictable outcome, both functionally and aesthetically. There won't be a tomorrow if we are careless today. Let's make the change today together by being responsible and by following COVID guidelines. Stay safe. Thank you.
Good evening, sir. Good evening, ma'am.
Dr. Amrut, why you decided to do socket preservation in this case?
First of all, since it was a molar teeth, we wanted to make sure there was no pneumatization that occurs at the site. To prevent that, we did socket preservation and followed by implant placement.
What are the indications for socket preservation?
Socket preservation can be done if implant is to be planned for as future rehabilitation procedure, sir.
Why in this case you plan to place implant in future, not immediate?
So there are studies stating that immediate implants are not giving as successful results as compared to delayed implant placements following socket preservation. For example, Botticelli et al. In 2004 stated that immediate implant placement, more than immediate implant placement, the ridge preservation procedure followed by delayed implant placement gave better results. Sir.
You preserve the socket with xenograft.
Sir,
Which xenograft?
The xenogenic bone graft materials, the BioOS pen
What
was
is that?
used.
That is company name. What is that? Means it is mineralized graft, demineralized graft. Which type of graft you use? What is BioOS?
So BioOS is bovine derived bone graft materials.
Is it mineralized or demineralized?
Sir, demineralized.
Okay. So, what systematic review says about preserved socket with demineralized bone graft? What are the drawbacks?
Sir,
Yes, sir. Our next presentation is by Dr.
Amount of remnant graft. What is the amount of remnant graft in case of sockets preserved with xenografts?
So usually the resorption takes place around 4 to 6 weeks after placement of bone graft materials.
Resorption starts. Amount of remnant bone graft.
Sir.
After you did, you placed implant after 4 months, no?
Yes, sir.
After 4 months, yes, or 6 months, what is the amount of remnant bone graft in the preserved socket? You have gone through any systematic review?
Sir, no, sir. I'll go through systematic reviews.
Okay, find out that. Okay. And
Okay, Amrut, indeed it was a very nice case. But I just have a doubt, like, was the socket preserved in perio department or the extraction was done in oral surgery department?
Ma'am, it was done in perio department only.
So you didn't think of like the membrane was left exposed in the oral cavity. So being a periodontist, you could have displaced the flap coronally to cover that exposed membrane, because in cases where we do membrane, we always say the chances of secondary infection are increased.
Yes,
it's good that you were lucky enough that you didn't get it in your case.
Yes, ma'am.
Maybe the age of the patient is also not that that much. It was a 35-year-old patient, but since it was done in perio department, so you could have given a thought of coronally displacing the flap and covering the membrane at least, if at all you have used the membrane.
Yes.
And one more thing, the deciding factor for the width of implant, that too you were placing in a molar, that what would be the size of the implant? What have you done for that, for deciding the size of implant?
Ma'am, we did CBCT to decide the size of the implant.
Okay, you have done. Matlab, it was not mentioned in the presentation, so that's why.
Yes, ma'am. Due to some technical error, we couldn't retrieve the CBCT that was done, ma'am. But CBCT was done. CBCT was done prior to implant placement. That's how we decided the size of the implant.
Okay, so good. It was good presentation.
Thank you.
Good evening, one and all. Myself, Dr. Priyanka, and I'm here to present a paper titled Counterpoising the Physiology, a Case Report. Coming to introduction, removal of a failing tooth results in the creation of a deep open wound in the alveolar ridge, the extraction socket. This poorly protected wound may become contaminated further chemically or bacterially, resulting in a protracted, poorly controlled healing period. The subsequent loss of vital soft and hard tissues may result in a ridge deformity that is an impediment to reconstruction. Dimensional changes after tooth extraction often result in bone resorption that complicates restoration with implant or conventional processes. Following extraction, it would be of interest to arrest the bone resorptive process or at least minimize it. Several plastic surgical techniques were developed to reconstruct ridge defects using soft tissue grafts. Impressive results can be obtained, but the surgical procedure might need to be repeated several times to achieve optimal results. Alveolar ridge preservation immediately upon tooth extraction may reduce future need of extensive surgical intervention and increase treatment costs for both the treating dentist and the patient. Coming to the case report, a 36-year-old systemically healthy male patient reported with a chief complaint of fractured tooth in the right upper back tooth region. Clinical and radiographic examination revealed fractured root fragment in relation to upper right first premolar. A treatment plan of atraumatic extraction followed by socket preservation using xenogenic bone graft and PRF membrane followed by implant placement 3 months post-operatively was planned. Prosthetic rehabilitation was planned 3 months post-implant placement. On clinical and radiographic assessment of surgical site to check for any ridge defects was carried out. Atraumatic extraction was carried out to remove the root fragment in relation to 1/4 under local anesthesia using Moll's periosteal elevator. The fresh socket was debrided thoroughly of granulation tissue and residual periodontal ligament fibers, followed by a thorough evaluation of the remaining bony housing. Coming to PRF preparation, before tooth extraction, 5 ml blood was drawn from the patient's antecubital vein and centrifuged for 10 minutes. The obtained fibrin clot was separated from the RBCs and prepared into a membrane in the PRF box. A xenogenic bone substitute material, in this case BioOs, was placed in the socket carefully, except the most coronal 2 mm. The bone material was used to fill the socket as this would allow appropriate space for the membrane placement. The obtained PRF membrane was placed to secure the graft. A figure of 8 suture was placed to secure the graft and membrane in its position. 14 days post-operative clinical assessment revealed satisfactory healing. 6 months post-operative clinical evaluation revealed uneventful healing and no buccal or palatal defect. Radiographic assessment revealed sufficient bone fill for implant placement. Implant placement was carried out under LA. First, the crestal incision was given and full thickness flap was elevated, revealing viable bone. Noble Biocare conical connection 3.5 into 10 mm implant was placed with healing abutment and simple interrupted sutures were given to approximate the tissue. 10 days post-operative evaluation revealed uneventful healing. Prosthetic rehabilitation was done 3 months post-implant placement. Occlusion was established and radiographic assessment was carried out. Coming to discussion, the morphology of the alveolus is very much tooth dependent in that the development of alveolar bone is determined by the form of the teeth and the axis of tooth eruption. Therefore, it is not surprising that the alveolar process undergoes various degrees of atrophy when a tooth is removed in adulthood. There is disproportionate resorption of the buccal plate compared to the palatal or lingual plate of the ridge, with the buccal plate undergoing significantly more resorption. Substantial tissue loss leads to increased difficulty in placing the implant fixture in prosthodontically suitable position. To facilitate such placement, guided bone regeneration procedures are often required. Coming to the goals of socket preservation, the main goal is to maintain the original anatomy of the ridge. Socket preservation procedure reduces the possibility of residual ridge resorption near the extraction site. Dental implant placement becomes less difficult when the socket is well preserved. This way, maximum bone and soft tissue at the extraction site is retained. Materials available for socket grafting include autogenous bone or bone harvested from the same patient, allograft materials or bone harvested from the same species, that is other humans, xenografts which refer to bone harvested from other species, and alloplasts which are synthetic materials. BioOs, a deproteinized bovine bone mineral, has been successfully used in several studies to preserve ridge dimensions following tooth extraction, which is a xenogenic bone substitute that has been proven biocompatible and osteoconductive. Volume stability of the graft is an important factor for implant survival. BioOs demonstrated high volume maintenance and new bone formation. Socket preservation technique includes the use of bone or bone substitute grafts in conjunction with or without membranes. Another approach for socket preservation is mainly focused on the enhancement of the alveolar healing process by the use of biologic mediators. 3 types of platelet concentrates have been proposed for socket preservation, that is PRP, PRGF, and PRF. Advantages of platelet concentrates are decreases the frequency of intraoperative and postoperative bleeding at the recipient sites, aids in the initial stability of the grafted tissue at the recipient sites as a result of its cohesive and adhesive nature, may promote rapid vascularization of the healing tissue by delivering growth factors in combination with bone replacement materials, and it induces soft and hard tissue regeneration. Coming to the conclusion, socket grafting techniques in combination with implant placement leads to superior clinical outcomes in comparison to the placement of implants into non-grafted socket sites. Many socket grafting materials or techniques have been clinically shown to increase the alveolar ridge volume available at surgical implant placement. The present case demonstrated a successful outcome of ridge preservation using xenogenic bone graft material and PRF membrane during the implant placement, suggesting that socket preservation is a more predictable technique, maintaining ridge contour both functionally and aesthetically. Thank you.
Good evening, sir. Good evening, ma'am.
Good evening, Priyanka. Nice presentation.
Thank you.
So you used PRF in your in this case.
Yes,
Edge
sir.
what?
Yes.
Edge what?
Sir?
Edge what? Edge a barrier membrane?
No, yes, it was used as a membrane, sir.
Edge a barrier membrane.
Yes, as a married membrane.
What is the disintegration time of PRF?
So it usually, sir, average time is as 14 days, sir. 7 to 21 days.
Okay. You did primary closure of your wound?
So primary closure was achieved by placing the barrier membrane, and then on top of it, we have given a
No, in your case, you did primary closure or secondary?
So it was secondary closures. It was not primary.
So then PRF will disintegrate within 14 days.
Yes, sir. So, but the
So
tissue,
what about the wound?
So, but the tissue formation in any extraction socket is seen to be covered by within 14 days. So,
Within 14 days.
Yes, in almost 2 weeks, usually the tissue gets covered around in a extraction socket. So the use of PRF was, we judged it on based on that.
And what about collagen membrane? You think?
The collagen membrane, so one is the cost-effective nature. So because collagen membrane is kind of costly when compared to the PRF, sir, and that's why we opted for PRF and the easy availability of PRFs.
How many studies you have seen or systematic review that has described about PRF's barrier membrane nature? Have you seen any?
So there's a study by Zhao et al. In which Zhao et al. It's a systematic review, sir, in 2020. It was based on the socket preservation and the use of PRF membranes, sir. And they have found similar results with in comparison to the colloid membranes also.
Okay. They have used xenografts?
So yes, so xenograft, and so they have used alloplast also.
Alloplast.
Yes, sir. The study included all those studies in which alloplast as a xenograft was used.
In your case, why not you did immediate implant?
The immediate implant has shown in studies. Immediate implant has shown for buccal bone resorption in the later stages, sir. And so we preferred first the socket preservation and then going for a implant placement after the bone fill was completed.
Socket preservation, there is no buccal bone resorption.
Sir, the percentage is lesser, sir, as compared to, Sir Fisher et al. Has shown that as compared to immediate implant placement in which 75% of buccal bone resorption is there, there is only 35% of buccal bone resorption in cases of socket preservation.
That is a which study? Which type of study?
Sir, it was a study done in dogs, so not a human.
It is an animal study.
Yes, it was an animal study, not a human study.
Okay.
Yes.
Ma'am, Swati.
Dr. Priyanka, can you just tell me what was the length of the PRF membrane that you used? You told that you have taken 5 ml of blood, right?
Yes, ma'am.
So with
Yes,
5 ml of blood, what was the length of membrane you got?
Ma'am, length, I'm not sure, ma'am, because we had just made the PRF membrane in the box, ma'am, and we had cut it according to the socket size, ma'am. Almost.
So since it was a small socket, so it covered.
Yes, ma'am, it is at most covered.
According to me, like 5 ml of blood is quite.
Yes, ma'am, quite less for the
small amount
PRF.
for
Yes,
making membrane.
Yes, ma'am, because it was a premolar, ma'am, and a single rooted tooth, so it was fine, ma'am, for us.
Okay.
Thank you.
Thank you, Dr. Priyanka. Our next presentation by Dr. Arunab Gogoi.
Good morning, everyone. Today, I'm here to present my paper presentation on root coverage with subepithelial connective tissue graft using tunnel technique, and it is a case report. So coming to the introduction, periodontal plastic surgery, it deals with regenerative procedures designed to restore form, function, and enhance the aesthetics. Tunnel techniques, it has gained popularity over the years among the clinicians, and it is showing positive and promising results for better aesthetics as well as gaining or as well as treating gingival recession defects. So root coverage procedure, it comprises a number of surgical techniques which have been developed over the years on an empiric basis, that is on experimental basis, and various techniques have been used for gingival augmentation and for root coverage procedures that would include free gingival graft, subepithelial connective tissue graft, acellular dermal matrix, growth-like factors like enamel matrix proteins. Subepithelial connective tissue graft, it is considered as the gold standard, and it has shown the best predictability, around 95% of root coverage in Miller's class 1 and class 2 gingival recession. It was mentioned by Tolga et al. In the year 2006. Coming to the case history of the present case report. So a 35-year-old male patient, he reported to the Department of Periodontics, YG Institute of Dental Science, with a chief complaint of sensitivity in the upper left front teeth region since 3 to 4 months. The patient had no medical history. Then clinical examination, it revealed that the patient had class 1 gingival recession, Miller's class 1 gingival recession in relation to 2.2 and 2.3, and inadequate weight of the attached gingiva. When coming to the case management, incisions were placed and pouch and tunnel technique was used for this root coverage procedure. As you can see here, pouch and tunnel was created in relation to 2.2 and 2.3. Then root conditioning was done at the recipient site with tetracycline. Then connective tissue graft harvesting was done from the palate using trapdoor appearance, using the trapdoor technique. This is a diagram or a figure showing the trapdoor technique from where connective tissue graft was obtained. You can see here in the figure connective tissue graft that was obtained by using the trapdoor technique. Then it is the donor site where which was sutured. Then the connective tissue graft, it was placed inside the pouch and tunnel up to the CEJ level, that is in relation to 2.2 and 2.3. Sutures were placed to stabilize the graft inside the pouch and tunnel. And then periodontal dressings were placed so as to prevent the recipient site from any further damage. Then clinical outcome, 6 months post-op, we can see here in the picture that a significant amount of gingival augmentation has been obtained, as well as root coverage has been obtained in addition to 2.2 and 2.3. Coming to the discussion, the concerns of hypersensitivity, root caries, fear of tooth loss, and increasing interest in aesthetics, it has led to the development and modification of surgical procedures that not only enhance the width of attached gingiva, but also achieve maximum root coverage addressing these concerns. And the subepithelial connective tissue graft, it gives the advantage of excellent healing of the donor site as well as excellent color match of tissues. Then the tunnel technique, it was developed by Allen et al. In the year 1994 as a modification of the envelope technique, which was given by Langer and Langer et al. In the year 1985 to manage the multiple adjacent recession using a single surgical procedure. And this technique has resulted in consistently favorable results. So the use of pouch and tunnel technique, it preserves the interdental papilla, and this facilitates an early and accelerated wound healing. And the tunnel technique also applies less traction and preserves the gingival height. This has been mentioned by Zavelugi et al. In 1999. So this case report, we can see that superior results have been obtained by adopting the tunnel technique with autologous subepithelial connective tissue graft in the management of Miller's class 1 gingival recession. So to conclude, we can say that tunnel technique can be an effective procedure in management of gingival recession with multiple adjacent teeth having Miller's class 1 gingival recessions. Thank you.
Okay, Dr. Arnav.
Good evening, sir. Good evening, ma'am.
Good evening. So, why you decide to do tunnel and pause technique here?
So tunnel technique, it has the advantage of preserving the interdental papilla, thereby the vascular supply is maintained, and it has been shown to provide better results along with the subepithelial connective tissue graft. So I opted for this technique, sir.
What is the gold standard for gingival recession coverage? What is the gold standard technique?
Sir, normally it is normally it is using the subepithelial connective tissue graft, sir.
Thank you, Sunil sir, for taking out your precious time.
Which technique?
Sir, kindly send the evaluation sheet.
Sir, along with the envelope technique, sir.
Envelope or coronal advanced flap?
Coronal advanced flap, yes, sir.
So why
along with the use of subepithelial connective tissue graft.
You didn't do coronally advanced flap in this case?
So, there were recessions were observed for 2 teeth, sir. So, for multiple recession, I thought it would be a better option to do a tunnel technique by preserving the interdental papilla, sir, because it will maintain the vascular supply and thereby we can attain
multiple recession.
Multiple recession was there, sir. 2.2 and 2.3, sir, recession was there. Plus, it was a Miller's class 1 recession. So.
Miller class 1. Do you have any radiograph of your case? Do you have any radiograph
Sir,
of
no,
your
sir.
case? So,
Sir, no, sir.
There is no interdental bone loss, according to you?
So, interdental bone loss is not there, sir.
How you decide that?
So, if you observe the papilla, sir, from the contact point.
From soft tissue, you know what is there in underneath the soft tissue.
Sir, like if there is alveolar bone loss, like interdental bone loss, sir.
There is open contact
mostly we
also in your case. So most probably there is chance of bone loss. You have not.
Okay,
then
sir.
you have. You should include radiograph. Okay, in your case.
Okay, sir. Okay, sir. Okay, sir. Okay, sir.
Yeah, that was one of my question also, that why did you opt for connective tissue graft in this case, since it was just a Miller's class 1 recession?
Yes,
So why you have
ma'am,
opted
Miller's
for...
class 1 is. Ma'am, there were multiple teeth involved, and so, ma'am, Miller's
Only
class
2
1
teeth,
recession.
beta. Only 2 teeth.
2 teeth, ma'am. Yes, ma'am.
Yes.
So, ma'am, the partition tunnel technique, along with the subepithelial connective tissue graft, ma'am, it has been shown to show better.
Can use
better
any
results.
other biologic matrix, no? For class 1 recession, you can use any other biologic matrix like PRA.
So we can use. We can use, sir.
The biotype is what type of biotype in your case is there?
What type of biotype you had in your case?
Ma'am, it near the gingival margin, it was thin biotype, ma'am. Comparatively.
It don't look like that.
See, one thing I want to say, have you gone through the literature? You are which year, PG?
Second year, PG.
So have you gone through the literature, like long-term results, if you are using any kind of barrier membrane, or you are using connective tissue graft, or you are using PRF? Whatever you are using in case of recession, there is no stable biotype increase. For 1 year or 2 year, you can get a little bit increase in the biotype. But if you see long-term follow-up of such cases, the biotype goes back to the normal only. There is no significant, there remains no significant difference between normal root coverage procedure and if you have done root coverage with some types of membrane. So if it was a class 1 recession only, so I think you should have not gone for such invasive surgery, harvesting the connective tissue graft. You could have done PRF also in this case. That would have been less invasive. And second thing, you have done conditioning, root conditioning you have done. It was pouch and tunnel. What you used for root conditioning? What was the agent you used for root conditioning?
Ma'am, tetracycline was used, ma'am.
So actually, ideally, any kind of root conditioning agent, it should not touch the gingiva. The photograph you have shown is totally on the gingiva. The root cancer, आपने देखा?
Yes, ma'am.
Have you
Partially it
noticed
was
it?
on the gingiva.
It was totally
Yes, ma'am.
on the
Yes, ma'am.
gingiva.
Partially, it
So
was in the gingiva.
it could have caused necrosis or sloughing of the tissue
Yes, ma'am.
on
Yes,
that.
ma'am.
And it was a pouch and tunnel technique, no? If it
Yes, ma'am.
was
Yes, ma'am.
if it was a full flap raise, then it was okay. But very much care should be taken of if you are using in such type of techniques.
Yes, ma'am. Yes, ma'am.
Plastic surgeries are very delicate surgeries.
Yes,
So
ma'am.
in
Yes, ma'am.
that you have to be delicate and handle the tissue very gently.
Yes, ma'am. Yes, ma'am.
Aruna, what is Vista technique?
So,
Vista technique.
vestibular incision, subepithelial tunnel axis, sir.
So, can we do that technique in your case?
So, like, it is one of the, so we can proceed with that, sir.
It is also a minimally invasive technique.
Minimally invasive technique, yes, sir.
Thank you, Dr. Aruna. Let's
Thank you.
move on to our next presentation by Dr. Basarat Ahmad and Dr. Bisma Aijazdak and Dr. Busra Iftikhar.
पहले हमें चलाना पड़ेगा रमैया श्री लक्ष्मी का वीडियो आएगा पहले, बसरत जी का बाद में आएगा.
Okay, no. Yes.
This is Dr. Ramya. Today I am here to present a case report on periodontal regeneration of advanced bone defect in aesthetic zone, the 6 months follow-up case. To introduce, the major goal of periodontal therapy continues to be the regeneration of attachment structure of teeth, including bone, periodontal ligament, and cementum, destroyed by the periodontal disease or trauma. Periodontal regeneration can be achieved by a variety of surgical procedures, including bone grafts, bone substitutes, guided tissue regeneration, or a combination of this. Bone substitutes like hydroxyapatite have been used in treating the defects associated with periodontal disease. But the main shortcoming of bone substitutes is lack of its osteogenic property and osteoinductive nature. This can be overcome by adding placental membranes which act as mitogenic and chemotactic agents, thus bringing the rapid regeneration. This case report presents a successful intervention outcome of a challenging case in the aesthetic zone of a patient with advanced bone defect in relation to 1112 using hydroxyapatite bone graft and chorion membrane. Moving on to the clinical presentation, it is a 29-year-old systemically healthy male patient reported to the Department of Periodontics with chief complaint of bleeding gums and mobility of upper central incisors since 3 months. History of present illness gives bleeding from gums during brushing and during biting hard food since 3 months. It is also associated with pain which was intermittent, dull, throbbing type and is not radiating to surrounding structures. Patient also gives history of bad breath since a month and also history of gradual loosening of the teeth in maxillary anterior region. There is no relevant medical and family history and it is the patient's first dental visit. Moving on to the intraoral examination. There is erythematous and edematous marginal gingiva in relation to 1112 and 21 and edematous interdental papilla is seen in relation to 11 and 12 and also periodontal pocket depth of 15 mm in relation to 11, 14 mm in relation to 12 and 5 mm in relation to 31 and 41 are seen. Moreover, grade 1 mobility in relation to 11 and 21 and also trauma from occlusion in relation to 11, 12, 21, 31 and 41 are elucidated. Moving on to the radiological findings, radiograph shows the intrabony defect in relation to 11 and 12 in both intraoral periapical radiograph and also in OPG. Based on these findings, patient is diagnosed as chronic generalized gingivitis with localized aggressive periodontitis in relation to 11 and 12. Moving on to the treatment plan. Firstly, pre-surgical therapy. Initially, full mouth scaling and root planing was done and trauma from occlusion is relieved with tapered fissure bar in relation to 1112 and 3141. Patient is recalled after 3 weeks for surgical therapy and for evaluation. Moving on to the surgical therapy. Firstly, using after administration of adequate local anesthesia, using a 15C blade, intraclavicular incisions are given in relation to 11 and 12. Later, a full thickness mucoperiosteal flap is then elevated using a periosteal elevator and then
The inner surface of flap was carefully curated to remove the granulation tissue. Complete defect debridement was done, and then the surgical area was rinsed with copious amount of sterile saline, and the defect at this point was classified as two-wall intrabony defect, as the mesial wall and palatal wall are present. The depth of the defect is then measured, and chorion membrane is being prepared based on these dimensions and kept aside. Now, the hydroxyapatite particles are incorporated tightly into the defect, and the prepared chorion membrane is placed on this G-graft. After the placement of biomaterial, the flap was sutured using single interrupted 5-0 sutures, and the patient was instructed to rinse the mouth with 0.2% chlorhexidine mouthwash twice daily till 15 days, and antibiotics and NSAIDs were given to the patient and are prescribed to use till the next 5 days. Periodontal dressing was placed, and the sutures were removed after 3 weeks. These are the post-operative pictures of the patient post-operatively after 1 month and 6 months post-operative. Moving on to the results, a significant difference was noted in the pocket depth and attachment level values at baseline and 6 months after treatment in relation to the right maxillary central incisor. The pocket depth mesially was 11 mm, distally 14 mm, and labially it is 15 mm at baseline. And after 6 months, it is 4 mm mesially, 5 mm distally and facially. And similarly, the clinical attachment levels were. This is the comparative picture of preoperative and 6 months postoperative clinically and radiographically. Here 15 mm pocket depth is seen, and here 5 mm pocket depth. And also radiolucency is appreciated in the preoperative picture and radiopacity in the postoperative picture, indicating the healing. Moving on to the discussion, regeneration in the deep intrabony defects remains a delicate procedure due to slow and difficult integration of the grafted material into the physiological architecture. The recent use of placental membranes together with bone grafts aims to improve the process of integration by accelerating the bone and mucosal healing. Chorion membrane in the present case supported the particulate graft and acted as a barrier membrane between the gingival epithelium and the hard tissue to promote the periodontal ligament, to form the progenitor cells that can regenerate new tissues. Chorion membrane constitutes of a reticular layer, basement membrane, and trophoblast cells. It has been used in regenerative techniques because of its ability to enhance wound healing, serve as a scaffold for cell proliferation and differentiation, reduce scarring and inflammation. An additional advantage of guided tissue regeneration procedure using bioresorbable chorion membrane is, in this technique, there is no requirement of using a second surgical procedure to retrieve the membrane. Hence, chorion membrane served a dual purpose for regeneration and supporting the G-graft at the surgical site. The membrane placed quickly became pliable as it was hydrated with blood and closely adapted to the contours of the underlying surface. The chorion membrane in the present case need not to be fixed while placing the sutures or by placing the tags, as chorion membrane does not shrivel and remains undisplaced in relation to the overlying flap. The present study has similar findings reported to the Rastogi P. et al. Study, in which deep intrabony periodontal defects at maxillary anteriors were done using hydroxyapatite particles with platelet-rich fibrin membrane. This study concluded that rapid regeneration of the periodontium can be achieved with bone substitutes by incorporating various growth factors. And a similar study done by Kotivale et al. In 2013 on evaluation of chorion membrane in GTR concluded that GTR using bioabsorbable membranes in pocket therapy demonstrated greater bone gain and good tissue integrity in clinical and radiographic evaluations than pocket therapy alone. And Kotivale et al. In 2018 conducted another study in deep intrabony defects associated with maxillary central incisors using corticocancellous block allograft and chorion membrane concluded that chorion membrane's unique biologic and physical attribute leads to rapid wound healing and successful treatment outcome with good prognosis. Hereby, I conclude that teeth with severely compromised periodontium of unpredictable prognosis can still be maintained with proper selection of an advanced periodontal treatment plan. Within the limits, the case report has been shown that the use of chorion membrane resulted in significant pocket depth reduction and clinical attachment level gain in much lesser time. The ease of applying chorion and its beneficial outcomes include rapid healing and periodontal regeneration holds promise for the future. Thank you.
Swati ma'am, start.
Good evening, sir. So, was good, but can you tell me with what chorion membrane you used? You used the prefabricated membrane or you prepared the membrane? Can you just elaborate the procedure?
I use the prefabricated membrane, ma'am.
Okay. So prefabricated membrane you got from?
I got from Tata Memorial Institute.
Okay, Tata Memorial. Can you tell me the difference between chorionic membrane and amniotic membrane?
Yes, ma'am. Amniotic membrane is more thin and fragile, ma'am, when compared to chorion membrane.
Sorry, you are not clear. Can you be a bit louder?
Yes, ma'am. Amniotic membrane is thin and fragile, ma'am, when compared to the chorion membrane.
Okay. Any other difference? Like why you prefer to use chorion membrane?
Basically, chorion membrane is easily available, ma'am, compared to the amnion membrane. We also did some studies using the amnion membrane.
And one more thing. So you mentioned that it was a case of localized aggressive periodontitis, right?
Ma'am, patient actually had anterior deep bite, ma'am. So because
Yes.
of that etiological factor, there is aggressive nature, ma'am, in the anterior deep.
No. I am telling that you told that it was a case of localized aggressive periodontitis.
Yes.
In relation to 1112, 2122, and 3141.
No, ma'am, in relation to 11 and 12, it is aggressive periodontitis.
Okay. Have you recorded the pocket depth of full mouth pocket depth? Have you recorded?
Yes, ma'am. I recorded full mouth pocket depth, ma'am, but there are only findings in relation to the anterior teeth, ma'am.
Okay. So over to you, sir.
Yes, ma'am. Okay, Dr. Ramaya, why did you did coronoplasty in this case?
Sir, there is trauma from occlusion, sir. So to relieve it, I performed the.
So you are doing that in aesthetic zone, na?
Yes.
Is it better to do ortho or do coronoplasty?
The patient is not willing for orthodontic, so for temporary relief.
And what about the vitality of 1-1?
Yes, sir, it is vital teacher. So I didn't go for.
You have checked vitality?
Yes, sir.
How you checked vitality?
By using pulse vitality tester, by using the.
Sorry, not audible. Hello.
Hello, sir. Am I audible to you?
Yeah.
Yes, sir. By pulse vitality tester, by using the liquid nitrogen.
So, what do you think about doing endo before doing regeneration in this case?
Yes, sir. We went for endo opinion, sir. The teeth is vital, so you can go with periodontal.
And the lesion looks like most probably it is endoperioral lesion.
No, so we suspected of endoperioral lesion, sir, but there is no problem with endo.
And you got chorionic membrane from Tata Memorial, okay?
Yes,
and to prevent the antigenicity of the membrane, what you have done?
Sir, it is the demineralized membrane, sir, what I got. Sir.
For antigenicity. It is what type of graft?
It is allograft.
Got it. Okay. You find out. Okay.
I want to add on one thing, that you should keep the patient on regular recall, because the chances of the tooth getting non-vital are very likely in this case, since it was a very vast bone defect. So you should keep her on regular follow-up.
Okay.
Thank you, Dr. Ramya Sri. Let's move on to our next presentation by Dr. Basarat Ahmad, Dr. Bisma Ijaztak, and Dr. Busra Iftikhar.
Will the screen be of this size only? Like it would be difficult to see it in such a small screen. Yes, now it's okay. It's fine now.
You can continue.
Ma'am, actually we are running late by 1
Nothing is audible. Anyone from the technical team?
Subhida, are you there? Dr. Subhida?
Dr. Busra sharing PPT herself.
तो सर पहले हमरो रखी दियो तो मुझे ये फोन पर करेगा ना मोर नेट लगी से सोल्व कर रही Dr. Basrat, are you there? Dr. Basrat, Dr. Vishma.
Yes.
One of you can present the slides. Okay. Your internet is not. Hello. Anyone of you can present the slide. Anyone of you can. Because
And I
no
think
audio
you
is there.
should turn on your video also. We cannot see anyone of the presenter.
Yes, sir.
Dr. Basrat, Dr. Vishma, Dr. Busra, anyone
Yes, sir. Yes, sir.
can switch on your video.
Yes, sir. Yes, sir.
Okay. Now present your paper.
Yes, sir. I'm present. Sir, this case is about addressing the periodontal orphan. So the periodontal orphan management of horizontal bone loss with chorion membrane. So can you hear me?
You are not audible. You are not audible. I think you are out somewhere.
Ma'am, 5 minutes we will provide you the video. Yes, sir. So can you hear me?
Yeah, we can hear you. You start presenting.
I'm actually from the Government Dental College, GDC Srinagar. I'm presenting a case of addressing
Not audible. Not
management
audible.
of horizontal bone loss within chorion membrane.
Hello. It's not audible, Dr. Basrat.
I think
Sir,
she
is
is
this
out
audible?
somewhere,
Hello,
sir.
sir?
I think she is somewhere outside.
Yes.
Yeah, actually, I'm traveling.
So anyone else? No, you are 3 presenters. Anyone else can present?
Ma'am, actually, our presentation was not there in that panel, so I have sent them right now. They have got it. If they can play.
You are not at all audible, dear. Not at all audible.
Ma'am, Busra sent me the video. Please wait till 2 minutes. I play.
Okay.
Good evening, everybody. I, Dr. Bismay Jaztak, PG third year, along with my co-authors, Dr. Bushra Iftikhar and Dr. Basharat Ahmad Mir from Government Dental College, Srinagar, I'm going to present my case report on addressing the periodontal orphan, management of horizontal bone loss using chorion membrane. Horizontal bone loss, the most encountered situation by periodontists, results in tooth loss, has paid scant attention. Thus, attempts to regenerate it has been elusive, with a number of investigated materials and techniques like root biomodification, guided tissue regeneration, guided bone regeneration using resorbable and non-resorbable membranes. Among the techniques is bone swaging, demonstrated by Ivan, is a technique in which the bone is advanced without fracturing its base to regenerate the lost alveolar bone. Also, this technique retains its osteogenic properties because of the pedicle nature of the graft, which offers it potential advantage over supracrestally placed non-vital bone grafts. Chorion membrane, which is a placental-derived resorbable membrane, can be used to cover the advanced bone segment along with the graft materials due to its additional biologic properties of increased growth factor release, and also it has the ability to induce migration of mesenchymal stem cells. Thus, this case report presents the combined use of bone swaging along with chorion membrane and allogenic bone graft in the aesthetic region to regenerate the lost alveolar bone. This case report presents a 35-year-old female patient who present with her chief complaint of space between upper front tooth region. On clinical examination, a probing depth of 6 mm was found with no bleeding on probing, no mobility. With the restoration done 1 year back, for the conservative closure of the midline diastema. A preoperative intraoral periapical radiograph was advised, and a horizontal bone loss between 1-1 and 2-1 was found, as it can be appreciated from the preoperative intraoral periapical radiograph. These are the intraoperative pictures of the patient. The first picture shows the modified papilla preservation flap was raised, and the bone segment between the tooth number 1-1 and 2-1 was swatched coronally. And the graft was placed covered, which usually was the demineralized bone matrix with allogenic bone graft with a high number of bone morphogenic proteins, and this graft material was covered by chorion membrane. And sutures were placed, followed by periodontal dressing, and intraoral periapical radiograph was taken intraoperatively to confirm the new position of the advanced bone segment. These are the post-operative pictures of the same patient. Through this technique, patient should increase radiographic height of alveolar bone, as can be appreciated from the intraoral periapical radiograph taken 1 month after procedure, and also it showed the reduced probing depth of up to 3 mm. Thus, this combination technique demonstrated to be a potential option in the management of otherwise periodontal orphan horizontal bone loss. As the regeneration can be appreciated in the post-operative radiograph taken 1 month from the preoperative radiograph. Thus, this technique helps to regenerate the lost alveolar bone, thus can be used in future most often along with this chorion membrane. Thank you.
Shiv Shankar sir, you are muted, sir. Please unmute, sir.
Dr. Bhishma, am I
Yes, sir.
audible?
Yes, sir. Good evening, sir.
Good evening. So, what is the interradicular distance between 1-1 and 2-1 in your case?
Sir, intraradicular distance was more than 2 mm.
More than 2 mm, it is 10 mm, 5 mm, 6 mm, around what?
Yes, sir. It was more than like 6-7 mm because the patient had undergone heavy restoration 1 year back. So it also contributed to the bone loss for 1 year.
Why did you think to continue with that restoration, not to remove the restoration and do ortho after that regeneration?
Yes, sir. We removed it intraoperatively. Before procedure, we removed it, and for first we went for phase 1 therapy, and we prepared patient so that the soft tissue healed accordingly. Then after that, we went for surgical treatment.
No, why didn't you do ortho before doing regeneration? My question is that. Because there is large interradicular width is there in your case.
Yes, sir. The patient was 35-year-old female and was reluctant for the orthodontic treatment.
Then if patient is reluctant, you have to motivate the patient. And
yes, sir,
how did you standardize your radiograph? To measure because
yes,
you have to measure the bone formation. How did you standardize?
Yes, sir. Actually, at least only 1 month follow-up period.
No. How did you standardize your radiographs?
Sir, actually, I took it through paralleling technique.
It's not looks like actually.
Radiographs are shortened also. It seems that
So
radiographs are shortened, broadened.
Not standardized, ma'am. Yeah.
So actually, I'm trying my level best to take radiographs along with grid. So it was not available intraoperatively, actually due to lockdown reasons.
Okay.
Actually,
Which graft did you use? Which graft did you
So
use?
demineralized bone matrix graft.
Okay.
So
Above that,
osteograft, unstadium osteograft.
above that, what you used? Above osteograft, what you have used? Above osteograft,
So
which barrier membrane?
which barrier membrane? Corion membrane I use.
Corion membrane. Why?
Yes.
Why not
So
any
it
other
is,
membrane?
So as its novel membrane, it has advanced features like it has inherent growth factors in increased biological properties like anti-inflammatory, antibacterial, and it also gets incorporated into the tissue well, so it helps in healing also. Besides bone formation.
Do you know about past principle?
It's
PASS.
given by Wang and it's given by Wang et al. So
Okay,
it,
no.
it's a
What is that? What is that? What is PASS?
Yes, so it's primary wound closure, angiogenesis, stability, and scaffold and stability of actually given for the implants, primary stability, which we need.
For scaffold, you have provided the bone graft. Okay. For
Yes,
stability, what you have
and
done in this case?
so for stability,
Can chorionic
so
membrane
for
provide stability?
So for stability of the advanced fragment, I have actually placed the bone graft.
No,
So
bone
that
graft
it
is for
skip back.
scaffold. Okay, bone graft is for scaffold. For stability.
Yes, sir. So it also provided stability of the fragment. Also, it was
You are doing
connected with its
horizontal
pedicle.
augmentation, no? You are doing horizontal augmentation. So how bone graft will provide stability?
So it was filled in the gap which was produced by bone swaging.
Which gap? Which gap will provide stability to the graft?
So actually, when we advance the bone, the gap which was created there, we filled it with bone graft, and plus we placed over it chorion membrane.
Okay, what is cortical puncturing?
So it's actually intentional holes which we prepare in the cortical plate.
So you didn't done in your case also? You have
No,
did?
so I didn't do it. So, but the bone which we advanced, it was viable. It was pedicled.
Means you have also advanced the bone, viable bone.
Yes,
the interdental
yes,
bone
sir,
you
in
have
vertical
advanced.
direction.
Okay.
Yes,
And
sir. Yes,
then
sir.
how it is stabilized? You stabilize that advanced bone.
So we the apical portion of that pedicled graft we filled it with bone graft and then covered with membrane.
Okay. Ma'am, Satina.
Bismarck, can you tell me what is the gold standard for horizontal bone augmentation?
Ma'am, there are a number of techniques which can be.
I'm asking the gold standard. I don't want to ask the techniques. I am asking just the gold standard for horizontal bone augmentation.
Ma'am, guided bone regeneration.
No, with what membrane? Like you have used chorionic membrane, it will not provide stability. As sir was saying, it will not at all provide stability. What will provide you stability for horizontally augmenting the bone?
Ma'am, we can put bone pin, bone tag for providing stability of the advanced fragment.
And one more thing, which year you are in?
Ma'am, just in third year.
You are PG third year. Can you elaborate the parts of case presentation, please?
Ma'am, introduction, aims and objectives, materials, methods, discussion and conclusion.
Where was your discussion and conclusion? These are
the
not,
parts of
first
case
of all, these are
presentation.
not the part of case presentation. And secondly, what about the discussion of your case and conclusion of your case? It's a presentation not of the department. It's a presentation of ISP, you know.
Okay, ma'am.
So it was like you have done case presentation. I don't know how, but you should be serious enough for this. You are wasting time of yourself also and ours also. Being PG third year, I cannot imagine a presentation by a exam going PG like this.
Ma'am, we are not exam going in third
You
year.
are PG third year. You told me PG third year, no?
Ma'am, just 1 month in third year.
Okay, if it is 1 month into third year also, then also you should know how exactly the case presentation should be.
Okay, ma'am.
Thank you, doctor.
Thank you, Dr. Bisma. With this, we end our session. Thank you, Dr. Sivasankar Pradhan sir and Dr. Swati Agrawal ma'am for taking out your valuable time and being a part of this first virtual PG convention. And one gentle reminder, ma'am and sir, to send the evaluation sheet on Subhash Chandra sir's number.
Thank you, Swayam Prabha.
Thank you, Shiv Shankar sir. It was nice being with you, sir.
Thank you, ma'am. And ma'am, we will meet also. Okay, ma'am.
Yes, sir. Yes, yes,
Okay,
yes, sir.
okay. Thank you.
Thank you, sir. Thank you, team.
Thank you, ma'am. Thank you.